Good morning, everyone. Today we are in the day 3 of BGCI 2022 conference, which is the 7th annual conference of genetic counselor. After 2 days of brainstorming sessions, we are entering the day 3. I, Dr. Pushpa NB, Assistant Professor in the Department of Anatomy, welcomes you all to day 3. So today we have sessions on ophthalmology. So this There are more than 350 hereditary eye diseases such as albinism, aniridia, color blindness, corneal dystrophies, glaucoma, keratoconus, Leber congenital amaurosis, night blindness, retinosis pigmentosa, retinoblastoma, or a few to just name. So for this, again, we are going to have enlightening sessions on these diseases. For these sessions, we have our chairpersons. Firstly, I like to introduce Miss Ria Ratna. Ria Ratna did her BSc Genetics from University Liverpool, UK. She did her MSc Human Molecular Genetics from Imperial College London. And currently, she is Level 2 Genetic Counselor, Ophthalmic Genetic Counselor at Dr. Shroff's Charity Eye Hospital, New Delhi. Her area of interest or pediatric ocular genetic disorders. Welcome you, ma'am. Uh, The next person for today's session is Dr. N. Indumati. Dr. Indumati did her UG and then PG in a diploma in counseling psychology, advanced PG diploma in genetic counseling, and then she did her PhD genetics from the University of Madras. She has 12 years of experience in genetic diagnosis and counseling. She is a level 2 BGCI certified genetic counselor. She holds for her academic credentials. She has scored third rank in the UG in the PG, and she is a college topper in the UG degree. She has 7 publications in national and international journals, and we welcome you, ma'am, to our sessions today. So, with this, I hand over to the podium to the Miss Ria Ratna.
Hello, everyone. Good morning. Dr. Indumati and I will be moderating the ophthalmology session today. And I am going to introduce Dr. Professor Govindswamy Kumar Manikaval, who is our chairperson today. And it's an absolute privilege to introduce him. He's the Director of Research at Narayan Netralaya in Bangalore and the Director of Research at Aditya Jyot Eye Hospital in Mumbai. His academics, I would like to mention, he's done his MD in physiology. He was a Fogati visiting associate, training under Dr. James Fielding Hedgemanic in the ophthalmic genetics and clinical services branch at NEI NIH in the USA. He was also a research fellow for Ocular Gene Mapping Laboratory in University of Otago, New Zealand, trained under Dr. Michael John Denton. His interests lie in ocular genomics, primarily involved in gene mapping, mutational screening, and genome-wide association studies in complex and Mendelian ophthalmic diseases. His career highlights include receiving funding from research projects from NIH, USA, France, and Indian grant agencies like DBT. And he now has over 130 peer-reviewed publications, including articles in international publications like Nature Genetics. We welcome you, sir. Please join us on the podium. So today we have a lot of talks lined up in inherited retinal diseases and retinoblastoma. We would be talking a lot about genetic counseling in ophthalmology, and a very interesting panel discussion towards the end, where we'll be talking about conundrums in genetic counseling in ophthalmology and decisions regarding termination of pregnancies in ophthalmic genetic cases. And I now hand over the stage to Dr. Kumar Manikaval to introduce our first speaker and kickstart the day.
Good morning, everyone. A happy Sunday for all in the audience, as well as those online. And thank you for joining on a Sunday morning. So we have a very interesting session. And we have faculties from United States of America till Australia, quite a variety of genetic research scientists as well as counselors. So let us start the program with the first speaker, Dr. Manju Bhate. And she is an MBBS and MD, and she's currently the Associate Ophthalmologist, Pediatric Ophthalmology, Ocular Genetics, Tradesmis, and Neuro-Ophthalmology Division. She's affiliated to the LV Prasad Eye Institute, Hyderabad. She's done fellowship in Children's Hospital, Westmed, Sydney, Australia, and then as a consultant in pediatric ophthalmology, John Hunter Children's Hospital, Sydney, again in Australia, till 2019 before she joined Eli Prasad. Her interests are pediatric cataract, complex strabismus, and ocular genetics, besides pediatric neuro-ophthalmology, retinopathy of prematurity. Her career highlights, she has presented widely in national and international meetings, and she's got a national level award on strabismus and neuro-ophthalmology conferences in 2016 and 21. She has published over 12 first author original articles in genetics and strabismus. Dr. Bhate.
Good day, everyone. I'm Dr. Manju Bhate. I'm a faculty in ocular genetics and pediatric ophthalmology at LV Prasad Eye Institute, Hyderabad. And at the outset, I'd like to thank the BGCI for the invite to deliver this lecture. In the next few minutes, I'll be taking you through some of the interesting ophthalmic cases and the related genetics. As you're aware, genetic testing has become the benchmark for the diagnosis and management of most patients with congenital and hereditary conditions. And genetic counseling is really important because it bridges this, it's like a bridge between the phenotypic and genotypic confirmation for a patient, and also advises the families with regards to the genetic testing and the overall prognosis. We in ocular genetics deal with a lot of inherited and familial conditions and the phenotypic genotypic correlations in these. So let's move on straight to the families. So this is family one, where we can see two siblings here, the oldest son and the younger daughter, and they were referred from the pediatrician for to assess their ocular features because they had some systemic features as which we'll go through later. So as you can see in this photo over here, you can see that the eyelids are set at a slightly lower level. There is some amount of ptosis. There's some amount of opacification in the peripheral cornea as well. So if we look at the high magnification photograph here, we can see that the pupil is slightly distorted. It's not central, it's not round. So this is called correctopia. The top photos of the older sibling, the bottom ones of the younger. And there's also this peripheral opacification. This is called as a Schwalbe's line. And these features of a prominent Schwalbe's line with iris abnormality is suggestive of Axenfeld-Rieger anomaly. So here, if this is an autosomal dominant condition, we see corneal and iris features and also some systemic abnormalities like dental and facial or umbilical abnormalities. These children went on to have genetic testing, and they had a microdeletion in chromosome 6. It was suggestive of Axenfeld-Rieger syndrome, and the father also had similar features of correctopia, and it's like a spectrum, so it can vary as to what ocular and systemic features may be present. So let's come to family 2. So family 2, as you can see over here in this photo, these are two siblings. They are extremely thin and tall. They have long arms, they have long legs, and they do have some sort of a skeletal abnormality as well. Here we can see that they have these long fingers. They have a positive thumb sign. So I think I'm giving clues to what I'm trying to say. And if we come to the ocular features, the ocular features where we can see the crystalline lens. This is subluxated. It's not in its normal position. So the top photos are of the older sibling and the bottom two of the younger, where the subluxation is even more extreme. And this is seen in cases of Marfan syndrome, and it is called as ectopia lentis. And so we have these Marfanoid features of tall, thin children with a positive thumb sign and a wrist sign, and the features of ectopia lentis in the eye. They also can have cardiac abnormalities and aortic root dilatation. So it's really important to get a thorough systemic evaluation. And in these children, the genetic testing was positive for a fibrillin gene. So they had the FBN1 gene positive, which was suggestive of Marfan's. So now we move on to another ocular condition, which is fairly common. And the little child on the right is a child who has an oculocutaneous albinism, where the skin as well as the eyes are affected. Whereas the boy on the left, his hair, his cutaneous features are not really evident. His skin is not affected, but he has very light eyes, and he has features of ocular albinism in his eyes. So if we look at the phenotypic features of oculocutaneous albinism in the eyes, we can see that they have reduced vision. Then they also have this shaking of the eyes called as nystagmus. This is the retinal image on both these sides. We can see that it's grossly hypopigmented, or it's also called as a blonde fundus with some foveal hypoplasia that is evident on OCT scanning. The lens also shows features of this lens outline, which is visible. It's called as iris transillumination. So all these are the major diagnostic clinical criteria for oculocutaneous albinism in the eye. Similarly, in this boy, he also had a head tilt, but this head tilt was because of a short sternocleidomastoid. It was not the eyes that was driving the head tilt, and he had a younger sibling as well. As we can see over here in this photo, this younger sibling. So both of them were affected, and this is an autosomal recessive condition. And because we see so many of these siblings, we actually we did a study to look at all these siblings who come with oculocutaneous albinism, and we noted that there was a wide variation in their phenotypic features. So this is something which is really important when we counsel families, because when they're expecting another child, they sometimes feel that the child may or may not be affected similarly. And this spectrum can have such a lot of variety that it's important and imperative to counsel accordingly. Next, we come to this another interesting little child. So here we can see this is a child who presented with cutis laxa or T-Parsi syndrome. So we can see a lot of facial features over here. So he has facial dysmorphism, triangular faces, and this typical old man look, a lot of wrinkled skin, a pinched nose, and what is evident in the eyes, you can see opacification over here of the corneas. So there is a corneal opacity there, which was really what drove the child, and of course the pediatrician who referred the child to us for ocular management. And this child then later on went on to have a penetrating keratoplasty to be able to get some sort of vision. So this is in both the eyes. He's got clear corneas after the surgery now. But looking at the systemic features, he also has congenital dislocation of the hip. So he also has to wear this kind of a brace to help with him sit and walk. So the other features, so here we see the pedigree chart with the affected child. And because of the skin features, some of the differentials that we need to consider is Ehlers-Danlos or Pseudoxanthoma elasticum. They have a lot of loose skin. Our patient fitted into the autosomal recessive. We are still awaiting genetic testing at this point. It'll probably be out before the conference actually happens, so I may be able to update you at that time. So this is the autosomal recessive type 3 cutis laxa. Let's move on to now something in the posterior segment or the back of the eye. So we'll look at some of the inherited optic nerve as well as retinal conditions. And this next case that we're going to discuss is a Leber's hereditary optic neuropathy. So this was a young male, 16-year-old, who presented with insidious onset of painless progressive diminution of vision. He did not have any hearing or neurological deficits. We also did his blood workup to look at his serum B12 and folate levels, which were normal. He was a non-smoker and non-drinker. And this is his optic nerve, which we can see is pale over here. And this can happen in case of inherited conditions or nutritional or some sort of an inflammatory condition. So this is looking at the OCT of the optic of the retinal ganglion cells, and also the visual field defect, which is more central in the cases. So this patient underwent genetic counseling, and he underwent testing, and he was positive for a single point mutation in the 11778 gene, and this is the commonest point mutation which is seen in Leber's hereditary optic neuropathy. So eventually, this patient was then started on treatment, and we're quite fortunate to have idebenone, which is a drug used in Leber's hereditary optic neuropathy, which has recently been FDA approved. And some cases have shown improvement in the central vision. So this a particular boy markedly had improved vision and is now able to navigate and, in fact, be able to even study and do his schooling and college education. So with this, I'm going to come to one of our papers that we published in JPOS on the clinical and genetic profile of Leber's hereditary optic neuropathy. We had a lot of clinical as well as genetic conclusions in this, which you can further read. But we mainly had males who presented with severe to profound vision loss and much later on. And the 11778 mutation was the commonest primary mutation in our cohort. From here, we move on to the inherited retinal conditions, and inherited retinal conditions are very commonly associated with some system involvement, commonest being the central nervous system, followed by the ear, the skeleton, the kidneys, and the cardiovascular system as well. So this little girl, she presented with, as you can see in this picture over here, she seems to be quite obese. She has polydactyly. She has an extra digit on her fingers as well as the toes. She also had features of a Duane's retraction syndrome where her ocular motility was limited. And coming to her retina, she had features of retinitis pigmentosa. Her ERG shows extinguished waveforms, both in the light and dark, that is the scotopic and photopic. Here we can see the fingers and the toes with the extra digit. So basically, I've come to coming to this condition called as the Bardet-Biedl syndrome, which is autosomal recessive, affects the eyes and the extraocular systemic involvement, which involves intellectual disability, short stature, obesity, hypogonadism, and polydactyly. The next syndrome, the inherited retinal, is the Usher's, which we see quite commonly, where there is retinitis pigmentosa as well as sensory neural hearing loss. And so this young patient who presented with retinitis pigmentosa, here you can see the pigmentary retinopathy, these sort of dark colored arrows over here. And he had extensive field loss as well. So Usher's syndrome there are some other syndromes as well who can have similar phenotypic presentations. So there is a lot of phenotypic overlap in some of these conditions where there is retinitis pigmentosa and associated syndromes. Next, we come to another baby. So this little baby who first I saw was at 4 months of age, and this patient had no eye contact, roving eye movements. And as you can see on the MRI, there is a molar tooth sign, which we can see over here, and this is suggestive of a Joubert syndrome. And in Joubert syndrome, so I'm just going to try and see if I can play this video. So he cannot initiate saccades. He cannot move his eyes smoothly as we can move from right to left. So every time he has to move his head, this is called as a head thrust or an oculomotor apraxia, which is very typical. This is that same little 4-month-old who's now actually grown up. So in Joba's So in Jobers, we see a number of ocular as well as extraocular features as we've listed out here. This child had an oculomotor apraxia. He had some pigmentary retinopathy, nystagmus, and also he had some varying amount of mental retardation as well. So with all this, I'm just going to leave you to some of these interesting cases and sort of conclude that pediatric ophthalmology and ocular genetics in particular deals with all these varied syndromes and the inherited and genetic conditions. And an appropriate genetic counseling is very crucial for the family, for them to plan for the children or for the affected child in the family or for when grows up or she grows up and plans the family for themselves. Genetic testing aids in obtaining a confirmatory diagnosis, and it's actually in this genomic era that we live in, it is really very crucial. A teamwork is very important in these sort of condition and helps to provide the best possible care for the patient as well as for the family. So with this, I really thank you for your patient listening, and I'm very happy to take any questions if you have. Thank you.
Thank you, Dr. Bhate.
Good day, everyone. I'm Dr. Manju Bhate. I'm a faculty in ocular genetics and pediatric ophthalmology at LV.
Yeah, thank you. So we'll take questions at the end, and therefore we'll move on to the next talk by Guy Chen. Let me introduce Guy to the audience both online and offline. Guy is an associate professor, Department of Ophthalmology and Visual Sciences at Hong Kong, and is the head of the Graduate Division of Ophthalmology and Vision Sciences at the Chinese University of Hong Kong. And he has done his PhD from the Chinese University of Hong Kong. He's a qualified ophthalmologist with a research background. And he's also the fellow of College of Ophthalmologists in Hong Kong. His interests are in molecular genomics and mechanisms of major eye diseases. And his interest lies on many things, including the clinical genetics, genetic testing, and consultation for eye diseases. So he has over 160 publications in reputed index journals. His H index is about 45. He's got a gold medal at the AAPPO Academic Development Mentorship Scheme of 2019-20. And he's the Asia Pacific Vitreoretinal Society Constable Lecture Award, the 13th APVRS Congress in 2019, is something he has been awarded. And then he's a Distinguished Young Fellow 2019 from Hong Kong Academy of Medicine. And over to Dr. Chen.
Genome contains about 20. Okay, good day, everyone. So I'm Guy Chen from the Department of Ophthalmology and Visual Sciences, the Chinese University of Hong Kong. First of all, I would like to thank the organizing committee for the kind invitation. Today, I would like to share some of our work on genetic analysis, testing, and consultation for eye diseases. These are our funding support, and I have no financial interest. The human genome contains about 20,000 genes, so our role is to identify candidate disease genes among them. A candidate gene can be disease-causing or disease-associated, depending on whether the variants in the gene can directly cause the disease or just to increase the risk of the disease. The central dogma in molecular genetics provides the foundation for us to identify disease genes, from DNA, RNA, protein to structures, functions, and traits. If a variance occurs at the DNA level, then the traits may change and disease may occur. Therefore, our role is to identify the disease-related variants in DNA through gene mapping. And when we have the gene and variants, we can provide genetic testing and consultation for our patients. In the field of ophthalmology, genetic disease may affect a large amount of people. They can be caused by chromosomal abnormalities, single gene mutations, and interaction of multiple risk factors. And as shown in this pie chart, and that genetic diseases in fact contribute a large proportion of blindness worldwide. This diagram suggests that the mechanism of genetic diseases. The Mendelian form is caused by disease-causing mutations in one or more genes. In contrast, the multifactorial diseases are caused by the interaction of multiple genetic variants and environmental risk factors. So for different forms of the diseases, we shall provide different genetic consultation for the patients. Apart from genetic consultation, the identification of disease genes also serve other purposes and eventually should lead to precision medicine for our patients. In our department, we have been working on complex and monogenic eye diseases, as well as ocular traits in both adults and children. For some diseases, such as glaucoma and myopia, we follow up the patients and work to identify the genes that are associated with the progression of the diseases. Here, I briefly introduce some of the major eye diseases, especially for those not working in ophthalmology. The first one is retinitis pigmentosa, which is the most common form of inherited retinal dystrophy. Clinically, it presents as optic pallor, attenuated retinal vessels, and diffuse bone spicular pigmentation on the retina. Advanced RP patients may suffer from tunnel vision. RP currently has no cure, and there is no effective treatment to slow down its progression. RP can be inherited in autosomal dominant, autosomal recessive, and X-linked modes, and some patients may present as simplex RP, where the patients have no known family history of RP. Currently, over 60 genes have been identified for RP, and all of these genes have been summarized in the RedNet website, which is very useful reference for us. The Stargardt disease is the most common form of inherited macular dystrophy, causing central vision loss. It is an autosomal recessive disease, mostly caused by mutations in the ABCA4 gene. Therefore, genetic testing is helpful to confirm the diagnosis. Regarding common complex diseases, glaucoma is a group of optic neuropathy causing typical visual field defect and optic nerve loss, leading to increased coverage ratio, and it is a leading cause of irreversible blindness in the world. In Asia, primary angle closure glaucoma is the major form of glaucoma. Currently, glaucoma has no cure, and lowering the intraocular pressure is the only treatment modality. Primary open-angle glaucoma has monogenic form, which is caused by mutation in the myosin gene, and it also has multifactorial form caused by multiple risk factors. Age-related macular degeneration is the leading cause of irreversible blindness among elderly population in developed countries. Patients with late AMD can suffer from severe central vision loss. AMD is again a complex disease with multiple genetic and environmental risk factors. Nowadays, we treat the wet AMD patients using anti-VEGF therapy. So in genetic consultation, the roles of clinician is important, as they need to identify the patient with genetic eye diseases, identify the inheritance pattern, and collect clinical information. After genetic testing results are available, clinician can interpret the data to patient as well. The role of lab scientists is important as well, as they would help to design and conduct the genetic testing to obtain the genetic variants from patients. Therefore, in our department, clinicians and lab scientists work very closely to help patients with genetic eye diseases. One example case that we work together is that a Chinese family with autosomal dominant Duane syndrome, which is the absence of the abduction nerve, leading to congenital sixth nerve palsy along with other systemic complications. We spotted this family in our eye clinic, and we extract the detailed family history. And by that time, the question was that whether the member in the next generation will be affected. And if to simply judge by the pedigree, we would tell that subject A would be safe because his father is unaffected, and subject B may have 50% of the chance to have the disease. And of course, we are not happy with this answer because subject A's father can be carrier of the mutation with incomplete penetrance. So it is still possible for subject A to be affected if he also carry this mutation. And so we recruit all the family members with the detailed documentation of their clinical features, and we search for the underlying causative gene mutation. We sequence the SOR4 gene, which is the major gene for Duane syndrome, and we identify a small deletion in the coding region, which may lead to the phase shift of the amino acid. And this mutation is completely co-segregated with the disease in the pedigree, and should therefore be the disease-causing mutation. Now come back to the genetic consultation is that likely both of subject A and B did not carry the mutation, therefore they are very unlikely to be affected. And this work has been published in a journal paper as well. So in view of the need of genetic consultation for patients and our strong interest in genetics, we have set up a genetic clinic in our department. Once a month, we see patients with inherited eye diseases and provide genetic consultation. Also, if patients are keen, we send their DNA for genetic testing, which have several potential benefits for them, including to confirm the diagnosis at a molecular level, to identify carriers in the family, especially the younger generation, and we will build up a registry and mutation database of inherited eye diseases and identify candidates eligible for future clinical trial of gene therapy. We first provide basic genetic consultation based on pedigree analysis. And we then send their DNA to the molecular vision lab in the US for gene testing. The gene panel used contains over 900 genes that have been linked to eye diseases. Some examples are the rhodopsin gene, RP1 gene, RPGR, and RP65 genes for retinitis pigmentosa, RB1 gene for retinoblastoma, myosin gene for primary open-angle glaucoma, OPA1 for optic atrophy, and the CFH and ARMS2 gene for age-related macular degeneration. Here are some examples. Case 1 is a 30-year-old male patient. He was found to have a bullseye maculopathy with poor central vision in both eyes. Genetic testing showed that he is carrying 2 compound heterozygous mutation in the ABCA4 gene. Therefore, we confirm that this patient has Stargardt disease. Since this disease is recessive, therefore his kids are more likely to be carrier, but clinically normal. Our second case is a 13-year-old girl. She suffered from both eye poor central vision with diffuse retinal dystrophy and clumps of pigmented change. The clinical features are similar, but not typical for RP or cone rod dystrophy. So she otherwise has no systemic complaints, and her parents are healthy. We conduct genetic tests for her and found that the proband is carrying a homozygous deletion of the exon 1 to 20 of the MPHP1 gene. Mutation in MPH1P gene can cause Joubert syndrome or Senior-Loken syndrome. Both were autosomal recessive diseases affecting both the eyes and kidneys and some other organs. Therefore, we refer the girl to the Department of Pediatrics for further systemic workup. And by further family history taking, we know that the parents are cousins, a consanguineous marriage. So this is likely the cause of the homozygous last deletion in the gene. The third case is a 63-year-old lady developed blindness in her 30s. Clinical exam found typical and advanced RP changes. She came with her daughter and keen for genetic testing. The results show that the patient carries a 2 variants in the RPE65 gene, while her daughter carries only 1 mutation. Since RP65 causes autosomal recessive RP or Leber's congenital amaurosis, the daughter should have low risk of the disease. Interestingly, while we know that RP65 is causative for LCA and RP, we also know that it is target for gene therapy available for now. LCA is a group of inherited blinding disease with childhood onset. The RP65 gene therapy is now available for autosomal recessive RPE deficiency-related LCA. By injecting the AAV human RP65 compounds into subretinal space, the RP65 gene can express and provide normal protein for recycling of chromophore, increasing the visual function. This product has been approved by FDA in 2017 and available on market with the brand name of Lusterna. When we got the gene testing results, we discussed with the patient for gene therapy, but she was not keen due to age concern. The last case are two brothers with typical advanced RP with poor vision. Genetic testing showed that they both carry a hemizygous nonsense variant in the RPGR gene on the X chromosome, and their mother is heterozygous for this variant. Therefore, the brothers have X-linked RP. The good news there is that a clinical trial of gene therapy targeting the RPGR gene is now available, and we are liaising with the company about this gene therapy. If the genetic clinic continues, we will help more patients with Mendelian eye diseases. Apart from the clinical service, we also conduct research on genetic eye diseases and traits. For Mendelian diseases, we aim to identify the causative genes and mutations, while for multifactorial diseases, we aim to identify multiple associated gene variants and build up genetic prediction mode for individual prediction model for individual risk assessment. We adopt different genetic approaches to identify genetic variants for different eye diseases. Here I take myopia as example, is that myopia is mostly due to the elongation of the eyeball, causing image from distance focused on in front of the retina, causing blurred vision. Myopia is a very common eye disorder all over the world, especially in Asia. In view of the high and increasing frequency of myopia, along with its blinding complications, it is desirable to study myopia, of which, however, the cause and prevention method have not been fully defined. Currently, some major environmental risk factors have been identified for myopia, including reduced outdoor activity, increased near work. Also, parental background increase the risk, suggesting that genetic factors may also play a role in myopia. Myopia have both Mendelian form and multifactorial form. And as early as the 1990s, the first linkage locus of myopia was identified. And so far, more than 20 linkage loci have been found. In a recent large-scale genome-wide association study, over 400 genetic loci have been identified for myopia. They collectively explain over 18% of the heritability of myopia, suggesting that there is still a large amount of genes and variants for us to look for or to identify. Our group has been working on myopia genetics in Chinese. In earlier years, we mainly work on adult myopia by using different approaches. We work to determine the roles of genes in different severity of myopia, and we conduct candidate gene SNP analysis in different grades of myopia and found that most of these genes associated with myopia were in fact associated with higher grade myopia in our population. These genes can be risk factors for myopia progression, but we cannot test this hypothesis in adult because in adult, the myopia are largely stabilized. Excuse me. Therefore, we proceed to work on children myopia. Since 2015, we have been conducting the Hong Kong Children Eye Study, and apart from detailed eye examination investigation, we also collect the buccal swab or blood sample from the children and their parents for genetic study. We have identified that certain genes are associated with higher grade myopia, indicating that they may be risk factors for myopia progression. Therefore, we conduct a longitudinal study to investigate new genetic markers for myopia progression in children. We followed the children after 3 years, and this study included over 1,000 children who had completed 3 years follow-up. We select SNPs from our previous study on high myopia and also some others work on myopia progression. And in our results, we found that 2 SNPs in the GJD2 and KCNQ5 genes were associated with faster myopia progression. Also, by studying the progression of spherical equivalent and also axial length, three genes were identified to be associated with faster progression of the spherical equivalent and also axial elongation. We then investigated whether these genes have additive effect by using polygenic risk score, and find that children having a high score have over two-folds of increased risk of faster myopia progression. So in conclusion, this study identified three new genes as risk factors for myopia progression in children. Their effects may be exerted via axon elongation. Therefore, additional attention with proper intervention should be given to those children who carry the risk allele of these genes. However, only three genes can provide very limited value for genetic prediction. Therefore, more genes have yet to be identified and incorporated into this model. We therefore have conducted a genome-wide association analysis or studies on different children eye traits, including myopia and myopia progression. So we hope that we can identify more new genes and to include all these genes into a model to increase the power of our prediction model. In our previous clinical trial, we have identified low-dose atropine is effective in controlling myopia progression. We have done a genome-wide association study on those children sample and identified around 10 SNPs to be subjectively associated with myopia progression in children after adjusting for their treatment arms. We are now validating these results, and I hope that I can share with you the update in the future. And with the results, we can predict which children are more effective for atropine treatment, and this is also a part of the genetic consultation. To conclude, we have been conducting patient-oriented genetic research. Our work on the large group of genes to identify major targets for functional studies with a view to identify new genes and new disease mechanisms and new treatment for eye diseases, and provide genetic testing and consultation for our patient. And hopefully, all this work can lead to precision medicine in the future for all of our patients. And lastly, I would like to thank my clinical team and laboratory colleagues, and also thank you very much for your attention. And I'm very happy for any comments and questions and for further discussion. Thank you.
Thank you, Guy. We move on to the next presentation. And we have somebody awake in the middle of the night. Amy is from the US, and it's past, I think it's beyond 12:30 a.m. Sunday morning for her. Thank you for being awake and being with us, Amy. So let me introduce Amy to the audience. She's at the National Institutes of Health in Bethesda, Maryland. And she's in part of the institute called as the National Eye Institute. And she participates and counsels patients in ophthalmic genetics clinic at the National Eye Institute and coordinates the X-linked juvenile retinoschisis natural history protocol. She's at the Cardiogenetics Washington, D.C. MedStar Washington Hospital Center. And she's developed the MedStar first cardiogenetics clinic across multiple cardiovascular specialties and MedStar hospitals and clinic in the DC metro area. And she also does that in telegenetic form. So counseling patients for arrhythmias, cardiomyopathies, and aortic syndromes is part of her routine. And she also educates physicians in appropriate testing strategies and limitations of genetic testing. She's also part of the Oncology Washington, D.C. MedStar Washington Hospital Center. And she is an American board certified genetic counselor, and she's done her MSc Medical Genetics at the University of Wisconsin-Madison. Amy, over to you. You have to operate your own slides, Amy.
Yeah, sorry about that, and I was muted. My thing switched. So thank you guys for having me here, and hopefully you can now see my slides, but I need to put them in presentation mode. And I'm going to set a timer because I will talk for a very long time. Oh, golly, please go. Thank you very much. So I'm assuming hopefully that you guys can see this now as a full screen. Yes, so I am one of the 2 genetic counselors at the National Eye Institute, and my hope here is to try to give you guys a clinical perspective of our clinic, but it's also a research institution. So I do not have any disclosures, no outstanding funding outside of the National Institute of Health. So briefly, I'm going to take you through our eye clinic, just on a very broad overview. We'll talk a little bit about genetic testings, and because this is a genetic counseling conference, I'm going to kind of highlight some other genetic counseling considerations that may or may not be something that you guys kind of think about as you are approaching talking with maybe your first individual who has low vision or blindness. So as has kind of been introduced previously, there are a number of different eye conditions, right? The eye is a complex organ that's kind of a derivative of the brain. And I will say that some of these slides you can see at the bottom here were put together with from my colleague Delphine. She's the other genetic counselor in the Eye Institute, and she and I put together a presentation for a different group a couple of months ago. And so some of these slides I borrowed from that presentation. And so she did a really nice job of kind of highlighting, you know, there are disorders here on the right side of the screen in blue that are more front of the eye. There are disorders at the back of the eye. There are cancer syndromes. There's a large number of syndromes all associated in the eye. Primarily, though, at the National Eye Institute, we don't see everything. We see, you know, a large subset of them, and the kind of the symbols with the stars are more of what we see, the more of our bread and butter. So we see a lot of retinal dystrophies, IRDs. We see a lot of individuals with coloboma because we have a coloboma protocol. And we do have also a SCA7 neurodegeneration protocol. So yes, we see a large variety of cases, individuals, disorders, but again, more of our bread and butters are the inherited retinal dystrophies, which have been introduced. And so I will not spend as much time going into a lot of depth, but I do have a case presentation in a little bit. So again, clinical evaluation, some of you very well may be very familiar with just going to an eye doctor. Some of you may never have been to an eye doctor, but typically when you go to a regular eye doctor, you know, you put your head in what we call a slit lamp, and they'll, you know, the eye doctor will look at your eyes and look at the front of your eye, maybe put up a lens to your eyeball and look at the back of your retina with your eyes dilated. You may read a chart here all the way on the right side of the screen. They may give you different letters or shapes if it's a child, if they're not able to read letters at this point in time. But at the Eye Institute, we have a lot of other more specialized testing in addition to, you know, again, looking at your eyes like you would and reading a chart like you would at your outside optometrist or ophthalmologist office. But we can look at, you know, visual fields here, or we can do the ERGs, which again measure kind of similar to an EKG where you have your, you know, the stickies on your chest to measure the electricity of your heart. It can measure the waveforms of how the retina is functioning. And we have tons of other different things, but there's a wide and deep kind of investigation for every patient that comes in through our doors who's being considered for a study. So again, just to, as a genetic counselor, I guess, my role, how I see what I do, I'm one of the first contacts for our patients before they get in the door. I call them, I get a family history, and then we talk about vision loss, right? And so, you know, vision loss is kind of abstract for those of us who have normal vision or, you know, decently functioning vision, right? Or we're very smart. Humans are very smart. We're able to kind of make do and, you know, sometimes not understand that we're not missing some things. And so, there are different ways we can lose our vision. So there are, if you see the picture up here on the top right of your screen, there are two young children who have different balls, who are smiling, they're friends. And if you kind of go around the circle, you know, if you go right below it, there is that kind of dark tunnel vision, right? So someone has lost their peripheral vision. They may or may not realize that because, again, people will scan their heads, they'll move from side to side. But some people will say, oh yeah, when I'm looking at you, I can't see your mouth. that's all lost. I can only see your eyes. So some people are very aware of what their limitations are, some are not. Some people may lose their center vision. So again, in a kind of a direct contrast that you can see, if you lose your peripheral vision, you may have still very crisp center vision, but some individuals who lose their center vision, it's all fuzzy. Your center vision is your crisp 20/20 vision, or if you're wearing glasses, again, we're trying to get everybody to 20/20, but it may be really fuzzy, and so glasses will not correct it, or you may just lose in general. You may have the gray spot, so you might lose that. You may lose color perception. Colors may start to fade. That's kind of at the bottom. So or you may perceive things a little bit differently, and it is indeed different than your typical red-green color blindness. Some people can't see at night, so when it's night out and there's not a lot of street lights, they can't get around. And there's a whole host of different things. And so when I'm talking with a patient, I'll ask them a bunch of questions. Well, do you feel like you can see blues and blacks okay, browns or is that okay, or is that change? Can you see like something white on white? Because some people can't see color on color, they lose objects on the table. So there's all these different questions that I try to ask to get at the nature of someone's vision loss, to kind of better prepare us for our conversation of what we're going to talk about in the upcoming conversation, this session. Additionally, as it's kind of been hinted at before, when I'm asking my questions with our individuals who are coming in, it's not just specifically directed at vision. There's so many other components that may or may not be affected. We do have individuals who come in with Usher syndrome who are deaf, and so you're calling through a phone interpreter that is an audio visual interpreter. So there are all sorts of different ways that we're able to communicate with our patients. But things that I also think about when I'm taking these family history, there's systemic issues. So again, hearing loss, it may not be as substantial as sensory neural hearing loss. It's me that requires maybe a cochlear implant, but again, extra fingers, toes, maybe they've been tied off. Other birth defects like a cleft lip or palate, kidney issues. If we're thinking about, an embryologic disorder similar to a coloboma, how was the pregnancy course, eventful, uneventful? Again, development, any seizures, regression. There's a whole host of things. As a genetic counselor, we're kind of always thinking about everything because you never know what's going to come up in a family history. So to kind of take a step back and also where we are today and move forward, again, it feels silly to say, but really, 10 years ago, we were still going gene by gene. And so, and it's spectacular how much more affordable genetic testing is, right? So instead of going gene by gene by gene, if we're not finding the answer, we run a big panel. In fact, everybody who comes into the National Eye Institute at this time, we are we're putting them on our exome protocol. So we're getting a panel, but then we get the data on the back end to keep digging. As you guys are all aware, right, there are so many considerations in terms of what panel that you are selecting if you are not getting an exome right off the bat, because exomes are still, generally speaking, a little expensive from a clinical standpoint. Do we believe this is monogenic or is it multifactorial? Looking at your panel, what's on the panel? Are your primary genes that you're still thinking about, are those on that panel? And additionally, the interpretation of each gene, variants of a gene by each lab, because each lab, at least in the United States, right, you can send to different clinical laboratories and they can interpret the same variant differently, even though we have different mechanisms that hopefully are trying to maybe make it a little bit more even, or ways that you can kind of try and sort out the different classifications. But there are so many different considerations. Of course, microarray, single gene testing, or trinucleotide repeats. Trinucleotides are not picked up. So if you are worried about SCA7, you're not going to pick that up on a panel. You need to order the trinucleotide repeat. Again, then we did phenotype first, getting really, really good phenotype data. Now, is it becoming genotype first? Are people coming in with genetic testing and we don't really know what their phenotype is? And the short of the answer is that's starting to happen, but I would argue that phenotype first is still a really great way. And that's right, because as we all know, there's so many nuances of making sure that we're understanding and how to interpret this. We have genes on our panels that have a number of different ways that they're inherited, both recessive, dominant. There are different types of variants. Some of them are hypomorphic. So if those hypomorphic alleles are homozygous, someone may not have disease, but if it's in trans with a more pathogenic, a traditional pathogenic variant, it may be something that we consider to be disease causing and something that we're worried about. Again, that location and the impact of each variant also may change, right? And again, is it a truncation? And so if you have one truncation and one missense variant, is that compatible with disease process? Do you need two truncations? There's so many different aspects of trying to understand, the genetic test results in addition to, the individual's presentation. And again, just like any other disorder, there's incomplete penetrance, variable expressivity, and there are certain forms of our disorders that have digenic inheritance. So there are so many, again, your traditional genetic underpinnings definitely apply, and to an extent are maybe a little bit more complex than some of our other disorders and other clinics that, I've been involved in. Additionally, just to keep throwing, kind of things that we all need to be thinking about, keeping us on our toes, our interpretation of these genetic test results may continue to evolve because, there are things that we thought this is going to be stable, or nope, this is something that we think is progressive. But there may be some people that were like, ooh, this is probably stable. But as we are following these individuals with very deep phenotyping, year over year, decade over decade, maybe we're finding that there are some subtle changes that, were brushed off because maybe testing, a decade ago, 2 decades ago, when this was first published, wasn't able to pick up on. And so what does that mean for an individual? Other things that as you're thinking about talking with families, talking with, you're talking with an individual and you're talking about, your grown sibling, they could be at risk, yes, maybe you had this early, but they could develop this later in life, or they might have very subtle symptoms that if they haven't been to an ophthalmologist and had these very sensitive tests, they might not realize that this is going on, right? So there can be a very variable age of onset for any of these disorders. Some disorders are very easy to diagnose clinically, and some are, well, yeah, there's something going on. We can see that there's, but we're not quite so certain what this is. And this is why we're still pushing our research. Right? That's why we're all trying to push this information forward, because we don't have all the answers yet at this time. And again, finally, syndromic, non-syndromic, or is it non-syndromic and then maybe it's syndromic, right? So something that maybe you have RP, and then 5 years later, you start to realize that you're starting to lose your hearing, your balance is starting to go. Are these USH variants? Is it really Usher? Because there is USH2A RP only, but is it potentially something that is, maybe turning into something that is syndromic? And that's, again, something that why it's crucial that individuals continue to follow up, because we are slowly learning more. And, I always say we're learning more every year, every day that people come in and see us. Finally, of my then and now kind of portion, historically, we said that there's no cure, there's no therapy. We don't have anything we can do. This is something that, again, for the most part, these are mostly progressive disorders. We expect you to continue to lose your vision. And now we know that, as has been mentioned, we have one, at least in the United States, approved FDA medication for RPE65. And there are many, many more that are currently under investigation with clinical trials. And again, Delphine helped me put this slide together for our other presentation. And I was recently updated back in April, but you can see that there are different types of trials for these inherited forms of eye diseases. And so there are the gene-based, which are limited because, you have to go gene by gene. And even some of the gene-based disorders are not for the whole gene. It's maybe for a specific variant within that gene. So it's a little bit more complicated, because if you're thinking you're trying to go gene by gene to solve these problems, our panels are hundreds of genes, right? It's going to take a very long time. And so there are other mechanisms and other modalities that really smart groups all around the world are working on. And so we're all so grateful. And, we're grateful for the patients who want to continue to push this forward to try and help, help them, but also help others because this is what we're all trying to do, is help people maintain as much vision, functional vision, as we can help them maintain. So I wanted to briefly highlight a quick study, a quick individual who came into our clinic. He came in, he was 42 years old, the young gentleman with the little arrow. He had a personal history of retinitis pigmentosa, or RP. He was diagnosed in his teens, and you can see that his maternal grandfather also had RP. And so, growing up, he was like, oh yeah, my grandpa had it. So, he was a really good support system for me. And, his cousin through his mom also had RP. Everyone in the family is male who has RP. And so these are his photos. And so it's kind of been pointed out about the bone spicules being a hallmark sign of retinitis pigmentosa. And so the color, the picture on the top is the color version. I mean, it's false colors. It's red and green, so the retina doesn't fully look like this. But the black and white photo is our fundus autofluorescence. So it's a special filter, a special light with a special filter that the retina kind of it shows different patterns based on if the cells are sick or not. And so it's kind of, you want more of a more homogeneous gray. The dark spots are sick retina, those are the bone spicules. And so essentially he has a very classic phenotype for retinitis pigmentosa. And part of the reason he came to us is he's a very smart man. He's like, I know that there are clinical trials for X-linked RP. We always thought that was what was going on in the family, right? Like my mom's dad had RP. This is what we had thought was going on. He's like, I just had genetic testing. Why didn't it show it? Like, what's going on? Why? And so, he and I spoke, and I didn't have his test results when he and I first started chatting. And I said, well, send me your test results. I'll look over them. I said, I'm suspicious if it was done at a certain laboratory, the main X-linked form of RP is a really hard gene to test. It may not have been included. We can always retest. And so RPGR, the main form of X-linked RP, was not on his test, and so we did retest him. But I just want to pause before I get to the next slide to finish his case, because the other aspects of this case for this gentleman were the psychosocial components. And I think this is where we as genetic counselors really can shine. And so there are so many things that if you think about as an adult, how your vision is crucial, both maybe in your employment, getting to and from work if you need to drive, how you are going about taking care of family members, and this is not just RP, right? This is, if your central acuity goes. So, I talk with adults. I mean, we see adults and children in our clinic, but, adults, how you've given me life-changing news. What does this mean for me? Am I I wanted to travel the world when I retire? What does this mean? How am I supposed to go about and do what I want to, how am I supposed to go to college? What do I need to completely change what I want to do? I need to drive, I need to do all these things. And so there's so many different aspects, including, this discrimination disclosure. This individual, this gentleman who came in to see us with RP, he had moved, I didn't include his son on the pedigree. He had moved 2 hours away from work so he could be closer to his son, so he could be involved in his son's life. So he was doing 2 hours worth of driving, but he's like, I can't drive at night. I can't see at night. So I have to leave when the sun is up to go to work, and I have to leave before the sun sets to come home. I can't work remote. I have to be on site. I'm like a mechanic. I have to be on site. And so, there's all of these components that, working, if in the DC metro area, we have a really great public transportation system, but, if you are dependent on your commute, I don't know how, that's a very hard thing to do. And so again, I kind of hinted at this gentleman did have an RPGR pathogenic variant. So the clinical trials, which is why he initially reached out, that he could enroll in them if he's interested, but because it's a trial, we don't know if any of them will work. And so, there is of course a limitation that none of these are giving back any retina cells, or it's trying to save the cells that are left. So it may not, give him back vision, but the hope would be maybe to slow it down. And again, the psychosocial challenges, his issues driving, how is he going to tell his son, but also wanting to be near his son. But again, because we found that it's X-linked, he couldn't have passed it on to his son. And he had that, again, inclination when we first met, but this test result kind of proved that. As kind of mentioned, there are a whole host and a group of opportunities for individuals, for patients who are interested. Most of these are in the United States, but clinicaltrials.gov does have trials all over the world listed. And so that might be a really great place. And I always search both by gene and by diagnosis, because again, not always is there a gene specific variant. And just finally, just to briefly wrap up, practical aspects of interacting with a patient with vision loss, things that may or may not be on top of your mind. So anticipate and ask, do they need help getting down the hall? They might need help with paperwork for, their disability. And if someone is low vision and blind, they might need an interpreter. So we have American Sign Language interpreters who accompany, or they might need a manual sign with their hand if they're really low vision blind. Utilize referrals to a low vision specialist. We have those in the United States. Or an ophthalmologic genetic counselor if you don't have one in your team, because again, there are so many different aspects to what we provide these individuals. Something that is hard for even our patients with a recent diagnosis. Legal blindness is not equivalent to lifestyle blindness, complete blindness. There is being legally blind but still having functional vision. But there is, people think, oh, I'm going to go lights out and not be able to see anything. There is a very big difference, and we can never predict what someone's final vision capacity is going to be. If someone comes in with a guide dog, do not pet it. It's a working dog. They need to be doing their job. And time is of the essence to get people into the right referral so they can continue to make meaning in their life. Again, the future's now. Test prices have come down, which is a really great thing in terms of genetic testing. But I think that clinical phenotyping may help clarify these test results, which may be a challenge. People come and they are with us from 8 a.m. to 5 or 6 p.m. So it is a full day of exams. If you are not able to do pretest counseling, I would try and recommend that you really do it, because it's really invaluable, especially if that test result is not clear or setting expectations. And so I just want to say thank you guys for your attention, and give some acknowledgement to, again, my colleague Delphine, Dr. Luther Hearn, my other ophthalmic genetics staff and clinic, and then of course all of our patients who we would not be here without them. So thank you so very much.
Thank you. Thank you, Amy. And again, once again, thank you for being awake in the middle of the night. Nice of you. Would you like to stay back till the panel discussion, or is it okay for you to stay
I'll
back?
try and stay awake. I'm drinking some tea.
Okay.
So I'll try.
Okay. So the questions will be during before the panel discussion. Thanks, Amy. So from North America, we move down under to Melbourne, Australia. We have two distinguished speakers from Melbourne. And I'll first introduce Sandra, who's going to be the next speaker. And her passion is retinoblastoma. And she's the retinoblastoma care coordinator, clinical research coordination, and senior clinical orthoptist at the Department of Ophthalmology, Royal Children's Hospital in Melbourne. She's a research fellow, Clinical Genetics Unit, Center for Eye Research, Australia. And she's a honorary fellow, Department of Surgery, Ophthalmology, University of Melbourne, and honorary clinical associate, Murdoch Children's Research Institute, Melbourne. So she has done her PhD in retinoblastoma, and then at the University of Melbourne. And as mentioned earlier, her passion is heritable retinoblastoma in particular. And her career highlights are that the retinoblastoma research with focus on raising awareness of early signs of the disease. So she also educates the parents for various eye diseases to be detected early. Over to Sandra.
Thank you very much. I'm not able to share my screen at the moment. It says I can't start while the other participant is sharing. I'm still not able to share.
I'm not still sharing, am I? Is it my fault?
I'm just getting a dialog box that says I cannot start screen sharing. I've been having trouble with screens.
Close the dialog box and try to share it again.
I'm trying. No, it's still not working. I've been having a lot of trouble all afternoon, in fact. I'm just going to jump out of the meeting and come back in. That seems to be fixing everything. I'll be back in a minute.
Apologies for the technical difficulty. Hope we'll solve it soon.
Ma'am, can you log out and rejoin again?
Yep, that's what I've done.
Yeah, it's working perfect now, ma'am.
Yeah. Okay,
Yeah.
great.
So your screen is visible, Sandra.
My screen's visible.
Yes. You have to go to the
Oops.
Put it on a slideshow mode.
Yeah, I'm just trying to move this out of the way. Oh, away we go. Okay. So thank you very much for the opportunity to present to your meeting today, where I'll be focusing on screening and surveillance for retinoblastoma. And although I'm clinically trained as an orthoptist, so an eye care health provider, it's been my privilege to be the RB care coordinator at the Children's Hospital in Victoria for almost 30 years, supporting children and their families through diagnosis, acute treatment, and survivorship. Now, this is the human face of retinoblastoma, and it is more than an intraocular malignancy. It irreversibly impacts the individual and their family, and genetic counsellors are integral to the care team. So it's important that you understand the disease. Today, I will briefly share an overview of RB, the history of gene discovery, and how these discoveries have translated to clinical care, and sometimes that we don't always have the answers. Although rare, retinoblastoma is the most common intraocular malignancy in children under the age of 5 years. It occurs in one or both eyes, and tumours develop in a centrifugal pattern in the maturing retinoblast.
But your slides are not moving.
Oh, God.
If you move,
I don't know what to do.
put it on slide mode, Sandra.
Beg pardon?
You have to put it on slide mode. View mode.
I have put it on. That's what I'm seeing on my screen.
Can you move your slides?
Have you got my slides now?
We are still on the first slide over here.
I don't know what to do to fix it because my slides are advancing here. I don't know what to do. Can you see my first slide now?
We can see your slides actually.
Actually, your internet connection is not stable at the moment.
Okay, now it has come. I think there is a delay.
It's working now.
Do you have the slides?
Yeah, so your internet is a bit
Okay.
slow. Yeah. Now we have.
Can
the
you see
first-
my second slide?
I think it would take a little time before it moves. Sandra, maybe you can go off the video mode. That will help with the bandwidth.
Okay. Try that. I'm terribly sorry. Is that better?
There is a delay actually.
You got my second slide now?
No, it's still in the first one.
Are you seeing my slides advancing?
It's still on the first slide, retinoblastoma screening and surveillance.
Yeah, I to do differently. I have no idea what to do.
Okay, yeah, now you've got the second one. You have the second slide.
Oh, something's very strange going on because I'm now looking at my first slide. So I'm not sure how you can see my second one. Do you want to move on to a different speaker? Sorry, Lisa, and I'll see if I can do something about my internet.
One thing we
Tether it.
can do, Sandra, what we can do is we have your slides, we can download it, but in the meantime, we can make Lisa present, if that's okay.
Yeah, let's do that. And you can advance the slides for me.
Yeah, so we'll get that organized for you. We'll download the slides over here, and then
Thank you.
we will change the slides. And
Thank
in the
you.
meantime, let me introduce Lisa. So Lisa is a research genetic counselor and orthoptist at the same Center for Eye Research in Australia, in Melbourne. She is a senior orthoptist, Ocular Diagnostic Clinic and Ocular Genetics Clinic, Royal Victorian Eye and Ear Hospital in East Melbourne. Lisa has a unique skill set with orthoptic and genetic counseling qualifications. And in a role at the Royal Victorian Eye and Ear Hospital in Melbourne, Australia, Lisa works in the Ocular Diagnostic Clinic and Ocular Genetic Clinic, performing ophthalmic and vision electrophysiology assessments. As a research genetic counselor and orthoptist at the Center for Eye Research Australia, Lisa works on multiple research studies that investigates the genetic cause and impact of inherited eye diseases. Lisa provides a link between the participants, their treating clinician, and the rest of the research team. With a wealth of knowledge and passion, she's also a board member of the Usher Kids Australia. Over to Lisa.
Thank you very much. I'll just try and start to share my screen too. Can you see my slides now?
Yeah, we can see your slides.
Okay, and you can hear me okay?
Okay, you can go ahead. Thank you.
Okay, lovely. Excellent. Well, thanks for the organisers for the opportunity of speaking today. It's a pleasure to be here. My talk is on inherited retinal and optic nerve diseases and making sense of the genes. I have no financial interests to disclose. So as we've heard earlier, inherited retinal disease, otherwise known as an IRD, are a broad group of genetic conditions that affect the retina, the light-sensitive part of the eye. And depending on the individual condition, depends on what layer of the eye is affected. And as Amy mentioned in her previous talk, some people may have peripheral vision loss, others central vision loss, and in other people, it might be a combination of two. Each individual condition is quite rare, but overall IRDs affect 1 in 4,000 individuals. However, worldwide carrier frequency suggests that autosomal recessive IRDs can affect more than 1 in almost 1,400 people. They are the most common cause of legal blindness in the working age population, far outweighing diabetic retinopathy and macular degeneration. And thus coming to terms with an IRD can lead to many questions. What caused this? How is this going to impact on my driving? What are the familial implications? As we've seen earlier in our previous presentations, there's quite a spectrum of IRDs, and retinitis pigmentosa, RP, is probably one of the commonest. There are over 280 genes associated with IRDs, with different inheritance patterns, age of onset, whether these are stationary or progressive. And in some cases, they may be syndromic. For example, Usher syndrome affects the hearing, but also gives rise to retinitis pigmentosa. With genetic testing now, the positive gene can now be identified in approximately 60 to 80% of patients. We're also seeing with IRDs that there's the clinical and genetic heterogeneous, which means that the one gene could give rise to different phenotypes.
Best practice guidelines have been adopted to manage patients with inherited retinal diseases. And as Amy mentioned, a thorough history and family history is crucial. Clinical examination, visual acuity, visual fields, some specialised retinal imaging and photos of the back of the eye, electrodiagnostic tests, which are similar to assessing the rod and cone function. And becoming a bit more standard now is genetic testing. And these are the guidelines that have been adopted by the Australian group, the Royal Australian and New Zealand College of Ophthalmology, but there are similar guidelines adopted in other countries. Like many rare genetic conditions, they're best managed in a multidisciplinary clinic. And where we're based at the Eye and Ear Hospital in Melbourne, we have an ocular genetic clinic, which has the clinicians specialised in eyes, so ophthalmology and orthoptics, but also has the benefit of having the geneticist and the genetic counselling as part of the clinic. So essentially, patients can have all their phenotyping performed at the same time, and then having a further discussion of genetic testing, counselling, but also addressing the psychosocial issues. So some cases that we see in clinic can be quite straightforward. And this is a lady that presented to clinic. She was in her 30s. She had nystagmus, wobbly eye. She was short-sighted, and she had reduced vision in childhood. There was a significant family history with several males affected, and the clinical phenotype was, we're pretty confident it was X-linked ocular albinism based on the eye features and the family history. The genetic testing results came back, and it was pretty convincing. So this verification was also done in her affected father as well. And this lady then went on to utilise these genetic testing results with PGT, pre-implant genetic testing, and IVF to have a child free of the ocular albinism gene. However, some other cases need a little bit more work. And this is a lady in her late 20s who presented to clinic for family planning advice. She was diagnosed with RP when she was 5 years old, similar to her mum. And we can see here on the far right, she had very good central vision, so 6/6 or 20/20. Her visual fields, and this is only including her right eye, and they were reasonably good. However, when we take the photos of the back of the eye, there were some distinctive pigmentary changes would fit with a retinitis pigmentosa or an IRD phenotype. And what was interesting with the pedigree here, that the way that she described that some family members were severely affected, whilst others were quite mildly. And so we sent off for a panel, an IRD panel. But in the meantime, while waiting on those results, we actually saw a cousin who was aged in his 20s, and he was a male, and he presented to clinic for the first time. When we did his visual acuity, his central vision was exceptionally good, 6/6 or 20/20. But what we found on the Goldman visual field, that his visual field was very restricted, almost to 10 degrees. So you can see there's quite a difference between the male cousin compared to the female. When we take the photographs of the back of the eye, we see quite a lot of atrophy. So this area here is certainly not functioning on all levels. So we did get the genetic results back, and this confirmed a pathogenic mutation for X-linked choroideremia, which would fit with the phenotype of a mildly affected female and quite a severe male. When we do some further literature about X-linked choroideremia carriers, usually they're a mild phenotype, but there can be a variation in degree of vision impairment between families. Very occasionally, we can see a severe retinal abnormality in a female due to X-linked inactivation. And so for this family, or for this individual in particular, we were she was given reproductive counselling, and she was looking to utilise this information with pre-implant genetic testing and IVF. Obviously, this genetic diagnosis had wider implications for other family members. And as we can see up here, the maternal grandfather was affected, but he had 9 daughters who were all going to be obligate carriers. So some of these individuals were quite receptive and came in for their appointment, others declined. And so it's very important from a genetic counselling perspective to be given this information. But certainly more needs to be done with understanding the female carriers in X-linked choroideremia. And currently at the Centre for Research Australia, we're conducting a natural history study for CHM carriers. And as Amy mentioned earlier, there is a number of gene therapy trials for inherited retinal diseases, including choroideremia. Hence, it's important to be aware of to provide a genetic diagnosis for families, particularly with X-linked dystrophies. Moving on to another case, another lady in her late 20s, and she has had poor vision since childhood and had glasses since she was 4. The family history was quite limited. Her parents died when she was very young, and she was moved from different homes. Her vision was quite reduced, but what was interesting that she had very constricted fields, visual fields. So this is her right eye and her left eye in comparison to a fuller field over here. And she had complaints of glare and night vision difficulties. However, when we did the electrodiagnostic test of the rod function, it didn't quite match up. And she'd been on a journey for many, many years and was a diagnostic odyssey. The diagnosis was unclear. It was a query, it could have been a retinal dystrophy. She was very keen to explore genetic testing as she was thinking of having further children. Blueprint Genetics conducted the testing, and on their panel was an IRD panel including a mitochondrial assay. So there were no pathogenic IRD variants. However, there was a confirmed LON mutation, the 14484. This is not the commonest one in Australia, but probably the second common one. And so this provided a clinical and a genetic diagnosis of Leber's hereditary optic neuropathy. So LON is the most common cause of mitochondrial blindness. There's normally normal vision until the disease strikes in early adulthood. This gives rise to profound blindness and renders patients legally blind in a very short number of months. The cells that are affected are the retinal ganglion cells, and these are the cells that transmit visual information to the brain along to the optic nerve. So some families are classic. The diagnosis is based on family and clinical history alone, and usually young males are affected. Professor David Mackey has been researching LON for the last 30 years and conducted research analysis on many of the Australian pedigrees. So if we see a patient in Australia, quite often they link into one of these larger pedigrees. However, what we found is that pedigrees aren't always classic. There may not be a maternal history of blindness, may be an atypical age or gender, and the clinical presentation may mimic other conditions. Last year, as part of a collaboration between the Centre for Research Australia, where Sandra and I work, and the Lions Eye Institute in Perth with Professor Mackey, we published an epidemiology study of our LON pedigrees in Australia, and this was published in the American Journal of Human Genetics. And what we found is, yes, there is a peak of males being affected in young adulthood, but what we also did find that there's a small number across the lifespan for females losing vision, but also a small number of children being affected. When we went back to have another consult with case number 3, more family tree information was able to be obtained, and in fact she does link into a known very, very large family with 14484 mutation. And in the pedigree there was a number of family members who might be mild, moderate or even severe. And in some cases there was spontaneous visual recovery, which can be seen with this particular mutation, but not to the level that the person was able to drive a car again, but certainly enough to obtain a few extra lines on the vision chart. So for this lady, it was the end of the diagnostic odyssey, but was now to grasp LON and the familial implications. So as I mentioned previously, LON is a mitochondrial inherited condition. It's usually in LON pedigrees, they're homoplasmic. There's a small number which may be heteroplasmic, but most are homoplasmic. But interestingly and difficult from a counselling point of view is that not everyone with the LON mutation will lose vision. We know that it can affect between 1 in 30,000 to 1 in almost 70,000 as a carrier, but only about 1 in 8,000 lose vision. The literature on these patient information websites suggests that males are at a 50% risk of losing vision over their lifetime, which is quite high and quite unsettling for family members. But from the research study that we published in American Journal of Human Genetics, the Australian figures suggest that for males, there's a 1 in 6 or a 17.5% chance of vision loss, whereas in the females, it's around about a bit over 5. So from our work suggests that the risk of losing vision may actually be less than previously reported. But it is important to emphasise that in some of our pedigrees, we have quite low penetrance, but there are some pedigrees which are high. These ones may have the double mutation, but also the neurological LHON plus phenotype. So as we mentioned earlier, we can't predict those who will lose vision in their lifetime, which can be very unsettling. And this prompted family members actually to publish a book about losing their vision. It was called Born with a Bomb. And so it's very important that LHON individuals, but also their family members, do have appropriate genetic counselling, but also counselling on possible triggers. And they're only possible, not confirmed. So some triggers may be smoking, might put you at an increased risk, or even heavy alcohol consumption, but that always doesn't fit if children are being affected, as they wouldn't have been exposed to these two potential triggers. Trauma could be a possibility, and so we would encourage families, to limit head contact sports, to be aware of any mitochondrial toxic drugs if they're being prescribed anything from their physician. And the other factors that we're looking at quite intensely, and same as other groups elsewhere, is looking at the role of estrogens and other genetic factors that may play a part in, may understand why someone may lose a vision and others don't, particularly in the families that there is a fairly high penetrance and someone smoked like a chimney and not lost vision, and there's others that have had a very healthy lifestyle and unfortunately lost their sight. There is no preventative treatment or cure at the moment, but this has been ongoing research, and there are clinical trials specific for the most common LON mutation. So understanding the triggers is quite fundamental in developing treatment options. Supportive management is crucial for LON individuals, genetic counselling, but also the psychosocial impact, putting them in touch with support groups, and there's various MITO support groups. The one in Australia is the MITO Foundation, but there are other support groups internationally, putting them in touch for a mental health plan. Some families may find benefit of connecting with other LON families on the LHON Facebooks, and all of the practical side of things. So putting them and people in touch with organisations, low vision supports, and ensuring that they have a healthy lifestyle. From a family planning perspective, So back to our case, so for this lady, she had an unaffected brother. From when he gets older, one of the good things is that he won't pass on the gene to his children, but he does have a risk of losing vision himself. So it's important that he's made aware of the lifestyle factors. For this lady, she will pass on the mitochondrial genetic risk to each of her children, regardless if they're a boy or a girl, but it's not certain if they will or won't lose vision. And again, it's a source of research to understand why is this the case. From a reproductive options, some families that we have seen sort of accept the risk of having a child with Lyme and get on with their everyday lives. Others may choose not to have children. This can vary even between the same families. Other family members, particularly in the high penetrant families, they've gone down the egg donation or gender selection pathway, genetically choosing females. Where we are, if that is the case, it's not a given because gender selection is not legalised here, and patients would have to undergo an assessment with the patient review panel, medical panel. A really big topic here in Australia for the last year or so has been the mitochondrial donation. And this is an IVF-based technique to replace the vital mitochondrial DNA and essentially to help reduce the risk of transmitting the Lyme mutation to the next generation. And so Mabe's Law is the law formerly known as the Mitochondrial Donation Law Reform, and this was legalised fairly recently, back in March of 2020, and second to the UK. And under Mabe's Law, mitochondrial donation is legalised, but initially this will be done as a clinical trial and then moving forward into clinical practice after the results of the clinical trial became evident. So just summing up and wrapping up that the patient journey to reach a diagnosis may take weeks or even years. And sometimes we don't always find a genetic cause to explain the retinal dystrophy or the optic nerve condition. And it's important that if there is an uninformative result, that patients are encouraged to return to clinic, as we've seen that over the last few years that genetic technology has improved quite vastly. Multidisciplinary team approach, which is one of the our presenter earlier mentioned, teamwork is essential, particularly with these rare but sometimes very complex conditions, and phenotyping is crucial to understand if the genetic results do fit with the clinical phenotype, particularly also if there's any variations of unknown significance. Genetic counselling is essential from a therapeutic with the RP65 Luxturna that's just been approved, and the ongoing work with clinical trials, and also the family planning discussions. So thank you all for listening, and I'll be pleased to take any question or comments at the end of the session. Thank you.
Thank you, Lisa. So we'll take the questions at the end. And we are back to Sandra, and quick introduction of her. We did a detailed one earlier. So her passion is retinoblastoma, and she's at the Eye Centre, Melbourne, Australia. Over to Sandra. You're on mute, Sandra.
I can't see my slides.
Yeah, we could see your slides. So you
But I can't see them.
Oh.
Okay, I'll just wing it. Okie doke. All right, well, thank you again for the opportunity to present at your meeting today, and I'll be focusing on screening and surveillance of retinoblastoma. And as I said earlier, although I'm clinically trained as an orthoptist, so an eye care provider, it's been my privilege to be the RB care coordinator in my state in Victoria for the last 30 years, supporting children and families through diagnosis, treatment and survivorship. Next slide. This is the human face of retinoblastoma. It is more than an... Next slide.
Just a minute. The videographer, can you actually focus on the screen so that Sandra will be able to see it?
That would be very helpful. Thank you. Perfect.
Okay.
Perfect. Thank you. So could I have the previous slide, please? Thank you. This is the human face of retinoblastoma, and it's more than an intraocular malignancy. It irreversibly impacts the individual and their family, and genetic counsellors are integral to the care team. So it's really important that you understand the disease. Today, I'm going to briefly share an overview of RB with you, the history of gene discovery, how this is translated from the bench to bedside, and some challenges. Next slide. Next slide. Thank you. Although rare, retinoblastoma is the, no, back one, please. Although rare, retinoblastoma is the most common intraocular malignancy in children under the age of 5 years. It occurs in one or both eyes, and tumours develop in a centrifugal pattern in the maturing retinoblasts, with a diagnosis of trilateral RB when pineoblastoma develops in the presence of unilateral or bilateral ocular disease. Next slide. There are both early and late presenting signs with leukocoria, strabismus and family history, generally conferring a good prognosis with treatment, whilst a child presenting with late diagnosis, late signs of disease, have a significantly poorer prognosis. Next slide. 60% of children will have unilateral disease, 15% of whom will have a heritable germline mutation. 40% of children with bilateral disease will almost certainly have a heritable germline mutation, although this is only identified in approximately 95% of patients. The work of Rushlow and colleagues confirmed MICAN amplifications as a further cause for retinoblastoma in the presence of two normally functioning RB1 genes, although the phenotype is quite specific with a very, very early onset of aggressive disease, remembering that RB caused by MICAN amplification is not heritable. Next slide. The primary and ultimate goal of treatment is to save the child's life, then their eye and then their sight. And there are multiple treatment modalities that can achieve this goal. However, the choice of treatment is determined by several clinical factors and staging of disease. Next slide. Although, next slide. Although classification and staging systems have evolved over time as treatment modalities changed, there is an increasingly universal trend to move towards using the AJCC cancer staging system, which uniquely and for the very first time for cancer includes heritability status as well. Next slide. But certainly in terms of survival, RB is hailed as a great success story where with timely diagnosis and treatment, it is the most survivable of all paediatric cancers. However, significant disparities in survival rates between high income and low middle income countries continue to exist. Next slide. Since the year 2000, with an increasing focus on awareness and early diagnosis, Indian children decreasingly present with signs of extraocular disease, where with treatment confers a more favourable prognosis for survival, which is really important when we come to advising and counselling on for survivors and the likelihood of their children developing a similar condition. Next slide. And again, next slide. With thanks to Alfred Hudson's work in the 70s, the distinction between heritable and non-heritable RB was made. Next slide. And for many decades, Bayesian risk analysis justified regular examinations under anaesthetic for all children with any family history of retinoblastoma, so siblings and offspring, decreasing in frequency with increasing age in an effort to detect tumours at a stage that was amenable to globe and vision-sparing treatment. The premise being that whilst we cannot control where in the eye the tumours arise, we can actually try and control when they are diagnosed and actively treat downstage disease. Next slide. The efforts to intensively screen children with a family history so invasively with RB are rewarded with an increased likelihood of certainly saving their life, and of course also salvaging the eye because of the extent of disease being much less when they're diagnosed. Next slide. And around the same time of Knudson's discoveries, the association between retinoblastoma and deletions on the 13q chromosome was also identified. Next slide. Which soon led to the discovery of the RB1 gene, which was the first tumour suppressor gene in the mid-1980s. But what's more important is how quickly this translated to the clinical setting, forever changing the treatment landscape for survivors with retinoblastoma. This enhanced their care because it informed the necessity for routine screening for themselves and also for any at-risk infants. Next slide. Genetic testing, in theory, is fairly straightforward. Ideally, we have fresh tumour tissue following enucleation if that's the treatment that's been used, and peripheral blood is then screened to determine the presence or absence of a germline mutation, and then we proceed to cascade screening. Advanced. Next slide. And more recently, there is the emerging potential for aqueous humour to be used as a liquid biopsy. Once validated, this technology could very much enhance genetic testing for children with unilateral RB when the eye is conserved and no tumour tissue is actually available. Next slide. Next slide. Now I'd like to highlight the advances in screening and testing over 3 generations in a family that I've looked after. The proband was diagnosed at 2 years of age. Retinoblastoma, we can all admit, is far too rare to justify population-based screening. So he presented symptomatically. Unfortunately, he required bilateral enucleation. Next slide. Unaware of the heritability of RB, including the medical teams that cared for both blind parents during the pregnancy. His first child had leukocoria, which was not detected until the child was admitted to hospital for another condition altogether at 6 months of age, and she was treated with a primary enucleation. Still on the cusp of the genetic testing era, his second child was screened from birth and diagnosed and treated for bilateral RB. One eye required enucleation due to vitreous disease, as this was prior to the now very frequent and widespread use of intravitreal chemotherapy. By the time he had his third child, though, the familial mutation had been determined, and this child was discharged from any screening at all because it had been demonstrated that this child did not inherit the familial mutation. Next slide. Fast forward another decade, and his daughter utilised prenatal genetic testing to inform her own pregnancy. And given the positive result for this baby, it provided the young family time to process the likelihood that this child would develop retinoblastoma, and that the treatments that we could use to treat the disease, as well as the frequency of travel that would be required to our centre because they did not live in Victoria. Next slide. Following our protocol, the baby was induced at 38 weeks and examined awake post-delivery. No tumours were visible on the fundus. She was then reviewed with an examination under anaesthetic at 39 weeks gestational age, and the fundus exam was again normal. However, optical coherence tomography identified an intraretinal tumour sufficiently distant from the fovea, so we were able to laser it. Next slide. Unfortunately, our Canadian colleagues published a similar experience that very same week. So it wasn't the newest thing, but it was very exciting to know that we could actually use this technology to look for tumours that remained nascent. With our ongoing treatment for the tumours in this little girl, as they arose, she has retained both eyes with excellent vision and demonstrating quite clearly that screening and technology together resulted in a significantly different outcome than those of her family members from previous generations. Next slide. Genetic testing can obviously inform screening and reproductive options. Provided the germline mutation is known, a parent can elect to undergo prenatal screening. If the developing fetus is negative, no surveillance is required and they are discharged from our care until the next pregnancy. If the developing fetus is found to carry the familial mutation and the parents elect to continue with the pregnancy, our current local protocol is to undertake serial fetal ultrasounds, followed by a fetal MRI around about 35 to 36 weeks, and then regular monthly screening with examination under anaesthetic for at least the first 12 months, and then we decrease the frequency so that we can treat tumours as they develop. If the family, however, elect not to undergo prenatal testing, which is more than often the case, the pregnancy is managed as if the fetus is positive until predictive testing post-delivery can determine their screening pathway, so either discharge or following the path of a child with positive for the familial mutation. Next slide. And here's a clinical example we published some years ago where for the first time retinoblastoma was identified on screening fetal MRI in a high-risk fetus. The familial mutation was known and prenatal testing confirmed the fetus also carried the same mutation. Fetal MRI was undertaken at 35 weeks and upon identification of tumours in both eyes, the baby was delivered the following day. Next slide. When we examined this baby at 2 hours of age, the presence of these tumours was confirmed and seen in both eyes. You can see them here on the slide indicated by the arrow. But please note that the appearance of very, very early retinoblastoma looks very different to the images that you would be used to seeing in textbooks. Next slide. You will, of course, also be familiar with the use of prenatal or rather pre-implantation genetic testing and IVF that Lisa alluded to and Amy as well to achieve an unaffected pregnancy. However, this approach is a very personal decision. And although it's been shown that it is more cost effective to fund PGT and IVF than treat a child with retinoblastoma, accessibility and affordability around the world does vary quite significantly. Next slide. It's also important to remember the retinoblastoma journey doesn't end at 5 years of age or once disease is brought under control. It is lifelong. This is particularly the case for patients with germline mutations who remain at an increased lifelong risk of developing second primary cancers. In time, I hope genetic testing may further stratify their risk and inform the intensity of screening that's required. Also, treatment modalities are changing and with the less reliance on radiation and an increased use of intra-arterial chemotherapy, thereby the systemic morbidity is significantly reduced. We don't yet know what patients being treated today, we don't yet know what their risk of second primary cancers is going to be. It may actually be quite different. Next slide. So although the advent of genetic testing has certainly changed the treatment landscape, some challenges still remain. Next slide. Firstly, the advent of genetic testing has certainly changed, is not always fully informative. We may not have tumour tissue either because the eye is being conserved or insufficient DNA can be extracted from old pathology blocks, and that is if the pathology block can be found. No mutations are found in tumour, whether it's fresh or preserved, or no mutations are found in peripheral blood when we expect to find them. Currently, we routinely re-refer our patients to back to genetics for genetic testing if it was done more than 5 or 10 years previously. Next slide. It's also important to remember that children with germline mutations will not always present earlier, nor should laterality be treated as a surrogate for the likelihood of heritability. Next slide. As an example, I'd like to present this case that we cared for in our centre some years ago now. This 5-year-old presented with a 2-month history of intermittent strabismus. There was no family history of retinoblastoma or enucleations in children for unknown reasons. But mum did have a thyroid carcinoma some years previously, and she was treated successfully for that. This child here was diagnosed with unilateral RB, and we elected together with the parents to undertake conservative treatment, and she responded very well to this. Next slide. And so as part of our protocol, we sent her peripheral blood off for genetic testing, in part expecting to find no mutations. But in fact, what happened, next slide, was that the proband was found to carry a germline RB1 mutation, and cascade screening demonstrated that the mother was mosaic for not 1 but 2 mutations, 1 pathogenic and 1 was a VUS. Older sibling who had been examined and was unaffected also tested positive for the germline pathogenic mutation, and the younger sibling had inherited the VUS. So this posed very significant issues with regards to information and counselling for this entire family in terms of risk. And notwithstanding the younger baby that the parents were very anxious about, because it was difficult for them to understand what a VUS actually meant, and having had the experience of their child, the other child having been diagnosed with disease and requiring quite intensive treatment. Next slide. Also, more is being understood about mosaicism, and with newer testing technologies, it's being identified on repeat genetic testing. However, with mosaicism, it can be difficult to interpret the risk of retinoblastoma occurring in the individual, or even developing second primary cancers when they grow through into adulthood. Next slide. And of course, low penetrance of disease can be particularly challenging when families no longer see the presence of the disease in their family members. Convincing them to submit their child to invasive screening with examinations under anaesthetic can become quite challenging, and it would be indeed an absolute tragedy if a child with a family history of retinoblastoma did not benefit from early ocular screening. As clinicians, though, I think it is essential that we guide them through balancing and understanding the risks of screening against not screening. Next slide. Because genetic testing has been available after many years, survivors were initially treated, there is a responsibility for clinicians and genetic counsellors to offer this testing. This particular study, which is currently in press, that I conducted with collaborators in Denmark, we explored survivor uptake of genetic testing that had not been previously tested. And what was interesting is that we identified a much higher number of germline mutations in unilaterally affected survivors than we would normally expect. It would normally be around about 10 to 15%. A further interesting finding in this study is that the survivors were in fact grateful that they were retrospectively contacted and provided an opportunity to better understand their risks, not just for themselves, but also for their future offspring. Next slide. So in closing, retinoblastoma is a prime example of how genetic counselling and testing can transform clinical management. Recognise that genetic testing can take many months, during which time any at-risk infants should be screened in the traditional way with examinations under anaesthetic, or at the very least clinical testing, that they can, until they can be confidently discharged from screening. And also to recognise that genetic testing, if unavailable or not fully informative, careful genetic counselling and ocular screening can certainly significantly impact on outcomes. Thank you very much for your attention. Please don't hesitate to contact me with any questions or queries that you might have, and apologies for the technological glitches. Thank you.
Thank you, Sandra. We move on to the next presentation. So we have Hannah from London, Britain. And Hannah is a genetic counselor at the Moorfields Eye Hospital in Britain. And she's done her MSc Genetics and Genomic Counseling at the Cardiff and Genetic Counseling training at Sheffield Children's Hospital. And her bachelor's degree is also in genetics from Cardiff. Her interests are in inherited retinal diseases, medical ethics, and psychiatric genetic counseling and mental health. Her career highlights are that she is educating the wider healthcare workforce on clinical application of genetics and working on a project looking at patient experiences of virtual ophthalmic genetics appointment. Over to Hannah.
Hi, thank you so much for having me. Should I be seeing the slides or should I share my own slides? Oh, hello.
I shared my slides and then you can advance them and hopefully that would work.
Yeah, we could see your slides.
Brilliant. So thank you so much for having me. So my name's Hannah. So what I was going to talk about today is just about technology and the role that it's played in genetic counselling for patients with inherited eye diseases. So we've gone through my background, but so I trained in general genetics and I've now specialised in inherited retinal disease. This is just my email address in case anyone has any questions. So the first thing I just wanted to touch on was whole genome sequencing for inherited retinal disease. So within the UK, what we're now offering for all patients with inherited retinal disease as a baseline test is whole genome sequencing. So this has actually changed relatively recently. So in October 2021, this was when it first came into play as a clinical test. Prior to this, we've been doing panel testing for all of our retinal patients. And this was, well, the most recent test was looking at about 200 genes associated with retinal disease. So since then, we've switched to whole genome sequencing, and that had been used prior to October for other conditions on the NHS. And it's just worth saying that we do still offer panel testing for some other conditions. So albinism is still a panel test, optic neuropathies, and Stickler syndrome, amongst others. And just below this, I've just put a little table, which is just from our national test directory. So this is the kind of the directory of tests that we offer for all genetic conditions across the UK. And as you can see, so whole genome sequencing has been offered now for cataracts, retinal disorders, and structural eye disease, whereas everything else remains under a panel test. So with whole genome sequencing coming into play as a clinical test, there's obviously been a lot of changes to our practice and to the lab as well. And I was just going to talk a bit about some of the benefits and some of the considerations that we've had to make when introducing this, particularly when counselling patients. In terms of the benefits, so the key thing really is what we're hoping to achieve is a higher diagnostic yield. Now I say hoping because this is still relatively new for us. Our turnaround time for test results is about 4 to 6 months. So the first results from whole genome started coming back about kind of February, March time this year. So we're only now starting to see kind of results coming in. But what we're hoping is that we're actually going to pick up more genetic diagnoses than we were previously. And in a second, I'll just go over a case of where this has happened. Now, there's a number of reasons why this is the case. So firstly, what we're trying to do where possible is just to recruit all patients as a trio. So that's with both parents. Now, recognizing this isn't always possible, so parents might be deceased or they might not be in contact with parents. A trio is preferred, but then we do also recruit with just one parent or just the patient on their own as well. Although what we say is that the likelihood that we find the cause is perhaps slightly lower where we're recruiting just one patient. That's because particularly in a lot of our patients that we see where they are a simplex case, so there's no family history of retinal disease, what we expect is that this has been inherited in a recessive way. So the difficulty is that when we're not recruiting parents, if we were to find, for example, 2 rare VUSs in a certain retinal gene, we're not able to then look at the parents and test them to confirm whether or not they're in cis or in trans. So just having those parents really kind of makes this testing better. The higher diagnostic yield also partly comes from the fact that we can then pick up intronic variants as well. So previous testing, so the testing we just offered just before this was exome sequencing. So we didn't pick up a lot of intronic variants. And also just coverage of genes that have been missed by previous panels. So as I said, it was about 200 genes on the previous panel. This is constantly changing. So before that, it had been 176 genes. So with whole genome, we're hoping that there's kind of other genes that we might pick up. And also, as we're kind of newly discovering or newly learning about new genes that can cause these conditions, it means we're then able to kind of go back and reanalyze the data because it's all there. Also, what we're hoping going forward is that if a patient were to then develop another genetic condition, or for example, were to have breast cancer with a family history of breast cancer in the future, what we're hoping is that their whole genome data will be available for other clinicians as well. Now, how this is going to happen in practice, we don't really know. But we're hoping that this is going to be the case because all of that data for their whole genome is stored within the NHS, our healthcare system. So what we're hoping is that that should be accessible to any clinician with the patient's permission. And this should hopefully mean that any future testing they need, that's going to be done a lot quicker, which might have implications for kind of their treatment and management. And also it's going to be a lower cost to the NHS in the long run. So although whole genome sequencing is perhaps more expensive than some testing we'd offered previously, in the long run, this could benefit us. So just wanted to run through a quick case study. So this was a 36-year-old man I saw this year. He was diagnosed with retinitis pigmentosa within the last kind of 5 years or so. Now, retinitis pigmentosa, it's a retinal condition which one of the first symptoms is generally night vision problems. So you'll speak to a patient and they'll report that, you know, when they go to the cinema, they perhaps struggle and they'll find themselves stumbling or not being able to find their seat. And one of the later symptoms they get is loss of peripheral vision as well. It's a relatively variable condition. So we see patients, you know, in kind of their 60s who present for the first time, but equally we see patients who are affected from a very young age and then lose a lot of vision. Now, this patient, as I said, he was diagnosed with this condition within the last 5 years, and he'd had problems with his night vision since his teenage years. He was generally fit and well otherwise. He had some cognitive impairment, so he told us that he had gone to a specialist school later in life. But yeah, otherwise he didn't report any health problems. The pedigree is on the right. So he was an only child. He's got one daughter who's, I believe, about 5 or 6. She hasn't got any kind of vision problems or any other health problems. His mum died in her 60s, unknown cause, and there's no family history on the mum's side of the family. His dad's still alive in his 60s, but he hasn't got any contact with him or the extended family on that side because they live abroad. And we'd previously offered a panel test. So we'd looked at 176 genes associated with retinal conditions, and this had come back negative. I think we found a VUS in one recessive gene, but otherwise nothing else. So what I did at the end of last year, so I recruited him for whole genome sequencing. Now, this was the first case that I'd seen where we'd previously organised other testing, which was negative, and then whole genome sequencing managed to solve it. All of the rest of the cases I've recruited with previous testing have come back negative as well. So I just thought I'd share this case just as an example of how the diagnostic yield can be increased. Now, that's for a very specific reason, because what we found in the results was that he's actually got a mitochondrial variant in a gene called MT-ATP6 at a level of 88% heteroplasmy in the blood that we took. So this condition, so this gene is associated with a condition called NARP. So that stands for neuropathy, ataxia, and retinitis pigmentosa. So it also causes some cognitive impairment in some patients. So again, it's a very variable condition. And so this finding, a likely pathogenic variant, explains both the patient's RP and his cognitive impairment. When we went back to the patient, he had been diagnosed with something else, but he wasn't sure what. He mentioned something like cerebral palsy, but he was unsure. So what we were able to do in light of this finding is just to refer him on to a neurology team, just to investigate anything else that might be going on. For the patient, it also confirmed that his daughter won't inherit the condition because it's a mitochondrial condition, so it's maternally inherited. We suggested that if there were anyone on the maternal side of the family with any kind of vision problems, that they get a referral as well, but he wasn't aware of anyone. Now, the reason this was missed, so there was actually a presentation relatively recently in the UK where they were talking about diagnosis rates and how we're notoriously bad at picking up mitochondrial disease. Now, this condition, it's something we've only got a handful of patients with at Moorfields, and we see thousands of patients. So because of this, we don't really recognize it very easily. And so there is a mitochondrial test that we could have done that would have picked this up, but we just hadn't thought to actually request this test because it's so rare that just didn't even cross our minds, to be honest, whereas whole genome was able to pick this up. And now we've actually found a second patient with this through whole genome. So it's possible that this is something that's perhaps not as rare as we thought in our patients, but it's something that we're just not testing for. So hopefully with whole genome, we're going to pick up more and more of these patients. In terms of whole genome sequencing in general, so there's a few things that we just need to consider, particularly when kind of consenting patients. So the first thing is just additional findings. So when we're doing panel tests, what we generally say is that, there's always a chance that we could pick up something unexpected. So for example, we know sometimes eye conditions can be syndromic. So sometimes hearing loss can be associated with retinal disease or kidney problems. So we were consenting patients on this. Now, with whole genome sequencing, what we then have to consider is the potential to find other things. So how this is going to work with our testing, we don't fully know yet. It's still being discussed. Now, the American College of Medical Genetics have their list of 80 or so genes that they recommend should be screened for when you're doing whole genome sequencing. And those are conditions, such as hereditary cancers where you can offer screening or management. At present, we haven't been told that we're going to be looking at a list such as that. So we're still looking at how this is going to work. Now, the consent form that we have just has this line in it. So the results of my tests may reveal unexpected results that are not related to why I'm having this test. These may be found by chance, and I may need further tests or investigations to understand their significance. So this is relatively vague, so it's open to us to kind of discuss it with the patient. Now, generally, I'd say patients are okay with this. Most people are kind of have that thought that, if you can find something that might have implications for my health, that's great, and it means that you can offer me testing and things like that. So that would be the majority of patients I see, I would say. But we do have patients who are concerned, and we have patients who are asking, what could you pick up? And it's very difficult because of the way the lab are doing things to actually answer that question. It's not that they've offered, we're going to look at this list of genes. What they've said is that just during the testing, we could pick up things. So if we're recruiting as a trio, if we find a de novo variant, they'll analyze that and they'll report it. Equally, if they're doing the testing and a BRCA variant is flagged up, they'll report on that as well, but they're not actively looking for it. Now, I'm yet to have a patient decline whole genome sequencing because of this, but I'm sure at some point it will happen. And the difficulty is that whole genome is the only option, really. So this is as I said, kind of the test that we're offering for patients with inherited retinal disease. We are occasionally doing some private tests. We as a department then have to pay for it, whereas this is funded from within the NHS. Particularly where, perhaps there's a clinical trial or there's an urgent need for the results to come back, because it's generally a lot quicker to do the private tests. So whether or not that's something we could offer patients going forwards, I'm not sure, but we'll just kind of wait and see. The other thing that we're offering patients is the opportunity to be involved in research as well. So we have a whole part to the consent form all about the research. So essentially every patient we offer this to is invited to join the National Genomic Research Library. So this is all run by the NHS, but essentially what they're doing is building up a database of patients' genome data. So the idea of this is that patients can opt in or opt out, and their data will be shared onto this database, all anonymously. But this can be accessed by kind of researchers and healthcare professionals who are approved by the NHS. So although it's generally kind of to help research, there are potentially some benefits to the patient in that if the whole genome data comes back negative initially and they've opted into this research study, it does mean that researchers are able to look at their data, and it's possible that they could then identify a genetic cause for the patient's condition. And we as a department, because we work through research as well, we will have access to this data, and we'll be able to then go in and interrogate the data and see if we can find anything too. I'd say probably at least 90% of patients are opting into this research study, but there are people who are concerned, mostly about kind of the use of their data, and they don't really trust it. So we do get people opt out of this as well. Now, just something else I wanted to touch on was just research and trials and treatments. So why do patients have genetic testing, first of all? So, I mean, I'm sure this is going to be similar to a lot of genetic counselors, what they hear in their clinics, regardless of whether it's retinal disease. The first reason, is there any treatment? So I'll talk about this in a moment, kind of the treatments available for these conditions. But understandably, this is kind of one of the main concerns of patients, because they're experiencing generally progressive visual loss, and they're obviously worried about the future. Are they going to lose more vision? Are they going to lose all of their vision? And they want to know, can this be stopped or can this be reversed? Second reason, one we'll experience, so will this affect my children and other family members? So knowing a genetic result means we can tell them what the risk is likely to be of passing this on, or siblings, for example, being affected. Patients also want to know more about their condition. Now, even if there is no treatment, patients like to have a name to their condition, or they like to know specifically what's causing it. This can also benefit them in that sometimes it gives the doctors more information about, what their condition is like to look like going forwards, because we see lots of patients with these conditions. And if we know what's causing their condition, it means we can, we've got an idea of what their specific condition looks like based on kind of other patients that we see. And some of these conditions are stable and some are progressive, so it can also tell us about that. And finally, can I get involved in any research or clinical trials? So particularly where there is no treatment, there is a lot of research and clinical trials going on at the moment, both here at Moorfield and around the world for these conditions. And a lot of patients want to get involved either for their own benefit, because in case, it were to become a treatment, or just to help others, and it's something we see a lot. Now, to date, there's only one treatment for an inherited retinal disease, and this is a gene therapy known as Lux-Turner, and it is actually funded by the NHS. Now, this is for a condition known as LCA, Leber's congenital amaurosis, and it's due to a gene called RPE65. This is a recessive condition. Generally affects children at a very young age and causes them to lose significant vision kind of by the time they're young adults. So the fact that we now have a treatment for this is absolutely brilliant. And it's just worth saying that this treatment aims to stop progression of the condition. So rather than reverse any vision that's been lost, it's stopping it from getting worse. So generally, this is something that's going to benefit kind of young people more often. And this gene it's actually been added to the American colleges guidelines of things that should be screened for as additional findings now because of the presence of a treatment. If you're offering whole genome sequencing to a very young child and you pick up a homozygous RPE65 pathogenic variant, you can then get in there and offer them this treatment as early as possible. So this was approved on the NHS by NICE in 2019. So NICE is the National Institute of Clinical Excellence. So they're the people who approve any kind of drugs or anything on the NHS. So in September 2019, there were a number of articles that went out in the news. So this is from the BBC, and explaining, that there was this gene therapy for rare eye disease. Now, what we noticed immediately after this is that we had a massive increase in the number of patients seeking referrals. So we were getting lots of calls to the department, patients saying, can I get this treatment? And we were also getting lots of referrals of patients who were going to their GP who had a long-standing diagnosis of a retinal disease, maybe hadn't been seeing ophthalmology, but they'd read about this and they want to get a referral. So we were offering more genetic testing because we were getting more referrals in from people who previously said, they didn't really care about genetic testing because it didn't change anything for them, or people who weren't aware of genetic testing because maybe they'd had the diagnosis for so long. And what was really difficult is just kind of trying to manage these patients' expectations. So understandably, they'd read this and they'd gotten excited. They thought, there's a treatment for my condition. When actually, this is a very rare disorder. It was estimated probably about 80, 90 people in the UK are affected with this condition, or were going to be eligible for this treatment. And it's quite easy for us to see a patient, have their images taken and tell them immediately whether or not this is something that impacts them. Because if you're seeing someone in their 60s who still has some vision, it's unlikely to be this because it's quite a severe condition. And equally, you can tell kind of by looking at the back of your eye whether or not this is likely to be something that could impact them. Also, even where a patient does have this condition, there's no guarantee they'd actually be eligible for the treatment. So I saw a patient recently in his, I think, early 40s, very poor vision. I think it was kind of hand movements only, so he could only see hand movements. And he had genetic testing, and we found 2 variants in RPE65. But actually, based on kind of current guidelines, he wouldn't actually be eligible for this testing, just based on the severity of his condition. and the fact that there's unlikely to be any benefit for him to actually having this test. So at the moment, they're focusing on kind of the younger patients. So again, it's kind of managing expectations.
We're in the last couple of minutes of your presentation slot.
Perfect, thank you. So it's managing those expectations. And also there's just other clinical trials as well. So this is just a selection of a few that I picked out. So Stargardt disease, it's the most common disease that we see in our clinic. There's a number of different clinical trials, and this is one of the phase 3 ones. Phase 3 trial for X-linked RP, and a condition called achromatopsia as well. So there's a lot going on. And a lot of the time patients are pursuing genetic testing so that they can take part in these trials. And yeah, we are recruiting patients to these. So in summary, improvements in tech and research are helping us diagnose more and more patients. Patients are encouraged by the news of treatments and trials, but there is a real need to kind of manage their expectations. So this is kind of balancing hope versus false hope. Giving them the hope that there might be something available in the future, but not not letting them be so kind of consumed by this, that I'm thinking that, there's going to be a treatment in 6 months or so, because that's unlikely to be the case. Thank you for listening. So I'm happy to take any questions from anyone in the audience. Thank you.
Thank you, Hannah. We are now moving on to the questions and comments section. So it's open now. Yes, go ahead with questions. So we have members from the audience asking the questions. You have to say to whom you're directing it to.
Yeah, my question is, can I measure its serum level of a gene?
Can you repeat the question? You have to speak onto the mic, please.
My question is, can I measure the serum level of a gene?
Sorry, we are unable to understand your question. Your question is
can I measure the serum level of a gene?
Okay, so your question is about whether we can measure the gene
serum or plasma level of a gene
in the serum.
Yes, serum or plasma.
Or plasma, but basically a gene becomes a protein, and the protein can be measured. Okay, but generally they don't do that for in genetic counseling.
No, this is the test. I am talking about the test. Can I measure? Suppose I work on ovarian cancer. I measure the serum level of gene, and it was a better result with respect to the expression of WT1 gene in ovarian cancer.
You're talking about cell.
There was no correlation.
No, you're talking about cell-free DNA. Is that?
No, gene serum level, because WT1, there is ELISA tests available for WT1 gene.
Yeah.
For all genes, even if you see BRCA mutation for BRCA gene, there is ELISA test available.
Sure, I think I'll talk to you after this session. What? Yeah.
Okay.
Yeah. Thank you. Anybody else?
Yes, there are some audience questions. So this one is directed to Dr. Guy. Is genetic testing performed for high myopia routinely? And if so, what is the objective?
Thank you. Thank you for the very interesting question. So in Hong Kong, the genetic testing for high myopia is not a routine. So, but now we are recruiting, as one of our speakers mentioned just now, that we are performing the trio sequencing because high myopia, there's not many known disease-causing genes for now. So we are still in the research stage for now, but not a genetic testing yet. Yeah, thank you.
Thank you. The next question is for Amy and Hannah, so we could get perspective from 2 different countries about it. Would you talk about the prognosis of a chronic progressive eye condition at the first session? Of course, it does depend on how much background the patient coming into the session already has, whether they already know about the diagnosis or not. But in the Indian context, we actually lose a lot of patients to follow up. So there's this pressure of fitting in as much information in the first session itself without overwhelming the patient. So how do you balance that, say for RP?
Hannah, would you like to go first? Or do you want me to go?
I don't mind. I can go first if you want.
Sure, yeah, that's fine.
We also have the problem occasionally where we do lose patients to follow up. Always going to be an issue, I think. Generally, we try and see patients every year, every 18 months or so. Now, what we do talk to them about kind of progression going forward and things like that, and particularly kind of whether or not their condition is likely to be one that's stable or progressive. Now, often patients, I would say, have that question of, what will it look like in 5 years? What will it look like in 10 years? Am I going to go blind? And the problem with a lot of these conditions, so like RP, it's very difficult for us to answer that question. And so we're kind of reiterating, it's most helpful to see you in kind of 2 years' time, and then we can see how it's progressed in that time, and that can give us kind of a ballpark of what's like to look like going forwards. So that's kind of probably as much detail as we'd go into kind of at the first appointment in terms of progression.
Yeah, similar to what Hannah and her team discussed, it's very similar on our end. I mean, I think there are times where I've maybe shared too much, where I say that, talking about, vision loss, which again, we cannot predict, and we're not able to for RP, for cone rod dystrophy, for any of those. We don't know what someone's end vision is going to look like, in 10 years, 20 years, end of life. And there was a teen recently that I was talking to who was very early, picked up kind of like she had some fluid in her retina, and we did a big clinical exam and we're like, we don't know if we would have tested you, but she had 2 pathogenic variants that segregated in trans, and like she was, as an American teen, kind of reserved with her parents. And so I was like, oh, are you worried about like losing your vision? And so I started talking about, well, like there's so many things, like there's public transit, we have guide dogs, there's there's tech, and she like just broke down. And I was like, oh no, like I was like, they, I think, will come back, but I also don't know. And so there's always that part of, I'm okay being the person who kind of gives that bad news of, this is something that at this time we don't have a therapy for. Our understanding is that this is often a progressive disease. Don't know how common or what that rate is. And like Hannah was saying, we often say, if you come, like, not just, but like in a year or two, we'll be able to kind of plot points and say, okay, this is how much has changed, this is how much hasn't changed. We cannot draw any, definitive like future path as to what those 2 time points say, but this is generally speaking what we might expect. And it's a moving target, and it's a really, I mean, we deal with a lot of ifs-thens in genetics and a lot of uncertainty. And I think, so we're comfortable with that uncomfortableness. But yeah, the losing patients to follow up, especially like when you have a genetic test result, or if you can't get a hold of them, I feel like I do share that. And it is a lot just in general of a discussion.
Can I just make one extra comment? And this follows on from your talk, Amy, as well, about counselling about blindness, because people, when they hear the term blindness, they fear that it's total black blind, whereas many of these inherited retinal diseases are very slow-moving conditions, and when you're counselling them that it's very slow, it's unlikely that you go total black blind overnight with an IRD. If that happened, it would be maybe something else going on with the eyes as well. And they're a little bit like, okay, it's not going to be completely dark tomorrow kind of thing, just to reassure them a little bit. But from our perspective also is the driving implications as well, making sure that they still meet the standards for driving, and this can be quite worrying for individuals.
Can I just make a comment? There's a very good tool on the Bayer website that actually shows a picture of a vision chart, or you can apply it to the picture of a London bus in a city street, and you can set it for different visual acuity levels. I use it for different reasons in my patients with amblyopia, but I use it to demonstrate what does 6/60 or 2200 vision actually look like, and to understand that concept of blur rather than you're not going to be able to see the bus. You'll see the bus, you just won't be able to read the number on the bus or the writing on the bus. So that may be something that you might find useful in your counselling as well with these individuals. And yes, it is very tricky giving information to someone that you don't have the answers, and you don't really know how they're going to take that information and the uncertainty around that information.
Yes, because I have had a few kids who are, say, 16, 17, and they are going to pick whether they're going to do medicine or what kind of career field to choose. And they're edging towards, like, they're wanting to pick, say, surgery. And do you want them in time enough that, maybe don't pick something that needs so much precision? You would not even if it's not complete vision loss, it just gets tricky in that moment to deviate them away from there, or how to handle that situation. Okay, should we move on to the next question? Yeah. So the next one is first. What percent? The next question is more generic, and everyone can take this up. What percentage of patients get back to you for reproductive counseling?
I can go first because my answer is really short. I have had maybe one in my 2 years get back to me. Most of the people, though, I see are probably 50s and older. So they're done having their children or their kids. So I've had one young couple.
Anna?
Yeah, I'd probably say a similar answer, really. I mean, if I'm seeing a young patient for the first time or the second time to be about results, I'll often have that discussion then anyway, or kind of a general discussion about the fact that, there are reproductive options available. I've worked at Moorfield for 3 years, and I've referred 2 patients for pre-implantation genetic diagnosis. So yeah, it really is a small number of patients that are kind of wanting to have more of a discussion around that, or like wanting to have a referral about that.
From our perspective, we get,
Sandra?
from our perspective, we get quite a number of referrals to discuss different options and to learn about the different options. But then there would be a small number that would go on to the Women's Hospital to then pursue the PGT. We've had a small number, handful of retinal disease, autosomal optic atrophy was another one that used the PGD. And from a LOM perspective, I think there was about 2 couples that looked at gender selection, selecting a female embryo.
From my perspective, I'm not a genetic counsellor, but from my perspective of the retinoblastoma survivors that I look after, there's always a lot of interest around how to prevent retinoblastoma from occurring. Many survivor couples will come and speak with the ophthalmic team, inquiring about what's different in retinoblastoma treatment, and these families are referred on to genetics for genetic counselling and to discuss their reproductive options. That said, I've only overseen 2 successful uses of PGD and IVF to achieve an unaffected pregnancy. The majority of survivors tend to flip the coin, as it were, and if they have an unaffected pregnancy, they'll flip it again. But once they have had a child that is affected with disease and they actually go through the journey of the invasive screening and, as is often the case, the intensive treatment, they don't go back for another baby. In Australia, PGD and IVF is not funded. There are very small subsidies, but it's very costly and certainly out of the reach of many, many people. Unlike in the UK, I believe they get they're eligible for many Mendelian diseases. Is it 3 cycles of PGD funded? In Denmark, it's unlimited. So the decision making for individuals may be certainly impacted by how accessible is this technology to them, and can they, if they have to fund it themselves, can they afford it?
Yeah, it's not funded here in the United States either. It's insurance dependent. So some insurance may cover it, some definitely do not.
Thank you for that perspective from all the different countries. Dr. Guy, please, your opinion as well. What is happening in Hong Kong about this? The reproductive counseling aspect of things with respect to ophthalmic disorders. Yeah.
Yes, in our clinic, about 10 to 20% of young couples, they're coming for counseling for because they're childbearing age, and maybe one of the couples have been suffering from like RP or other eye diseases or genetic diseases. So basically, we provide the genetic consultation based on the pedigree information first. If we can judge that it is due to the disease, maybe recessive, then we just provide in journal the consultation, right, just based on their pedigree. But if the disease are more likely to be dominant or unknown or simplex, so we provide the genetic testing, which is a self-financed item. The government for now, although in Hong Kong, the government are now providing some free service for genome, even for genome sequence, but the waiting time will be an issue. So usually the patient will pay by themselves. And as I mentioned in my talk just now, that we send the DNA to the US, to one lab in the US, so that we have a gene testing. So after we get the results, usually for now about 60% come back to be positive mutation, right? Just like in general, just like the RP, usually now it's 6%. So our number is quite similar to that in the literature. That about 60% they can obtain the positive result, so that we convey the information to them. But RP after all is not I would say, although it's a life-threatening disease, but it's not a life-threatening disease. So we should convey this information to the couples, right? So but the decision will fully or totally at their own discretion. So we will just explain to them the property of this disease. For example, RP, they may have, although currently no cure, but we may screen, or we may have an earlier screen for their kids and have some certain protection for them. But it may not that affect their decision whether to have this child or not, right? So yeah, and of course, if they want, because even though for dominant disease, still is a 50% of chance to have their child having this disease. So the next step may be to test the amniotic fluid, right, for the kids. But for now, we did not perform these tests for now, right? Because we need to refer to the ONG department to work with them to look at this. But for eye diseases, we are not concerning this as a major impact for the couples, right? So for now, we have never referred couples to the ONG department to have the testing in the amniotic fluid. Yeah. Yeah. Thank you.
Yeah. Thanks. So the question about parents coming to you for ophthalmic genetic counseling, where they have precedence of a child with a genetic disorder. And what frequency do you get such kind of patients? So I do get quite a lot of patients where they would like to know the chances for the next child to be affected. And we have also done prenatal diagnosis. As mentioned by many of the faculty, the frequency of that is not that high, because majority of families, they feel that having one child with a vision problem is enough, and they will be able to manage that child, and they don't think about another child. But a small subsection of them do want to have a normal child, and therefore they have come. We have done prenatal diagnosis. We have, in situations, fairy tale situations, not found the mutation in the subsequent child prenatally. But in certain situations, we have come across where the fetus was carrying virtually the same mutation, either in autosomal dominant or autosomal recessive conditions. Okay, X-linked recessive conditions are pretty rare in India, and except for one situation where the child had the chance of having retinitis pigmentosa autosomal dominant type, it had the same allele with that of the affected father, and they went ahead with the pregnancy. So that's something which was a big relief for doing genetic counseling, where the parents don't decide to go for an abortion. But in majority of situations, they do go ahead, particularly with retinoblastoma, a family, a couple of them which have handled where they wanted to go for the second child for prenatal. And so despite saying them that retinoblastoma is one of the cancers which can be managed very well, not only from life point of view, but also from the vision point of view. With early detection, particularly since we know that one child had it, we have actually, in fact, observed them with RETCAM in the theater and found very peripheral tumors, which was taken care of. Okay. But despite all that kind of situations, the choice is, of course, left to the parents what they want to do. And maybe we can just start the panel discussion as well, because we're running short of time. So I would like to raise one point here to all the faculty. See, the problem in ophthalmic genetic counseling is that almost 99.9% of disorders are not lethal. Okay. So children do survive. So abortion is a very tricky area, a dicey area where you feel very guilty as a counselor to suggest options for them. Okay. So I would like to ask that question. Particularly, I would like to start with Amy, because abortion is a hot topic in the US right now with the Roe and Wade Supreme Court judgment. So I would like her to opine upon abortion per se in ophthalmology, particularly ophthalmic genetics. And secondly, how has this judgment changed the scenario for genetic counselors in the US? So two questions to you.
Yeah, it's been a big genetic. It's big in terms of genetics. So I should kind of say, right, we are a tertiary research center, so we actually don't provide a lot of clinical care. So everything we do is research based. So anything, and this is partially why I haven't had a lot of like prenatal discussions with our patients, because we refer them to a prenatal genetic counselor because that's not our specialty. I'm not credentialed to discuss those things at our institution. And so because of the recent Supreme Court rulings, it is now kind of on a state by state basis. And even before that, when Roe v. Wade, which I am not a lawyer, and I'm definitely like I'm still working through this in terms of how I'm talking to patients about it if someone brings it up to me. But even years ago, I remember going to one of the American Genetic Counseling annual conferences and going to a talk for a clinic that did late term abortions, because there are always reasons for families who maybe have a wanted child and they are unable to carry the baby to term. So something that I learned in graduate school was, especially when I was on my prenatal rotation, if you come across a family that has an inherited disease that for whatever reason, right, that family it is decided that is something that their family is not able to manage, because we all know chronic illnesses can weigh heavily on families, on caretakers. Something to share that, if it's helpful for you guys to have the thing as well. The baby was sick the baby didn't make it. And I cannot talk about it right now. And so I think about that phrase a lot because pregnancy is a very delicate situation in a lot of instances, just generally. There's a lot of things that have to go right from just a development standpoint that may or may not be genetic. I'm thinking amniotic bands, right? There's so many other things. And so I don't have an answer. I cannot speak for all genetic counselors, unfortunately, in the United States. I do know, though, that from my friends and colleagues they're all across the country, and that I think that it has made some individuals, right? Again, a lot of women have wanted pregnancies where something has been found on the genetic testing and they are unsure what their next steps are going to be. And so, helping, we're now going to have another hat where we're going to, try and find and do what's best for our patients. And it can be hard if it doesn't align with our own beliefs, but, we're here to, as medical providers, to care for our patients and make sure that they are, getting what the best. I always say we want you to be living your best life. And so, vision loss isn't something that should, we might need to adjust some things, but we want to make sure that, you can do what you need to do. And so I realize that's kind of a pivot from the current topic, but that's, I guess, it's still so new. So yeah, we're trying to sort that out too.
Thank you. And the same question to Hannah. So the abortion in ophthalmic genetic counseling, and secondly, the status in Britain.
Yeah, so I mean, personally, I'm not aware of any patients who have decided to have an abortion based on the status of their pregnancy being affected with one of the conditions we see. But I'm not sure necessarily that we would know about that anyway. I'm not sure necessarily the patient would feel like they wanted to share that with us. I mean, I make patients aware of that option where they want to have that discussion. Now in the UK, they release abortion statistics. They're quite readily available online, and you can have a look and you can filter it by reason and by condition as well. So in the UK, if you're terminating a pregnancy based on a medical reason or the fact that there's a disabling condition for the fetus, it's considered a ground E abortion, and you can read the stats for that. And unfortunately, they group, I think it's eye, ear, face, and neck. But so you can see the number of abortions that have taken place for those groups of conditions per year. And I think I looked at this, and every year for the past decade, it's under 10 abortions that go ahead for those reasons. So it really is a minority of patients who are going ahead with that. But yeah, like I said, we make all patients aware that it is an option for them.
Okay, thank you. So, Sandra, what about retinoblastoma? Yeah, go ahead.
Yeah, so it is a very interesting question. And I have really only had one personal experience with a family where the father was bilaterally affected. The first child had retinoblastoma, enucleated one eye, and the other eye was treated. And then the mother confided in me that she was expecting again. She was 6 weeks pregnant and she was pursuing CVS testing. And she said, if it's positive, I don't want to proceed with the pregnancy. And I said, look, I'll refer you to genetic counselling and all the services that are appropriate for you to access during this decision-making time, which I did. And the testing came back, it was positive, but they proceeded with the pregnancy because the father, who was the proband, said there's nothing wrong with me and there's no reason, this is not justification for a termination, because to terminate that pregnancy is to suggest that my life hasn't been worth living. And that is a single example that I think many people will have that same thinking, irrespective of what the condition is. So apart from that experience, I don't have any other a great experience in that regard. My general feeling is that most families want to just flip that coin and hedge their bets, I think, until they go through that process of treating a child with RB, and then they make very different choices. So it's very interesting how their thinking changes once they've had the lived experience of a child with RB.
Okay, thank you. Yeah, please. Your mic isn't on.
Sorry, that the question directed to me?
Yeah, to Sandra, I think.
Yeah. You were talking about a retinoblastoma person and saying that he felt that was my life not worthwhile, and termination of the pregnancy, which the wife or the spouse wants, would indicate that. But we have come across several couples where either parent or both parents have vision impairment, and they say, what we have gone through, we do not want our child to go through. And that is why they want a child with who does not have any form of visual difficulty. I don't know whether it is because of the lack of support of disability in India, or whether it is what we personally feel that, I've gone through this, and why do I want my child to go through that?
I think it demonstrates the very personal decision making that this represents. And our work with the collaboration I've been involved in with genetic counsellors and geneticists in Denmark addresses this very issue. We did some qualitative research and one-to-one interviews, and a lot of these issues emerged as themes where the decision making is incredibly personal, and where one person feels that, in spite of their treatment, in spite of their vision impairment, they've had a good life. But on the other hand, they wouldn't wish this condition on their own child. So they would do anything to prevent this from occurring in their child. I think it's a question we will never have an answer to. And just remembering that it's a very personal decision that individuals can only make when they've got all the information that they need to make a decision that's right for them, as individuals and as a couple.
Yeah, thank you, Sandra. So yeah, as
Can I have a comment? I
yes,
have two
please
minutes.
go ahead.
Okay, when Dr. Annie said, I exactly agreed to that, because here I am a living example of myopia. I heard childhood myopia, I heard adulthood myopia, but I am a patient of, not patient, a case of progressive myopia. At my 6 years of age, I was -6. Today I'm 62, I'm -22. Eventually, I also didn't want my children to go through what I went through. It was not lethal. I talked to my ophthalmologist. He said there is nothing which we can do. My parents did not have a counselor. I did not have a counselor. But today I am a counselor to my siblings. We are 7 children. Out of that 4, we are bad. My brother died because he committed suicide of blindness. My sister is 60% blind. I am what I am now. And my another sister is still, she's also 60 years old. She's doing good yet. But the same problem, like we didn't have anybody to tell what our children will suffer through. I had thick glasses, then I went to hard lenses, then to semi-soft lenses, then to soft lenses, then I underwent cataract. My number got nullified, so today I'm not wearing any glasses or any lenses, but my vision is limited. And since childhood, that limited vision, I went on studying and I finished PhD. But still, while doing that, we had a social stigma. We had a family stigma. Even my cousins suffered. Everybody had kept us names, and then everybody kept names to our parents also. But my parents' parents, their parents, nobody had any eye problem. So we thought, I'm sorry, I'm getting emotional. We thought it started in our generation. But still today, like there must be so many people like me who are not blind, who are not partially blind, who are not properly sighted. So we have no group of patients also together who can represent such a group also. And even if we have to tell something to the patient, like people like us, we actually have no message to give it to them. So that is what I just wanted to, I kept quiet, but when you said that, my son, I never wanted, but he has glasses of -2, -3. I'm worried when he will become my age. I don't want him to suffer like me. Thank you.
Thank you. That's good. Just extending that point made by one of the audience, let me come to the point which is very important, scientific discovery in myopia, where now you have the atropine treatment. Okay, you can slow down the progress with atropine treatment. So the days are gone when somebody with myopia has to live with it. Okay, I would like Guy to make a comment because he did show a study of their in Hong Kong where they're looking at the progression of myopia with atropine treatment. Maybe you can tell the positive points in that, Guy.
Yes, many thanks, Professor Kumar. So this is an important issue that now in past about 5 years, we in our department we have been doing the clinical trial using low dose atropine in prevention of the myopia progression. So our data basically we have published a series of paper mostly in ophthalmology that we find that the atropine 0.05% of atropine is very effective in retarding the myopia progression by about 67%. That means for those using the low dose atropine 0.05%, they have their myopia progression lower or slower by more than 60%. So this, in the long run, so their chance of getting high myopia, which was less than -6 diopter, will be lowered by even 90% when they're getting in their adulthood. So this will be very important for now. But these are our subjects are mostly they start their atropine treatment. We defined them as a fast progressor when we recruit the children. So usually the fast progressor means they have myopia progress more than -0.5 diopter per year. So we recruit them. So that means that all these children are fast progressor by definition. So, but even though in these children, their progression of myopia can be slower by a quite dramatic percentage. So now we are also working on the prevention, the aspect of prevention myopia onset in those kids who has not yet myopia, but their parents have high myopia. So that these kids have high risk of getting myopia later in their lives. So we are now using the atropine to have a prevention, and our results are quite positive as well. And we are now organizing the article. So hopefully we can get it published soon, so we can share with you more data about the usage of atropine in myopia prevention. Yeah, thank you.
Thank you, guys. So therefore, the take-home message about myopia for all the genetic counselors, online, offline, is that today myopia can be treated. Not only managed with spectacles and other things, but also treated and the progression can be slowed down, particularly with family history of high myopia or malignant myopia. Today, in most of the eye centers in India, this atropine treatment is provided. Okay. So about abortion and eye disorders, Lisa, so you can just go ahead. And complete.
It's very similar to Hannah and Sandra. I haven't had any personal experiences with termination. If patients want to explore those options, we refer them to the Women's Hospital for further discussion. The other point I was going to make is the advances with reproductive genetic testing. So there's now panels that not only just eye genes on the panels, but for a number of genes, muscular atrophy and and other quite more severe and lethal conditions. We do have getting a few more referrals from couples who might be a carrier risk for albinism or some of the common genes, USH2A, ABCA4. But again, we haven't had any couples who elected for termination.
Thank you. So there were two slides which were quite interesting in today's presentation by all the faculty. One was that by Amy, where she put a slide where she showed various possible treatments that are happening in ophthalmic genetics. And she put a list of gene therapy and then cell therapy and biomolecule therapy. Okay. It was a very interesting slide. Now, most of the times when we do genetic counseling in ophthalmology is that the biggest question is when can we be treated? Okay, there's a question most of the patients with visual impairment or blindness would ask. And there was another interesting slide that Hannah put during her talk about the RP65 therapy, which has been taken by the government and under the NICE scheme that every patient in Britain can now avail that. So most of the times what we see is that these therapies are very expensive. It's a bomb that most people cannot actually afford. Okay. So that is the question. I'll again start with Amy, and you can tell that will this become affordable to a common man? All this research and therapy modalities that is currently going on. Amy.
Yeah, I think that's a very fair and important question because, right, if it's not affordable, who's it benefiting, right? That's kind of the point of what we're all trying to do. I would hope that it will become affordable. I know that there are a lot of, I mean, I don't know a lot, right? It's a pharmacy, like the pharmaceutical research. There's so many things that it takes to get a drug to like a therapy even, and then if it's going to be approved. But yeah, it's really important that things are affordable. But I think it's right now, at least in the United States, it's really expensive, and I think some of it's covered, but again, I don't have much familiarity with that, but just given NIH is all government funded, everything that people get on site is covered and free. So I don't know of for those, and I do know of to answer the question in the chat, I have seen someone who had Luxturna when it was still in therapy, but they were older when they received the therapy. Unlike other family members, they have a number of family members also with RP65 LCA, and because he was older, he did not have as much of a benefit compared to his extended relatives who were much younger when they were enrolled in that study. So they were part of the initial therapy trial.
Okay, Hannah.
Yeah, so in terms of funding, so like you pointed out, so it is, I think we're very lucky in the fact that it is funded within the UK. And I know, so I think originally the cost that the pharmaceutical companies said was about $500,000 per eye or something like that. It was very expensive, it's ridiculous. And I think, so the NHS managed to negotiate it, but they never released how much they negotiated it down to. So I don't know how much it costs the NHS. But like I said, it's not many people it does affect. So I'm sure that came into kind of the calculations when they factor that into whether or not they'd fund it. And they also look at, kind of will it benefit, will there be a cost benefit over the whole lifetime of the patient? Because if we're seeing them, every year, it's a cost to the healthcare system. So yeah, and kind of social care as well and things like that. But yeah, like I said, we're very, very lucky. And in terms of answering the question that was in the chat, someone asked, can anyone share cases of successful gene therapy? We have seen a number of patients. So I don't generally see, I don't generally do the pediatric clinic. So that's where a lot of the treated patients are. I've only met one patient who has had the treatment. I think she's about 30 or so. So she's a bit older. than the other patients who've been treated. She told me that she had noticed some improvement in her vision. Now, the aim of this is to stop it getting worse. So I'm not sure if that's just kind of, I don't know, placebo effect or something, or whether there has actually been some benefit. She said kind of in low lighting, she noticed she can see better. But yeah, I don't know.
Yeah, Sandra?
Certainly with retinoblastoma, we published a comparative analysis where we compared the cost of intensive screening, which is what we would normally do for a carrier of a germline mutation, and just figures off the top of my head was about 30,000 Australian dollars to the age of 5. The cost of 3 IVF and PGD cycles was $30,000. So the numbers are there for the bean counters in government that hold the purse strings. As you said, Hannah, the number of people that would access this technology are very, very few. But the cost savings are extraordinary if you're going to look at dollars and cents, and particularly with retinoblastoma, where you're not just looking at the diagnosis and treatment in those first 5 years of life, but the cost of lifelong survivorship care, and then you add on to that diagnosis and treatment of their second primary cancers if they develop them, or the screening and surveillance that they would require so that you diagnose those conditions earlier to improve survival rates. So with retinoblastoma, it's just, I just don't understand why government wouldn't elect to fund PGD and IVF for retinoblastoma specifically, if somebody wanted it.
Thank you. So, Lisa?
So last year, Novartis and the Australian government approved gene therapy or Externa for RP65 in Australia. We have seen one patient in Melbourne who's gone through the therapy. She was a female patient aged in her early 40s. She had treatment on one eye, but declined the second eye as she felt that there was very limited improvement in the vision. And in Sydney, there's been a half dozen patients being treated, but they're of a younger age group. So I'm not completely aware of their prognosis and their thoughts, but I know that they were a younger cohort. And the cost is being picked up by the state government where the therapy is being performed, but also in part from Novartis.
Thank you. So to Guy. So Guy, being in Hong Kong and China, that India and China has many things very common, is that huge population. And secondly, poverty is a major factor, and more so in India than in China right now. So will government, do you think, will play a part, or how can we take it to the government so that some of these treatments can be available to common man? Yes, Guy.
Many thanks, Brother Kumar. So now, as I mentioned in my talk just now, that now we define a lady which over her 60s. She developed her RP symptoms at her 30s, and then now her vision is light perception only. So she just came to us with her daughter. So we did the testing for her, and she did carry 2 mutations in the RP65 gene. You know, since she is at her 60s, and I think that, and also her retina are all atrophic, very diffuse atrophic changes. So we do think that the gene therapy, the Lucentis may not be helpful to her. But I did discuss with Novartis, the representative in Hong Kong, that whether we can lower the price, and also, as you know, in Hong Kong in Hong Kong there's no reported cases treated by Lucentis, right? Even in the kids. So I just talked to them whether we can lower the price. They can lower the price and provide a low price to the patient, which may still provide some hope. But eventually, they did discuss with their headquarter and can provide some lower price. But eventually, the patient did not want that treatment. Although we explained to her that because her age and also the atrophic retina, so eventually she did not have the treatment. But in Hong Kong, I would say the standard for now is a self-financed item. So the patient or the family, even for the kids, they have to pay by themselves. So the government is not yet covering this expense. But in Hong Kong, we have a number of charity foundations. So we can, although I cannot guarantee, but we can seek for different sources of the donation, right? I assume that the family cannot afford, right? So we can look for some donation from the charity organization that they may provide some or a large proportion of the support to the patient or the family, so that we can still have this treatment for the kids. Yeah, but for the long run, I hope that, of course, it will be better for the government to cover the expense, but it's quite expensive. So I'm not that optimistic that the government will cover all the expense. But I would say case by case, or on every case based, so that we can seek for like charity funds for the kids. Yeah.
Okay, thank you. So with that, we come to the end of the ophthalmic genetic counseling session. And I would like to therefore do a small quick round of thanks, particularly for people who are in the background for running this program and making it possible. So I'd like to thank James Fielding Hedman-Sek from the US and Professor Shomi Bhattacharya and Devendra Kumar from Britain and Professor Calvin Pang from Hong Kong and David Mackey from Australia. I'd like to thank the Board of Genetic Counselors of India for giving us this opportunity and making aware of the ophthalmic genetic counseling to the genetic counseling audience in India. And particularly like to thank Dr. Annie Hassan and Dr. Lakshmi for the opportunity. And I'd like to thank the moderators, Ria, and as well as sorry, Indumati for this coordinating the program. And also I'd like to thank all the faculty starting from Amy, Hannah, Sandra, Lisa, as well as Guy for joining today. Despite being a Sunday, we stranded you at your workplace or home. So thank you for the audience finally for giving a good opportunity. Thank you very much. Bye.
Thank you all. Thank you.
Thank you.
We are
Thank you very much.
continuing. Yeah, we are continuing with the program here in India. So we would like to say goodbye to all the international faculty. Thank you.
Okay, thank you.
If we could
Thank
just,
you.
I understand it's very late for so many of you, but if you could just stay back for 5 more minutes, Dr. Lakshmi would like to take over, and she wants to introduce us to someone who would like to speak with us. If the speakers could stay with us as well, that would be amazing. Thank you.
It's optional if you want to stay, but then if you feel that it's too late and then you want to go ahead, the faculty can go ahead with disconnecting. Thank you.
Good morning again. So when we started these sessions for various clinical specialty, there was a thought during the discussion when I was telling Annie and others, let's have one person who can articulate well in English, who's a patient in that particular specialty as such, which will again value add to the genetic counselors of how important their role is. So that is more because I got in touch with Revati, whom you can see now. She's master's in public relations, and she's such a wonderful leader. You won't believe. And during Corona, she got the CM award. She runs a school for special children. And in the record, she's 100% her visibility is not there. But the thing she has achieved It is more because of people around. And during the discussion with her, what I understood was, yes, she was sort of recognized for RP and things. And from small, she was such an active girl and she always used to score well. And she never wanted to say that during evening she was not able to see and all that. And when she was 12, she lost her mother. But still, she was so much, but then she needed more and more help. But when the clinician saw her and all that, yes, it was RP. But again, there was some sort of, she couldn't get back again, and there was not much available. But from her front, she always wanted to do the best. And she would like to speak a few words, after which I have a few thoughts which I want to share with the counselors. Revati?
Good morning, everybody. Thank you for the opportunity to the organizers. Yeah, my name is Revati Mayamai, and yeah, I was diagnosed with retinitis pigmentosa. So my parents knew about it at the age of, when I was at the age of 6, but I didn't know about it till the age of 16. I thought everybody's vision is as good or as bad as mine. And when I came to know at the age of 16, I fought with my ophthalmologist. And I said, you're kidding that, like, there's no treatment available. I'll find my way out. And then I did research, study, everything. And then I was, I took a second opinion with a different ophthalmologist. And genetic counseling, I went in. And they did not insist on testing at that point, 20 years back. And I started fighting life. I started finding new treatments like Ayurvedic treatment, alternate medicine. It helped me survive life. And academically, I started doing well. I started finding my way out. Like, I wanted to do the sciences, but the doctor advised sciences is not advisable. You should go to the humanities. And then I took on that and started working as an assistant professor in a college, and later moved on running my own preschool. But at one point, which could have given me a better quality of life, is like if I had listened to the counseling, right? If it was insisted more 20 years back, my quality of life would have been way better than what it is today. So that's something which, like, I was overwhelmed and I was resigned. I was not listening. I was one of those kids who were like throwing all the tantrums. So that is something which I would, request the medical fraternity here to insist to the patients. Patients, we are unaware. We don't know. We're already overwhelmed. So we just, that's one thing that I would put across to everybody, as, this is an opportunity for me to express myself. And one more is like, we are just looking forward. I'm looking forward to what's available, because 20 years back, there was no solution. And right now I'm looking forward to what's available, for me to have vision back, restore my vision. So thank you so much for the opportunity.
Come here, just sit down. Just sit down. There's a chair. Okay, what I wanted to share with the genetic counselors is, you see, as educated as Revati, when something hits, it's so difficult as a patient to really fight it out. Our education doesn't help there. So I would say, again, with my experience with Dushin, the people who have been very bad with me, throwing reports on my face, have been those who are educated. They cannot take it. I think even the rural ones, they sit to listen, take it from us and understand. But when it comes to the urban and when it comes to education, it becomes much more difficult to accept. So two things I would like to really make to the counselors, the young counselors again, is please follow up on your patients. Don't give up. I wouldn't have met Revati unless I met her in a wonderful forum called Landmark Forum. And you wouldn't believe, I never knew she couldn't see. She's such a leader. And again on Zoom, unless she told, I would have never understood. It is one of the best training and developments I have undergone in 55 years. And she was a leader. And I was just wondering, and then something told me that when I was talking to her one morning, and she told me this. So immediately, as usual, I told Suraj, you need to go and meet her. And we have taken the pedigree and lots of consanguinity there down south. Again, in her family, we have taken the sample and all that. So for me, it really struck. That was the time we were planning for this meeting as such. And I thought for every session, one person who can articulate in English. Yes, we bring in patients who can talk, but still somebody who can really give various perspectives. So one thing is from here, and again from my experience, please follow up. They are not, acceptance comes at various levels for patients and families. And again, to keep in touch, there is something coming up tomorrow, to be with them and tell them we need to be in touch. That is one thing. One other thing is, do maintain a DNA bank. Don't throw it away. For our patients who came in 2008 and 9, till MPCR was negative, MLPA was negative. They had girls in the family, and the boys no more. But now, since we have a DNA bank, since we had the sample, from 2016, we started NGS. We could identify the mutation. And now the girls who are 18 in that family, we could do a carrier testing. If we had just thrown away the DNA, the boys no more, it's so difficult to help the family. So I think these two things I really wanted to share with the counselors. Please follow up. And I think maintaining wherever you are working, maintain in a good database. And you can request and have a social worker or somebody who keeps in touch, and don't give away with your patient. It takes time. It takes time to accept, but keep with them. That is what we as counselors can really do. Yes, we should. So that is the humanity part. That is where that empathy comes there again and again. All of you, wherever possible, have your DNA bank. Anytime you want to have the sample, again to go prick, take is difficult. And sometimes we might not have the proband again. So it will be helpful. Thank you. Thank you for this time again. And thank you, Revati, for making it. Thank you.
Yeah, thank you. So I'd like to give certain points for young genetic counselors in the audience and but also online. I've been doing genetic counseling for the past 35 years. Okay. And let me tell you, I'm fortunate enough to be having a medical degree. So I have seen that side of medical practice and then been doing genetic counseling of late. So there's a big difference in these two fields. Okay, they are some way diametrically opposite. Okay, as a clinician, you should have a closed mind. Okay, you're seeing a patient, making a diagnosis. There is a half a dozen differential diagnosis. You have to pick one to start the treatment. Okay, you can't treat them for all the 6 of them. Okay. Now, on the other hand, genetic counseling, you have to be open-minded. Okay, so and second thing is that in genetic counseling, it's like entering a restaurant and then going and sitting and opening the menu card and looking at what are all that's available in the restaurant. Okay? That's the job of a genetic counselor. We have to tell everything possible. It's not that just because a patient cannot afford, we cannot talk to them about gene therapy. Okay, so we cannot be close-minded. And there is a couple coming to you, and for the people on the outside India, consanguineous marriages are very common in India, particularly this part of the world, southern India. People still get married consanguineously, though that rate is dropping down. So as a counselor, you cannot have a fixed mind and think that, look, autosomal recessive diseases are common, and why are you getting married consanguineously? Okay, you have to have open mind. Today we can do carrier testing in genomics, okay, and we can give them precise counseling and help them with prenatal diagnosis or pre-implantation genetic diagnosis, okay. So having an open mind is very important, and the moment you start your counseling, you have to be in the shoes of the patient. This is very important. Okay, you're not somebody external. You're part of the family, and therefore you have to help. And because we have a lot of contacts, for example, if my patients cannot afford for a genetic testing, then I find a donor. There's so many people who are ready to give money. Okay, India is a poor country with rich people. This is a statement made by Vivekananda. Okay, so the people are ready to give money, provided you do things very correctly and honestly. Okay, so therefore, it's not that we have to verbatim vomit our knowledge to the patient. We have to help them. wherever they find difficulty to get a job or to find a genetic diagnosis money, we can always help. And you can always talk to us. You can talk to Dr. Lakshmi, you can talk to Dr. Hassan. We are all here to help. Okay. So it's a great profession. There's a huge need for genetic counselors across the world because there's so many fields now for in vitro fertilization, pre-implantation genetic. Every place you need a genetic counselor to explain it to the patients. So clinicians are too busy to take this. Okay, it is the counselors who have to take it and be a bridge between the clinicians and the patient and the family. Thank you.
We are coming to the end of the session 4 of day 3. I would like to thank the chairperson, Dr. Govind Swami Kumaravelu, for chairing the session. And I would like to request Dr. Jaya Vyasa to come on to the stage to honor our chairperson. I also request our Dr. Jaya Vyasa to present the certificates to our moderators, Ms. Ria and Indumati. I once again wholeheartedly thank all the eminent speakers, chairperson, moderators for such a wonderful session on genetic counseling in ophthalmology, which had a bit of emotional touch also. Hope you all enjoyed the session. And I also request Dr. Lakshmi BR from MDCRC and Dr. Preeta Shetty to receive the honor for meticulously moderating pre-conference session on genome education and training. I request both of you to come on to the dais to accept the token of appreciation. Thank you, one and all. Please join for the photo session.
I also request the dignitaries to honor Ms. Revati, who has been a real warrior and set an example how to lead, even though we have some God-given gift, but still we can lead a better life even with that too. Yeah, we will join for a photograph. I request even the online speakers, please join. Thank you, Amy, Lisa, Geyser, Sandra, and Hannah. It was wonderful session and also being with us late night, especially Amy. It was very interactive. We learned a lot from you, hoping to have you connected forever and have your expertise in future too. Thank you so much.
Thank you all. Yeah, bye-bye.
Thank you. You're
Thanks
welcome.
again, guys.
Bye.
Thank you.
Thank you. Bye. Bye.
There's an announcement. A book by Dr. Visha Davis is available in the basement. For more details, please contact the registration desk. And fun activity will begin in front of the auditorium. And then please have lunch, assemble back at 2 p.m. for genetic counseling sessions in reproductive medicine. Thank you all.
A common man's understanding about the sexual and reproductive health may involve a large number of myths and truths. A genetic counselor plays an important role in providing an opportunity to understand and learn the skill needed to achieve sexual and reproductive health excellence. Myself, Dr. M.V. Ravishankar from JSS Medical College, from the Department of Anatomy, would like to welcome you back for this session, academic feast organized by Board of Genetic Council of India, that is the 7th National and International Conference, to take over the most expected session of this conference, that is Genetic Counseling in Reproductive Medicine. I call upon Dr. Prachi Modan from Mumbai, Dr. Deepanjana Datta from Kolkata, Senior Genetic Counselors to the stage. Over to you, madam. Thank you.
So good afternoon, everyone. We'll start our post-lunch session. And I would like to call the chairpersons. First, Dr. Parveen Jahan is already here. Let me introduce her. So she's from the Maulana Azad National Urdu University and in genetics department. She has done her PhD from Usmania University, Hyderabad. And her interests are in molecular analysis of immunoregulatory pathways in recurrent pregnancy loss. And she has been given the Best Reviewer Award by the Journal of Advances in Medicine and Medical Research, and member of the Indian Society of Human Genetics, and also given the Best Poster Award at the World Congress on Breast Cancer. So welcome, Dr. Parveen. Yeah. Now I call upon Dr. Jayashree. Yes. So Dr. Jayashree is the Associate Professor and Unit Head, GSS Academy of Higher Education and Research here. And she's a consultant at Spandana Fertility Clinic in Mysore. Among the academics, she has done her MBBS from Mysore Medical College, MS, again, Mysore Medical College, and DNB in OBGY also. Her interests are reproductive medicine, gynecology, and endoscopy. Among the career highlights, she's Vice President of the Mysore Obstetrics Gynecological Society, Secretary of the Mysore Obstetrics Gynecology earlier, and a faculty in various conferences. Welcome, madam. And our third chairperson is Dr. Praveen NS. Dr. Praveen? Yeah. So he is currently the fetal medicine consultant at Navya Fetal Medicine Center, Mysore, and worked in premier institutes such as the Royal London Hospital and King's College, London. At the King's College Hospital, London, he worked under Professor Kypros, whom we all know, Nicolaides, as the father of fetal medicine. And academics, he has done his MBBS from Mysore Medical College and MD, DNB, and FRCOG London. And he's interested in the clinical applications of obstetric scan. He's worked in the UK for more than 10 years, and he's still a visiting faculty to the NHS. Presently, he has presented many scientific papers at national and international conferences and actively participates in public education and teaching. Welcome, Dr. Praveen. So now I would like the chairpersons to one by one. So Dr. Parveen, you can introduce the first speaker. Thank you.
Important session. Thank you and welcome one and all. It's my privilege to introduce the first speaker of this session, Sharada Jagannathan. Her affiliations are she is an obstetrician and gynecologist, consultant in Sri Ramakrishna Hospital. Her academics goes like this: MD in obstetrics and gynecology from Stanley Medical College in 2002, and fellowship in high-risk pregnancy and perinatology, National Board, New Delhi, and special training she has received as a fetal medicine examiner in the National Board of Examinations. As far as her interests are concerned, she has interest in maternal and fetal medicine. Her career highlights are postgraduate examiner for DNB National Board. I welcome you, madam. Over to you. Thank you.
Thank you very much. Good afternoon, one and all. At the outset, I thank the president, the organizers of BGCI, Dr. Lakshmi, MD, CRC in particular, and Deepanjana, who made this possible. And I also feel very honored to stand before an Augustus crowd, very strong in genetics. A sharp difference between y'all and me is this genetic knowledge, where I stand very low in this subject as a clinician. In next 15-20 minutes. So in the next 20 minutes, I would talk about how we would go in a practical, because we come across the patients, the pregnant mother, the family, and the fetus first. The first step would be me, the obstetrician, would first see the expecting mothers. The fetal medicine specialist or the obstetrician trained in imaging would do the ultrasound. And then if at all we find abnormality or if the clinical scenario suggests, we would send them to a clinical geneticist. He or she and their team, including the counselors, will help us to arrive at a diagnosis, and they would tell us what sort of investigations to be done. And then we would arrive and then prognosticate with the arrived diagnosis. Prenatal diagnosis is the science dealing with congenital anomalies. Ultrasound is the powerful tool where we do to find the congenital abnormalities. We look for aneuploidies, that is the Down syndrome, trisomy 13, 18, and we also try to pick up genetic syndromes in the fetus. A most powerful tool is the sonography. Sonography is an operator-driven instrument where it depends upon the operator, it depends upon the patient also. With increasing obesity, some anomalies, subtle anomalies can be missed with obese abdomen, and a favorable position of the fetus also helps in identifying to the optimum level. The second important tool what we have to the additional to the ultrasound are serum screenings. Serum screenings, both in the first and the second trimester, we have for the aneuploidy and the neural tube defects. And once we find the screening, be it the ultrasound or the serum screening, and we find that there is something abnormal, we would then move on for confirmatory test. And this confirmatory test would be either by going for chorionic villus sampling, fetal blood sampling, amniocentesis, and then to arrive at the diagnosis, we would do karyotyping or microarray. And nowadays we have a number of tests, including, depending upon the situation, NGS or even whole exome sequence. With this, as I mentioned earlier, we would be able to get an accurate information, and therefore we can prognosticate, give them the recurrent risk, and if there is a therapy, we can offer them therapy. If no therapy and great morbidity, we can even offer them termination of pregnancy. We have a number of scenarios where we come across, where we would refer them to a clinical geneticist or a genetic counselor. It would be these. The very common things what we come across: women of advanced maternal age, or mother being a diabetic, or she's on anti-epileptics, or there are abnormalities in the ultrasound, or if her blood markers, the serum markers, first, second trimesters abnormal, or say, for example, she's got a Duchenne muscular dystrophy in the family, or other birth defects, consanguineous marriage, and history of recurrent pregnancy loss, especially if they have a chromosomal abnormality in one of the partner. So with this background, Of we dealing the patients first, where we come across genetic abnormalities, we refer to the genetic counselor. What we do it in our armamentarium, we have the strongest tool. One is the ultrasound, second is the serum screening, and third is the confirmatory test, where we do invasive test and obtain genetic material and confirm the diagnosis. So we have the ultrasound. And the two important time period we would like to have ultrasound will be, one is 11 to 14 weeks. The other one will be at 20 weeks. In Dr. Shubha Patke's paper, she's given in very, very low research setting, even if you have to do only one scan, maybe if you do it around 18 to 20 weeks, we can do a complete target scan. In addition, add an quadruple screening or a serum screening at that time, we can pick up both aneuploidies and we can pick up open neural tube defects. So one scan will be at 18 to 20. And if we have the luxury, this two scans would be an absolute. So in the first trimester screening, the 11 to 14 week scan, we would do see intrauterine, then we see singleton or twins. If it is twins, we say it is chorionic, dichorionic or monochorionic. Then we try to do an anatomical survey, look for the major abnormalities, and then do the screening for Down syndrome. And apart from it, we also look at the environment. We look at the placenta, cervix, and the uterine artery Doppler, where in uterine artery Doppler, the pre-eclampsia screen itself is a topic for another day. So we do almost a proper target scan. We've shifted from the second trimester into the first trimester, where we do an extensive scan, spending quite a lot of time looking at the gestational age, looking at the nuchal, we look the spine, we look even now indirect signs for open neural tube defects can be obtained even in the first trimester. Open neural tube defects can be predicted at the first trimester itself. Then we do head-to-toe examination right in the first trimester and try to pick up lot of abnormalities. So nuchal translucency is the main thing, like how we have our moderator trained from the professor. With that, we've all learned that nuchal translucency is an important potential marker. It's a potential marker not only for aneuploidies like Down syndrome, many cardiac defects, cardiac dysfunction or evolving genetic problems or akinesia, anemia, infections, congenital infections, all that it can be a marker. And once, as I told you, we do a first scan, 11 to 14 week scan. A very properly done 11 to 14 week scan thoroughly itself can predict around 90 to 95% of aneuploidies, especially Down syndrome. And if you see this busy slide, you can see there are a number of methods available for screening. But in our country, however, in our country, we don't have a policy or mandatory policy where the policy makers have made it and they have given, we don't have such a policy. So it is our people who opt inside the screening program. And as I mentioned, at least one proper scan would be fine at 11 to 14 weeks. And if we can add the biochemistry, then again, that would include, it can pick up around 90 to 95% of Down syndrome, which is the, as mentioned here. And once the NT is increased, if the NT is increased more than 3.5 mm, many times we see people doing the serum screening, but actually it is not necessary. We don't need to do serum screening if the NT is raised so much. In that case, we can straight away go for karyotyping, and now it is being replaced by chromosomal microarray if it is more than 3.5. If the chromosome is abnormal or the microarray is abnormal, we would terminate. And if it is normal, we would proceed with subsequent scans, ensure that the baby is normal. And we find there is any abnormality, then only we would recommend them for termination of pregnancy. Okay, and we've seen that if the child has a nuchal translucency elevated and we find that the chromosomal or microarray is normal, the follow-up is found to be, the outcome is found to be good. In the study paper, they found that majority of the children were normal, except one was Noonan syndrome. And now even for Noonan syndrome, we have a panel. And especially when the NT is raised more than 4 or 5, this panel can pick up Noonan syndrome also, what is being added. Otherwise, it is generally said to have a very good outcome. Now coming to the, having seen about the 11 to 14 week scan, which is so powerful, which can pick up majority of the abnormalities, we can also include Down syndrome testing. And as I told you, pre-eclampsia testing as in maternal fetal medicine is concerned. Next is the mid-trimester anomaly scan. In this mid-trimester anomaly scan, we again do a head-to-toe examination of the fetus, where we see thoroughly the head-to-toe, and we'll be able to pick up majority of the abnormalities. Maybe we'll not be able to pick up like ear abnormalities, those sort of things, but most of it we can be able to pick it up. Here we can see the lips, the profile, the eyes, the upper limbs, lower limbs. Here you can see so beautifully, and you can see the environment, the placenta and the cervix. And very thorough detailed cardiac fetal echo is also included in the target scan. We will be able to pick up most of the abnormalities in the cardiac. Maybe what we can miss will be ventricular septal defects or interatrial defect, patent ductus, that we can miss. Or rarely, not rarely, we can miss abnormalities like total anomalous pulmonary venous connection or coarctation, which are all evolving. But majority of the times, if we do a decent scan, we'll be able to fairly pick up most of the abnormalities in the fetal echo in the cardiac. Then again, we go to the rest, like this is the umbilical cord insertion, the bladder, the kidneys, and the spine. These kidneys and bladder, yes, in the subsequent slides, I'll tell you, because these abnormalities can also have evolving abnormalities, especially the urinary tract obstruction can present urinary tract, or the GI tract that can present later in the, say, in the third trimester, and therefore they cannot be picked up in the second trimester. So normal scan reassures the family. Several abnormalities can evolve with advancing gestation. So a third trimester scan again comes in rescue. With this, that what is the potential of the first and the second trimester scan, I would just like to add another important slide to understand why we do miss abnormalities in the scan. That is because of the time pattern. Though this is a very old paper, it is still a very powerful paper, because the anomalies are being divided into, some anomalies will be always constant. It will be present in the first trimester. We ought not to miss it. Whereas some abnormalities like these transient conditions, which I've mentioned, will be present only transient, and they will disappear in the subsequent scans. Some conditions can present first, can present second, or in the third trimester. And some abnormalities absolutely will be only late anomalies, third trimester presentations, which we cannot pick up in the first and the second trimesters. So first trimester, which we will have to, we should not miss, will be like anencephaly, body stop, holoprocent, conjoined twin, cyclops, gastrocrisis, and dextrocardia. We cannot afford to miss them. Whereas these transient conditions like nuchal translucency, cystic hygroma, these effusions, fluid collections, choroid plexus, urinary tract obstructions, cysts, all of these will be present transient. So we take them as markers. And once we find these markers, we will go in depth and again do a more thorough detailed scan. Sometimes we do invasive testing to rule out associated genetic abnormalities. Then variable onsets like diaphragmatic hernia. I've seen sometimes we can pick it up at 14. In some cases in diaphragmatic hernia, a 20-week scan will be normal, but it can present very late. We've seen it coming up eventration, or it can come up at 32 weeks. Hydrocephalus especially, they come in the third trimester. Talipes, many times in the first trimester it look like talipes, but in the second trimester they may not be a talipes, or it can present late. Coarctation, pulmonary stenosis, all these things present later. And these conditions which always present later would be the agenesis of corpus callosum, listen, especially these new central nervous system problems always present very late, and they are very challenging. And this is the time we definitely need the help of the geneticist team. So with this background, I'll just take on to 2-3 cases and then finish my lecture. Very, very common thing which we see is women with advanced maternal age, that has actually caused most of chaos, unnecessary termination, and it has totally undermined the happiness of pregnant women, because it's very common now to see women getting married very late, and by the time they come, they're already 32 to 40 years, especially when they're second time pregnant, they're 40 years of age. So this patient is a 40-year-old patient. Generally we don't do by age we go. We always, whenever a woman comes, whatever is her age, we do 11 to 14 week scan, and then we add on to the this biochemistry test, and then we come at we come at a posterior risk. Posterior risk, in this we find that earlier her a priori risk was very high, but then later her risk has become very low because her NT was normal, her nasal bone was present, there were no other markers, and we just left this patient to do nothing. We reassured her and she delivered a normal baby. Okay. So next, sorry. So this is another case where same again, this first trimester screening. This first trimester screening has come positive for a priori risk. Here you can see the a priori risk was very low, but then because her NT nasal bone is absent, her risk was very high. So we did an invasive testing, and that invasive testing came as positive for Down syndrome. And the invasive testing came positive for Down syndrome. It is pure trisomy. So we can tell that it's purely meiotic non-disjunction, and therefore the recurrence risk would be very low. Then this is another case where same thing. The quadruple test was positive for trisomy. The baby also had an unossified nasal bone. So for confirmation, we did a confirmatory test where we did amniocentesis, and then we found that it was a Robertsonian translocation, which is again very important here because the recurrence risk completely changes, unlike in the previous case. So women with structural abnormalities, there can be umpty number of structural abnormalities. I just put any abnormality starting from anencephaly to talipes or congenital cardiac disease or urinary tract. Any abnormalities will come. We always sought the help. We get inputs from the geneticists and then see what appropriate test has to be done, and then we prognosticate to the family. This I put it because now a commonest thing is this nasal bone. I feel in the first trimester, we should not include nasal bone because it's very common to see, and the subsequent trimesters we do see. So this patient had at 16 weeks referred for non-ossification of nasal bone. And again, most striking thing is the advanced maternal age here. So anybody who thinks 40 years and advanced maternal age nasal bone, they would definitely say it would be a Down syndrome. But then to our surprise, we found that the chromosomal test was normal and the patient continued the pregnancy. So we found that normal chromosome, normal karyotype, and we continued the pregnancy, and the baby wasn't looking anyway. The first thing when we say absent nasal bone, patients will have all bizarre imaginations and they'll get so worried. And this baby may be a little small thing, a depressed nasal bridge like looking, otherwise it looked absolutely normal. So there can be many other conditions, and this condition I just put it non-immune hydrops. Why I put it? Because it's again a challenging thing because there are umpty number of causes for non-immune hydrops. Again, we have to rule out chromosomal infections, then look any other etiology. And this case, after we evaluated, we found to have it was a pleural effusion where the infection screening and the karyotype was normal, and this patient had, this baby fetus had a tapping, pleural effusion tapping. After delivery, the baby had a stormy period with pneumothorax and all, but fine. And now the boy is doing 3 years old and doing well. And open neural tube defects also, a very common thing, central nervous system abnormality. We come across this, okay, so I think it stopped. The central nervous system abnormality, why I put it? Because now we can try to identify them in the first trimester. So if you go across, there are a number of case scenarios, but I would like to put all this. We as first people looking into the patient, we have this powerful tool of ultrasound, blood test, and all this would be given to you people, the geneticists, the genetic team, and you would give us inputs. You would tell us, do this particular testing, or this panel, because we, as I told you earlier, we don't have any much of knowledge. We clinicians either don't read or don't have the patience, or we are busy. So we get information from you. If you say neurofibromatosis gene, neurofibroma, please do this test. We would do a CVS and then we would do the test. And once the reports is done, we will get your information and would try to help the family. Thank you for patient listening.
Thank you, Dr. Sharada, for that lucid and informative presentation and within the time. Okay, thank you very much. We'll take the questions at the end of the session. Thank you. I request the future speakers also to maintain their time, please. Thank you. Now our second speaker is Lobna Abdul Salam. I welcome her. Her affiliations are, she is from Codex Genetics Center for Excellence. She is a co-founder, medical director from 2021. She is the head genetics department, Queen's Medical Center. Exclusive partner for Egypt from 2021 with Perkin-Elmer Genomics Private Limited USA, and SN Gene Reference Molecular Oncology COE Private Limited Asia, and Genic Precision Medicine COE Europe. She's also associated, she was associated with genetic consultant Adam International Hospital from 2019 to 2020, and medical director Colors Genetics Center 2019 to 20, and head genetics executive director Genome Center Cairo University from 2011 to 17. As far as her academics are concerned, she is a MBBCH, Faculty of Medicine, Cairo University, Egypt in 2003. PhD Human Genetics, Faculty of Medicine, Alexandria University, 2017. Diploma Clinical Genetics, University of North Carolina, 2018. Her interests are genetic diagnostics and counseling in cytogenetics, molecular genetics, FISH, array, NIPT, and NGS. She's also interested in CRISPR-Cas9 thalassemia and clinical research, pharmacogenomics, and she has interest in teaching genetics. And her career highlights are she's the member of African Association of Human Genetics since 2017, member of National Association of Human Genetics since 2017, member of Egyptian Medical Syndicate since 2005. She has obtained several grants and publications, invited presentations in various national and international forums. She has authored a book on surgical atlas of cleft palate and cleft palate fistulae, chapter, Global Incidence of Cleft Palate. With this introduction, I welcome you, Doctor. Please take it up. Thank you.
Good evening, everyone. I'm Dr. Lubna Abdul Salam. I'm a professor of genetics at the Faculty of Medicine, Cairo University. My presentation is entitled The Advanced Technologies in PGD. It includes a couple of case series from our center. Basically, PGD aims to prevent the propagation and inheritance of genetic diseases from carrier parents to their offspring. As per ISHRI PGD consortium data, there was 4,700 cycles recruited for PGD for monogenic diseases from December 2009 to October 2010. And basically, this is considered a very low estimate for the general number of cycles for this year due to difficulty of genetic diagnosis of single gene mutations from single cells. Thus, new technologies offered us an outstanding solution for the reprogenetic field. Based on the new advanced technologies, there are different approaches especially for NGS, including whole genome sequencing, whole exome sequencing, clinical exome sequencing, also chromosomal microarray, NGS targeted panels, and to a lesser extent, the PGS, MELPA, and whole gene sequencing. Remains the ultimate question, which technique fits which diagnosis? Why this technique fits it the most and will get us the best diagnosis? And what should be the primary screening method, and what will be the confirmatory method for the PGD testing later on? And of course, since we are part of a low socioeconomic market, the cost is the main hurdle here for designing a genetic panel. Here is a series of our real-life cases that hopefully they will be interesting for you. Case number 1. They came to the clinic as consanguineous parents with two phenotypically affected sons and one normal daughter. The index case was an 11-year-old boy. He was short for age with a normal mentality. He was congenitally blind with biochemical investigation showing decreased calcium, normal vitamin D, and normal growth hormone. Basically, based on our preliminary diagnosis for this case, we designed the following diagnostic approach. Optimally, for this case, we should go for trio analysis with whole exome sequencing for the mother and father and index case. But due to the expenses and the high cost for this kind of design, we chose a more compatible approach for this family. So we chose to go for whole gene sequencing covering the suspected genes for our preliminary diagnosis for the index case. And then after identifying the causative mutation, confirm the presence of the mutation and detect the mode of inheritance in both parents. Later on, we designed a specific primer assay for Sanger sequencing and Techman assay for the PGD. Our genetic testing confirmed our primary diagnosis of osteoporosis pseudoglioma. It is an autosomal recessive disorder with an incidence of 1 to 2 million. So basically, it's considered a rare disease. The main signs that is known for this syndrome and was found in our case was congenital blindness due to retinal degeneration and pseudoglioma, osteoporosis. The severe variant for this syndrome was also found in the other sibling in this family with severe skeletal deformities and mental retardation. Our results confirmed the presence of single nucleotide variant in the known causative gene reported in the literature. Our second case was a consanguineous couple with two affected sons. The older son died at 7 years of age. They had other two normal daughters. They had a family history with a similar condition with a child of the parent's brother. For the preliminary diagnosis of this case, because it was more or less a straightforward case, was to do MELPA for both the father, mother, and index case. Still, because of the cost, we had to go for a more compatible option for the budget of this family. So we chose to go for MELPA for the index case only, identifying the causative mutation and then confirming it later on. For the parents, we decided to do a Sanger sequencing assay for the confirmatory results and for the PGD later on. As per initial preliminary diagnosis, it was a Renning-Hoffman disease with the SMN1 type 1. It is an autosomal recessive disorder with an incidence of 1 to 8,000. It's rather frequent here in Egypt. The main symptoms that is known for this syndrome and found in our case was very delayed neuromuscular milestones, including no head support, cannot sit unassisted, difficulty in feeding, very poor growth and delayed milestone. The other variant that was found in this family is severe deterioration in respiratory functions, which needed proper respiratory support. And what we found is the well-known gene deletion in exon 7 for this case, and we confirmed the carrier status in the parents as well. Now, because of the frequency of these cases in Egypt, our center is part of the National Genetic Screening Program started this year in Egypt for the SMA screening program. It's sponsored by the Egyptian Ministry of Health for all consanguineous couples with a family history of this disease or a previously affected child with SMA. This was in collaboration with the Trial Gene Therapy Project sponsored by Novartis Orphan Disease Project. Our third case came as two unrelated parents. They were their first child. There was no family history of any genetic disease. The index case shows clearly cranial synostosis, syndactyly of the hands and feet, which gave us the preliminary suspected diagnosis. Our diagnostic approach was basically whole gene sequencing for the index case, and this is what we actually did for this case. We detected clearly Apert syndrome as we suspected clinically. It is an autosomal dominant disorder, mostly sporadic. Its incidence is 1 in 80,000. The main symptoms for this syndrome, and was actually found in our case, is the brachycephaly, the exophthalmos, the clearly mitten-like syndactyly of the hands. As we proved the SNV that it is autosomal dominant, those couple has a very low recurrence risk, less than 1%. So they were advised that they no no extra intervention is needed for future pregnancies, and they can go for another trial of natural pregnancy without the risk of recurring this syndrome again. Our fourth case came in the clinic as a 10-year-old female child with clear short neck with clear webbing. The parents were unrelated. She has one normal male sibling. So among the other variants that was found in this female, our initial differential diagnosis included Turner syndrome, Noonan syndrome, Klippel-Feil syndrome. Our diagnostic approach was based on exclusion of the disease list that was found in the differential diagnosis list. So we started with cervical X-ray, karyotyping till we reached the genetic test design. Optimally, we decided to go for targeted gene panel sequencing, including 7 genes for the suspected diseases, for the phenotypic features, for both the mother, father, and the index case. However, since that was cost-wise more expensive than going for whole exome sequencing, we decided to go for the more cost-effective covering more varieties, which is the whole exome sequencing for the index case only. And then later on, we decided the specific assay for Sanger sequencing and the Tachman assay for the PGT. Our whole exome sequencing revealed clearly Noonan syndrome diagnosis, which is either sporadic in inheritance or autosomal dominant with reduced penetrance. In this case, we proved that it is autosomal dominant with reduced penetrance. The main symptoms that was present in our case and known for Noonan syndrome was the facial asymmetry, the ptosis of the upper eyelids, the down slanting palpebral fissure, the abnormal auricle and the low hairline, and as well as scoliosis. The results showed 2 single nucleotide variants, and by screening the parents, we detected the 2 mutations in one of the parents, proving the autosomal dominant inheritance with reduced penetrance. Actually, the single nucleotide variants was present in the mother, and the mother showed very minor phenotypic variants for this syndrome, which was passed undetected for her whole life. Our fifth case is actually, it is one of the most interesting cases that we have. They came as 2 brothers from unrelated parents. They're phenotypically normal, both brothers. However, the index case, the brother found in the picture, was phenotypically different than the rest of his family. And basically, they were about to get married to 2 sisters, and they wanted to make sure that the children won't look like our index case. So, and that was the whole complaint, the whole history of the case. But with thorough phenotypic examination of the case, we found a group of very interesting phenotype, minor features with the proper scoring scale. We suspected a very rare diagnosis, and we moved on our diagnostic approach based on this suspicion. Optimally, we should go for the whole gene sequencing for the index case, for the genes known to be causative of our suspected preliminary diagnosis. However, since it is a rare syndrome, it was not reported before in Egypt, we decided to go for this time more expensive option, which is the whole exome sequencing for the index case, in order to cover all possibilities and not to miss anything in case our diagnosis was wrong, and then to confirm the causative mutation later on in the parents and in the rather normal brother. Our diagnosis, our genetic testing confirmed our preliminary suspected diagnosis, which is the Spritzen-Goldberg syndrome. Basically, on the clinical score scale, it checked more than 90% of the minor phenotypic findings that is related to this syndrome. This syndrome is known to have either an autosomal dominant inheritance with reduced penetrance, or rather suspected reduced penetrance, germline mosaicism, or it is a sporadic autosomal dominant inheritance. However, unfortunately, we could not prove the exact mode of inheritance in this case because the parents and the brother refused to go for further genetic testing for the resulting mutations in the index case. The incidence of this syndrome is 50 cases reported worldwide, so it's basically very rare. The main signs that were found in our case and known on the clinical score system for this syndrome was dolichocephaly, made face hypoplasia, skin hyperelasticity, low set ears, backward rotated, minimal subcutaneous fat. And the resulting SNV from our testing actually proved to be in a causative gene reported for this syndrome in the literature. Our sixth case was a consanguineous couple with 2 affected sons and 1 normal son. Our index case was a 5-year-old son with clearly cleft lip and palate, polydactyly, agenesis of the corpus callosum on MRI, and ventricular septal defect. All these clinical features were very suggestive of a ciliopathy disease, especially acrocallosal syndrome, and this is actually what we followed in our diagnostic approach. Optimally, we should go for trio analysis by whole exome sequencing for the index case and both his parents. However, due to the cost issues, we went for clinical exome for the index case, covering all the genes for ciliopathy panel to identify the causative mutation and then confirm the resulting mutation in the parents to confirm the mode of inheritance, and later on design specific assay for both Sanger sequencing and Techman assay for the PGD purposes. So our genetic testing proved our preliminary suspected diagnosis of acrocallosal syndrome, and we confirmed the presence of the mutation in a heterozygous pattern in both parents. So we confirmed the autosomal recessive inheritance in this condition. Its incidence is actually not known, but fewer than 50 cases have been published since the disease was first described in 1979. The main signs found in this case and generally known for the acrocallosal syndrome was the agenesis of the corpus callosum, the polydactyly, and multiple distinctive facial features, global developmental delay, and intellectual disability. The single nucleotide variant that was found in this case was actually reported in the literature for the acrocallosal syndrome. Our seventh case, and I guess this is the most interesting case and the most rare case in this case series, they were a consanguineous couple with 2 affected sons. Actually, the symptoms found, the phenotypical features found in both sons combined gave us the direction for a very interesting rare syndrome. What we found in both sons combined was blepharophimosis, megalocornea, micrognathia, sparseness of the lateral eyebrows, cryptorchidism, mental retardation, and postnatal growth deficiency. The pattern of these minor clinical findings in both siblings combined were highly suggestive of the rare Dubuis syndrome. So our diagnostic approach to confirm this was optimally should be quadro analysis for the 2 sons and both parents, either by whole exome sequencing or whole genome sequencing. But since the syndrome is very rare and no gene or genetic mutation was reported for it in the literature, we decided to go for whole genome sequencing for both sons in order to cover all possibilities, even intronic mutation that might be causative of the disease, and then confirm the presence of the mutation later on, the pattern of inheritance in both parents. What we found, in our results that was extremely interesting and suggestive of the Dubuis syndrome is we found a homozygous mutation in both brothers that was in a heterozygous pattern for this in the parents. And since there was no previous mutations till the time of testing was reported before the Dubuis syndrome, by the software analysis, the resulting mutation that we found was highly suggestive of the clinical phenotypic feature that was found in this case and found in both siblings. And so we recommended that this could be the first causative mutation reported for Dubuis syndrome, and this is very much likely matching the clinical features that we found in this case. The inheritance was in an autosomal recessive pattern because it was heterozygous in both parents and homozygous in the both children. The incidence is super rare, less than 200 cases reported in the literature over the last 40 years, with no an actual definitive genetic mutation reported in any case record so far. The main signs that were found in this case and reported generally for the B syndrome was the cryptorchidism, multiple distinctive craniofacial features, global developmental delay, and intellectual disability. Basically, our results would be considered novel single nucleotide variant for this case, and its first case report suggestive of a gene mutation for this syndrome coming out from the Middle East, and it will be published very soon as at the time of writing this case report. So basically, our take-home message for PGD is generally a triad of proper clinical genetic diagnosis, reliable molecular design, and accurate bioinformatics data interpretation to reach a definitive diagnosis. Thank you.
Thank you. I would request Dr. Jayashree to please introduce
Good day,
our next
everyone.
speaker. A very good afternoon to one and all, and I wholeheartedly thank the organizers for giving me this opportunity to chair this session. Our next speaker is Dr. Tani Wilson. She is affiliated pre-registration genetic counselor at Guy's Hospital and Genetic and Developmental Medicine Clinic, Sultan Qaboos University Hospital, Nine Wells Hospital, Glasgow. Moving on to her academic qualification, she has a Master of Science degree in Genetic and Genomic Counseling and Honours degree in Human Genetics. Her areas of interest includes research work on do men show greater use of maladaptive coping strategies in comparison to women with a diagnosis of long QT syndrome. Moving on to career highlights, she has internship position at the Laboratory of Neural Microcircuitry within the Brain Mind Institute at EPFL University, Switzerland. She has internship in a marine environmental company and bursary awarded in conference Genomic Practice for Genetic Counselors. I request Dr. Tani Wilson to please deliver her talk. Ma'am, can you please unmute? You are on mute, ma'am. She can hear from you.
Can you hear me now?
Yes, ma'am.
Okay. So good afternoon, everybody. My name is Tani Ann Wilson, and I'm a genetic counsellor at Guy's Hospital in the United Kingdom. I'm going to be talking to you about some of the genetic counselling options that we speak to when we have pregnant patients in the UK. So first of all, we receive many referrals from many areas of the National Health Service. These can come from GP surgeries, midwifery teams, fetal medicine units, other healthcare professionals in specialities, other regional genetic centres, and then sometimes patients can choose to be seen in our service if they wish, if they want to be treated at our hospital. So the National Health Service, or the NHS, I'm sure is something that you've all heard about. It is a government organisation, and it's made up of many different systems and teams that provide a social health care so that our patients don't have to pay full costs for their treatments. It's a wide range of medical professionals, and we have many different organizations with varying roles and responsibilities, from admin roles to clinician roles. And this is how we provide support and service to our patients. So I appreciate that everyone might know what genetic counselling is, but for anybody who does not, the way that we talk about it is something called MyRose. So it stands for basically the management of a condition. We talk about the implications of these genetic conditions, the reproductive options associated with these conditions and what we can offer our patients. We provide support to our patients, This can be different forms of support, sometimes psychological or counseling support, emotional support, and then familial support for the families that are associated with our patients. We then also provide education with recurrence risk, talking about inheritance, and then we do testing and research as well. So I'm just going to speak through a case and explain to you what we do in relation to a patient called Jane. She's a 34-year-old female, and she's 8 weeks pregnant. So she has a clinical and genetic diagnosis of NF1, so neurofibromatosis type 1, and she was tested as a teenager because she was symptomatic. So she's never had the discussion around reproductive options that we would normally offer our patients. So she's pregnant and she wants to know what is available. So when we first see a patient, and again, this is something that you might be familiar with, we talk through various different things in a rapid access clinic appointment. So rapid access clinic appointment, or RAC for short, is a special service that we offer our pregnant patients who need to be seen more urgently than others, because obviously in a pregnancy, there's things that we need to do, and so we don't want to waste much time. So in this appointment, we talk about a family history, a patient's personal medical history, if they've had any miscarriages. We talk a little bit about the condition, but normally when a patient is affected, they know quite a lot about this already, sometimes more than we do. We discuss the chance that the pregnancy will have this condition, and then we talk about any initial questions. And this is a really good opportunity in this appointment to see where the patient is at and to take time to get to know the patient and how they want to proceed in the pregnancy. So once we've kind of set the scene and we've set the foundation, we've done the initial discussions, we then talk about the reproductive options. So when someone presents to us from a natural conception where they've fallen pregnant naturally, there's a few options that we talk to them about. The first thing is they can carry on and they don't have to do anything. So if they just want to get some information and understand what the chance that the pregnancy will be affected by NF1, that's absolutely fine. We'll give them that information and we'll support them through that journey. We can then talk about testing after birth. So this is cord blood testing. Again, I think that you're all familiar with that. And where the real purpose of a rapid access clinic appointment comes in is the prenatal diagnosis when we talk about invasive testing. So this is something that I'll talk a little bit more about. If a patient is coming to us and they are not pregnant, but they have a diagnosis, this is where we will spend some time talking about PGT, which is pre-implantation genetic testing, or we talk about egg and sperm donation, as well as adoption. So invasive testing, so particularly for Jane, she wants to find out if her pregnancy is going to have NF1 or not. Now, I know that this is a technique that you use in India, so you're very familiar with this. But what I really wanted to highlight here is that when someone goes through invasive testing, it's not so much about going through the test to give them a result, it's how they feel about it and what they thought about going through this procedure. A lot of our patients have never been through invasive testing before, so we really want to talk them through the process about what's going to happen step by step, when they're going to be seen, what's going to happen in the appointment, explain kind of the theory about what happens in a CVS as opposed to just saying we can do a genetic test. So one thing that's really important to highlight here for our patients is that when they go into an appointment to have a CVS, there is a screen because they have to do the ultrasound in order to know where to put the needle in. And some of our patients don't know that they don't have to look at that screen if they don't want to. For some patients, before they have a diagnosis, they don't want to think about being pregnant. So if they see the fetus or the baby on the screen, that can be quite traumatic and be quite emotional. So we talk to them about this and we say to them, if you are in that room and they show you the screen, you can ask for it to be turned away if that's something that you don't want to see. Another thing that we talk about is obviously the risk of miscarriage. For some patients, that's something that they don't want to take a chance with. They would rather just proceed with the pregnancy and not do anything because they don't want to run the risk of a miscarriage. And this is something that I'll touch on a bit later as well. Okay, then there is something called NIPD, so non-invasive prenatal diagnosis. For Jane, this wouldn't necessarily be an option because she is the person who carries the mutation, but this is an option that we would discuss with some patients where the father carries a mutation. For some autosomal recessive conditions, this is possible as well via paternal exclusion. And this is an option that we talk to patients who don't want to take the risk of a miscarriage and would try and find out if the pregnancy has a condition in a different way. Sometimes though, however, an NIPD result needs to be confirmed by invasive testing. So this is something that the patients need to think about. And this is why we have these appointments to really talk through these options with the patients. And it's important to note that the appointments that we give as genetic counselors, we liaise with the fetal medicine units and the midwifery teams directly with email. So we really do take care of our patients from that perspective. We make sure that they are followed up. We keep the midwifery teams and the fetal medicine consultants updated on our discussions, what to expect, how the patient's feeling about things, so that the patient doesn't have to go back to their doctor and try and explain everything. We've managed to keep everyone updated so that we try and make it as least stressful for the patient as possible. Okay. Another option, as I mentioned, is the cord blood. So this is testing where we take a sample from the umbilical cord after the baby is born, and this can be tested or stored. This is not something that we routinely use for adult onset conditions because we want to protect a patient's autonomy. So we don't want to test someone before they've had the option to choose testing. But for Jane, for a child with NF1, this is something that could be helpful. If she didn't want to go through testing in pregnancy, but her child became symptomatic as a young little child, then we would be able to use that sample to test if need be, which means we wouldn't have to put the patient through having a needle test when they're little, because that can be quite traumatic for the little ones. Okay, and I know we've just had a fantastic talk from the doctor before this about PGD, so I won't spend too much time on this, but this is a procedure that Guy's Hospital runs. So we're one of the only hospitals in the UK who do PGT. And this is something that we offer to patients who have a genetic diagnosis or for autosomal recessive conditions who have a 1 in 4 chance of having a child with a condition. We would then talk to them about PGT. And this is something that is funded through our government organization if a patient fulfills certain criteria. So these are the criteria on this page. So if a patient or a couple meets these criteria, then we are then we'll offer them 3 rounds of PGT. So this is something that is funded by the government. It gives them the opportunity to have a good chance of having a healthy child. So as you can see, just to highlight, so the couple needs to live in England. They need to be at risk of having a child with a serious genetic condition, more than 10%. The couple is referred by our service to PGD specifically. The female partner needs to be under 40 years of age and have a BMI of between 19 and 30. Both partners are to be non-smokers and non-vapors. The couple can't have an unaffected child together. And there needs to be a suitable license for this. So this is something that we can provide to our patients. It does give some patients who have been through a really traumatic journey to get to this point a chance of having a healthy child. So this is what I really wanted to speak to you about today. So when we are speaking to our pregnant patients about the options that they have going through genetic testing, there's a few things that we want to consider. And this is why we offer these appointments. These appointments are 45 minutes long because we want to give the patients time to really think about their options and their next steps. So some of the things that I really want to highlight are a patient's personal experience of a condition. Sometimes we get patients who have had 3 or 4 children who've been born, who've lost these children, and so they don't want to lose any more children. They want to get through this again. They want to get through this safely with this child. They don't want to go through it again. Sometimes we talk about things with patients like, what does it mean to be a parent? Is it something that's really important to them? This is really important when we think about the invasive testing option where we think that it has a miscarriage risk, because for some patients, they don't want to take that chance because they are so desperate to be a parent. It's also something to think about guilt or anxiety. So for someone like Jane, who's got a diagnosis of NF1 and she's living her life, she might have some reservations about ending an affected pregnancy with NF1, because technically that's who she is. She's a person who's affected by NF1. So she really wants to think about, her journey through her life and how she might feel about going through a pregnancy and then ending that. Pregnancy in itself is a very, very stressful situation for anyone, never mind someone who's going through a pregnancy with a kind of the chance of having a genetic condition. So we want to control the patient's anxiety. And that's why we manage these patients with all the other services. We create the referral options. We discuss with our fetal medicine units about the patient to try and take as much stress and anxiety away from that patient as possible. Another thing as well is, we think about a patient's personal health. So for Jane, how is she managing her diagnosis? How does she want to go forward in this pregnancy? Can she go through that pregnancy? With NF1, there are some prenatal risks or risks of pregnancy with that diagnosis. It's really important to think about. And finally, the other thing I want to mention is that a lot of our patients, as one of the speakers mentioned before, they're coming to us at older ages. So we're getting a lot of pregnant patients between the ages of 35 and 40. And for them, it's really important to think about that they're getting older. So the chance that they can have a pregnancy might be getting less. And so this pregnancy might be really, really, really precious. So we want to counsel around this and think about a patient's needs and a patient's wants with this pregnancy, because they're at an age where maybe they don't have 15 years to try and have another child. It's really important to think about this. So just some things I wanted to highlight. Some other things I wanted to mention and some helpful tips that maybe would be useful for any other genetic counselors is we really want to understand the patient's experience of the familial condition, and we want to understand a couple's journey to having that pregnancy. Really important to think about when we're in those appointments. Also, a really helpful question, and a question that we've used really often, is that if a patient attends a session alone, so if the pregnant lady comes by herself and she's not with her husband or her partner, or she's not with any family, it might be worth asking them, if your husband was here, what do you think he would say? Or if your partner was here, what do you think they would say? Is to really try and see if the couple is on the same page, if they're thinking the same, if they have the same thoughts around going through invasive testing or not, just little things like that. If a patient is really struggling to make a decision, do I go through invasive testing or not? So if Jane, our patient, is really struggling, she doesn't know what to do, we might want to talk to them about how they've coped with big decisions in the past. What's a big decision that she's had to think about previously? Or how has she coped with bad news in the past? Because we might give her the result that the pregnancy does have NF1. How would she feel about that? Does she feel ready to have that information? So that's something that we talk about in terms of coping. What are her coping strategies? And I mentioned that below. So there are different coping strategies between males and females. Very often, males are very problem-solving coping strategy. They have a problem and they want to create ways to solve it. Women, on the other hand, normally are emotional problem solving patients. So they might want to talk to all their friends. They might want to talk to all their family. They do a lot more talking other than the males, who don't often do much talking. So together, we want to see if the partners are on the same page, and see if they can make this decision together and support each other with the different coping strategies. Some patients are information seekers. So all they want to know is what is the percentage that my baby's going to be affected? What can we do if the baby is affected, etc., etc. So it's really important that we provide our patients with accurate, up-to-date, and succinct information, just giving them enough that they can take that information home and they can think about it. Another thing which I really want to mention is that wording in an appointment is really important. Some patients don't want to talk about the baby. They would rather refer to it as the pregnancy, because they don't want to form an emotional attachment with that pregnancy before they know that the baby is healthy. So if a patient comes to you and they say, I want to know about my pregnancy, then we would advise that you use that word, continue to use the word pregnancy. Sometimes it can be really harmful if we start talking about the baby and then the baby's going to be affected, because that creates that emotional link, and that might be more difficult for the patients and might give them more anxiety and more stress. Okay. And then just a final slide. So Guy's and St. Thomas's Hospital is hosting a virtual prenatal genetics course. This is coming up in September, and we are going to be speaking about all aspects of prenatal genetic counseling from the services that we offer, some useful hints and tips, and we would really welcome you to join us for this course. It's 6 half days, so it's about three hours per session. for 6 days. And as I said, it's hosted by my service. So if anybody has any questions or anything, please feel free to ask me, or follow the link below and you'll be able to get all the information that you want about this course. So we'd be very happy to see you there if you want to come there. We also have a virtual cancer genetics course, but that's something that we've just completed, so we will keep you up to date with the next ones. So thank you very much. That is everything from me. I understand that we have questions later on, so thank you.
Thank you so much. Please stay with us because we'll discuss the questions after the panel, and we'll take up the audience questions after the panel as well. I would request Dr. Praveen to please introduce the next speaker, please.
In fact, I was associated with her genetic lab Gene Tech for several years. So affiliations of Dr. Anuradha are founder Gene Tech, a genetic genomics lab, Hyderabad, academics, PhD in human genetics, postdoctoral integrated laboratory system, Research Triangle Park, North Carolina, USA, Waxman Institute for Microbiology, New Jersey, UMDNJ Medical School, New Jersey. Her interests are genetic diagnostics, designing of novel economic and application-oriented diagnostic tests. Career highlights: conducted 200+ genetic awareness programs in South India, designed world's first and most comprehensive NGS-based genomic panels for infertility practice, presented at ACMG 2019, ISAR 2021, ASRM 2021, and other international platforms. Multiple paper publications in reputed journals, reviewer, author of medical book chapters and other higher education courses. Young Scientist Award of Genetic Toxicology and Environmental Mutagen Society, USA. Best Research Presentation of her doctoral work in St. Louis EMS Meet, USA. Best Presentation Award for her technical paper in Genetic Toxicology and Mutagen Society Meet in British Columbia, Canada. Over to you, madam.
Thank you, sir. Thank you so much. It's always a pleasure to see you. And another great pleasure today is I have met my super senior Parveen ma'am. And as pleasant as she can be always, she used to help us even draft our PhD work. So very nice to see you, Dr. Praveen, and Namaste, Dr. Jayshree. I will meet you later. So it's really nice to see all youngsters here. And BGCI is doing a great job. And thank you for inviting me. And I'll go ahead with the lecture since I have only 15 minutes. I usually speak for an hour, so please ring that bell 5 minutes ahead of time. The topic that I have is only about NGS. So I am not going to speak about anything else other than the NGS related genetic counseling challenges that all of you are facing or will face. So just a few slides to talk about the technology and chemistry. We all know the first generation sequencing, which is Sanger sequencing, and then came the second generation sequencing, which is NGS, which has changed the way we diagnose our patients. And here we have different kinds of chemistries. It can be emulsion PCR based chemistry, which is the ion torrent platform that we use, and bridge amplification can be used, which is done by Illumina, or nanoball generation is done by BGI technologies. So different chemistries with their own limitations and advantages, but they all offer NGS sequencing. The third generation, of course, will look at longer reads. With the second generation NGS, you're going to sequence around 200 bases, whereas long reads of 400 plus even up to 1500 reads you would be able to get in third generation sequencing. So PacBio, the Oxford Nanopore, these are some of the technologies where you will get longer reads, but your accuracy of sequencing is slightly lower. It is still being worked out. So based on all this, you will have to pick and choose what is the best method of testing for your patients. And what are the advantages of NGS? Of course, I don't have to give you the list, but just to show you that you can sequence multiple genes, which we cannot afford to do on a Sanger sequence. And you can also do multiplexing of different panels. For example, you can have an infertility panel, you can have an autism panel, you can have some other cardiovascular panel, and you can multiplex all this and you can process in your laboratory. Ability to multiplex different samples. We can multiplex up to hundreds of samples depending on the size of the chip or flow cell that we are using. NGS is a great technology which produces rapid, accurate, and sensitive genomic data for you. And then it can also handle huge amount of data. And it's relatively low in terms of cost because we started our laboratory in 1998. And you can imagine at that time to sequence something, we would probably pay, patients would shell out 10 lakh rupees. Today it's done in 10,000 rupees. So that's the amount of relative cost reduction that has come these days based on how big your sample is. But there are also some limitations that we will all have to remember, which is you will have to confirm your variant that you have identified by NGS through Sanger sequencing. That's the gold standard way of confirmation. So don't totally rely on your NGS, but NGS has longer turnaround time and higher cost. Although I did talk about 10,000 rupees, it's between 10,000 to 30,000 rupees. And then it's still a higher cost for a lot of patients in India. So if we are taking up NGS, we need to be aware that the turnaround time is also high. Someone cannot come to us at 26 weeks of gestation and then say, I need a report tomorrow. It's not possible because all labs are pulling up their cases and they are working out. So there are some other technical limitations. Again, I will not go into detail, but it can't do repeats as effectively as some other technologies. Bigger indels, CNVs, although there are people who come up with technologies where selected CNVs are included in their exome sequencing. However, the level of accuracy is still not yet there. Also methylation, epigenetic factors, these are all issues. The third generation has resolved most of the issues of second generation NGS. However, the accuracy is low. So you will have to weigh and see which one to use and then use it for your patients. So what are the applications of NGS? Here are the applications. You all know aneuploidy screening is one of the most common application. You do NIPT by NGS. That's the most common. And then you also do what is called embryo screening, where you're again looking at aneuploidy, looking at all your chromosomes, but by using NGS. So we have aneuploidy screening as one application. Second application is you want to identify the disease causing variant by sequencing large number of genes. This you can do by sequencing selected genes called focus exome, clinical exome, medical exome, whatever you may call it. People can choose to sequence certain number of genes, or you can sequence the exome of all genes, and that's called whole exome, or you can also do complete genome. And the applications there are when somebody is presented to you with a syndrome and you really do not know what clinical presentation it is, you cannot identify without giving multiple differential diagnosis, use exome sequencing. Carrier screening to pick up autosomal recessive disorders, or you know what you're looking for example, polycystic kidney disease, but you know there are multiple genes involved in it, then also you can use exome. Similarly, NGS is also used for selected design of certain targeted genes. For example, in our laboratory, we have designed infertility hotspot panel where we have around 800 hotspots that we look for, which is related to infertility and ART procedures. Similarly, some other laboratory requested us and we have prepared autism related hotspot for AmpliSeq. So these things are also possible. HLA typing is possible. I'm not touching upon cancer. A lot of onco panels are possible. And of course, metagenomics is now possible with third generation sequencing. And you can also do RNA sequencing. These are all the applications of NGS technology. Now I'll move on to the challenges for you as a genetic counselor. As far as NIPT is concerned, cost is a major issue. So whether to use NIPT as a primary screening method or as a secondary screening method. When we say secondary screening method, we are going through the regular markers, and wherever there is a high risk, then we are recommending NIPT instead of amniocentesis. Now the challenges there are which panel to select, whether to do only 3 chromosomes, whether to do all 46 chromosomes, whether to do chromosomes along with microdeletions and duplications which are selected, which panel to select. Of course, you will have to base on if there is a high risk report for Down syndrome, there's no point looking for microdeletion syndromes. In that case, you will select all chromosomes or selected chromosomes. So you will have to take decisions based there. And if the fetal fraction is less than 2.5%, you will have to know how to counsel your patients. And multiple pregnancies. Currently, most of the bioinformatics can look at twin pregnancies, but anything beyond twin pregnancy, you have to caution the patient or not take the sample. Post-NIPT confirmatory test counseling is extremely important. You have to draft the way you speak to patients so that if the NIPT result comes positive, you will have to offer an amniocentesis program. Another aneuploidy testing is PGT-A, PGT-M, and non-invasive chromosomal screening. Since I'm used to talking to doctors, there's a lot of confusion what test to use when among clinicians. So it is you guys who will help them in understanding what is required. If we are looking for only aneuploidy, we are doing PGT-A. But if we are looking for any monogenic disorder, Mendelian disorder, then it is PGT-M. PGT-M requires good amount of pre-workup before we take sample from embryo. All these things have to be considered in your PG. NICS is also there. We are also working on NICS. The concordance is around 80%. We are trying to achieve more than 95% before we offer it as a commercial test. When you want to offer exome sequencing, again, you want to know whether you want to do a focused exome, clinical exome, medical exome, or whole exome or whole genome. Just because somebody is offering for less price, it is not correct to just go ahead and take that particular exome sequencing panel. So you will have to do your own workup before you decide what to do. And whether to take a single sample, whether to take a trio, whether to take a duo, these are all the challenges that you have. And that is me and my team in any laboratory. This is any team in any NGS laboratory. There's so many questions all around us, right? So I don't think we can ever escape this, although we're trying to find solution one after the other. Whether the pathogenic, is it a new variant? What does the in silico data say? Is it urgent sample? Which one to do first? Contradictory report. Somebody is saying this variant is causing the disease. Somebody is saying no. So these are all the things. At this point, I would like to ask in this hall, if someone sends your exome for your risk for a child with mental retardation, and if we in our laboratory find out that you have a risk for breast cancer, how many of you would like to know that? Yeah. I'm asking them as patients, how many of you would like to do that? So this is the concern, 50% of you. Okay, fine. So these are all the challenges that we have with mostly rotating around uncertainty. So we have, I will come back to the same question a little later. If you have something which is uncertain significance, you can find it in proband. So So you all know what is a variant of uncertain significance, right? How do you deal with it? The best way to deal with that is to design a targeted testing and then offer only those targeted panels which are associated with the phenotype. That's the best way. But then it will reduce your diagnostic value. Therefore, we will have to do a mix and match. Then what are the types of uncertainties? So these are all the types of uncertainties: clinical effectiveness, incomplete knowledge, secondary or incidental findings, uncertainties about the technology itself. Some technologies will have homopolymers, some technologies will not detect something else. So there are several related to condition also. The condition may have incomplete penetrance. So these are all the things that you have. For clinical effectiveness, I would recommend a trio. If you do a trio, you are reducing 50% of your headache as far as clinical effectiveness is concerned. And in India, that won't be possible all the time. So therefore, you have to be extremely cautious about your counseling. And for incomplete knowledge of the variant, what I would recommend is a good phenotype and genotype correlation. Work with your clinician and get that information. I'll be done in just 1 minute. Pathogenic variant, if you have to use your classification, be extremely thorough with your ACMG. Today we have 73 genes that are listed in as secondary findings that you can work with, and whether to report or not will only be dependent on the consent that you would get from your patient. So I'll not go into these details, but just I will stop with just 2 stories. One story where carrier screening was offered to one of our patients. We identified, actually they came with retinitis pigmentosa baby. We did at that time, probably in 2000 or something. I had no NGS in my hands. So we did Sanger for known gene, and we identified the mutation, and we told them that, please come back, we'll do amniocentesis and tell you whether the baby next time will be retinitis pigmentosa or not. They came back, we did the test, then baby was normal. We informed that the baby does not have retinitis pigmentosa. They delivered a baby with SCID. So they are carriers for multiple mutations is what we have to remember as counselors. Then the second story is when the patients with, this is a simple thalassemia case, they came to us, we did mutation testing, IVS15 positive. Then we told them, you have 1 in 4 risk for pregnancy in next pregnancy. You please come back when you get pregnant. They came after 2 years carrying a baby with thalassemia, and get a call from the physician saying, it seems you told them there is no risk, so they went ahead. I said, I never said something like that. How could I even say it's a recessive mutation? There is 1 in 4. So I called the patients back and I spoke with them, and they told me, aapne to 1 in 4 bola hai, 1 abnormal ho gaya, so we thought the other 3 are going to be normal. And I am not joking. This, I never get tired telling this story, because this is the communication. Communication is extremely important. And as genetic counselors, you guys have to design what is the policy of communicating properly. A written communication. Patients want to hear what they want to hear at the end of the day, but we have to be empathetic to that issue, and we will have to communicate properly. And sorry, I did not have time to explain all the NGS limitations, but if you are counseling based on an NGS report, you have to be very, very careful and look into lot of aspects to make sure that you deliver your message properly. Thank you so much. Thank you.
Thank you, Dr. Anuradha. I request you to please stay on the stage because now we are having our panel discussion. So I see Dr. Mandakini Megh there. And may I request Dr. Deepak Modi also to come on stage? Dr. Deepak? Okay. So let me introduce Dr. Mandakini Megh first. Okay. No, you introduced me. I'll be on the stage. Okay. So Dr. Mandakini is chairperson of ICOG. She was in 2020 and 21. Director and consulting obstetrician gynecologist of Dr. Meg's Gyneco Care. Among the academics, she's an MD, DGO, FICOG, and many more. And among the career highlights, she has been vice president of MWIA Central Asia, national vice president FOGSI in 12-13. She was head of and superintendent of Kama and All Bless Hospital for Women and Children in Bombay. She was deputy director of health services, government of Maharashtra, Mumbai, and state level consultant, maternal health wing, UNICEF, government of Maharashtra, and maternal health consultant, government of Maharashtra, public health department, Bombay. Welcome, Dr. Mandakini.
Thank you very much. Thank you for that kind introduction. And hello, Firoza.
Yes.
Hi.
Okay. I now introduce Dr. Deepak Modi. So, Deepak, can you please come on stage? He's there already. Okay, fine. So, Dr. Deepak Modi is a scientist, F and head, Molecular and Cellular Biology Laboratory of ICMR, National Institute for Research in Reproductive and Child Health. And he's done a PhD from Bombay University. His interests lie in genetics of sexual development and infertility, genetic networks and embryo implantation and placental development, COVID-19 and reproduction. Among his career highlights, he's elected as Fellow of the National Academy of Sciences, India in 2020. He's a INSA Young Scientist Awardee and National Academy of Sciences Young Scientist Award, Innovative Young Biotechnologist Award, the ICMR Young Scientist Award, PM Bhargava Oration Award. So that's quite a lot, Dr. Deepak. Good. And now, yeah, Dr. Deepanjana will conduct this session and she'll introduce Dr. Firuza Parekh and the other speakers.
Hello. I would like to introduce Dr. Firoza Parekh. She's affiliated with, she's the director, Jaslok Fertility International Fertility Center, Jaslok Hospital and Research Center, Mumbai. She's the editor-in-chief of Fertility and Sterility, the Indian edition, and she's the editorial board member for Fertility and Sterility USA. We really don't need to introduce her as she's known to all of us. She's one of the pioneers. She has 36 years of experience in IVF and reproductive medicine. She is responsible for birth of over 20,000 babies by ART. And she reported the first birth after the PGT. I also take this opportunity to introduce my friend and also advocate Rituparna Chatterjee. She is a lawyer associated with DSP Law Associates, Fennis Ligates Contributors, and Chaudhary and Company. She has done her degree from National Law, Orissa, Cuttack. She has been handling a lot of social issues, and one of the social issues which she has become very prominent with is wetlands in Calcutta. And she has been a phenomenon because in most of these cases in infertility, she has been advising us. So welcome, Dr. Parekh, and welcome, Advocate Rituparna Chatterjee.
Thank you so much for your invitation. Appreciate it. Thank you so much. Good evening, everybody.
So good evening, everybody. Today we have a very exciting session ahead of us, and what we kept as a topic is reproductive choices and rights in the era of genomics. Next, okay, just a minute. Okay. So we all are aware that just a few days back, there was a very path-breaking judgment that was given, though it was not concerned with India as per se, but still it was a judgment which actually was challenging the abortion rights. They said that abortion cannot be legal and abortion is illegal irrespective of what the conditions may be. In India, if we look at this, there is Article 21. Sorry. In India, if we look at this, there is
In India, if we look at it, we have Article 21. I don't know how many of you are aware, but Article 21 is an article which actually gives us the right for our own reproductive choices. It's an Indian fundamental right that we have choice over our own body. Now, the problem with this is it is not, like lawyers would look at loopholes. And it really, if I just read it out, the main point, it describes that reproductive right includes a woman's entitlement to carry a pregnancy to full term, give birth, subsequently raise the children. And these are fundamental rights because it defines our dignity and it defines the bodily integrity. But then, this comes up. I'm very sure all of you were aware of this, that there was a law which stated that you cannot abort a Down syndrome fetus. And this was a Supreme Court law. It was a case where, this was a case from Bombay where a 26-old gestation fetus, the couple did not, came to know late and they wanted to terminate. And the court said that you cannot terminate. So my question to the panel first, Dr. Firoza Parekh, would be, do you really agree to this?
So it's a very pertinent question. Thank you for asking me this. It all again boils down to not just reproductive rights, but what are you going to offer this child? Different families have different situations. There may be a family who has all the wherewithal to take care of a child afflicted with Downs. They may have all the facilities. Here, they could be a mother, maybe divorced, maybe the husband may leave her, and she may not have the means to look after this child. So, of course, we are all proponents of life, but we have to individualize our situation. I, for one, would think that if the woman does not have the wherewithal, she does not have the family support, she may consider carrying out an abortion. Of course, in this particular case, since life or the viability of the baby comes from as early as 20 weeks in some countries and 24 weeks in other countries, this is crossing a line, and this gray line is very fine. So it would need just a discussion here. In 2 minutes would not be enough to say yes, she can go ahead, or no, it's not correct. There are so many nuances in this, and each case has to be looked upon on its own merit.
With that note, I would go to Dr. Meg and ask, why at 26 weeks we will detect Down syndrome with so much of, genetics, so much of technology available to us? Ma'am, you are on mute, ma'am.
Here, so first, thank you very much for inviting me, Firoza, for this wonderful conference. And I'm going to answer this way, that here we can see there are many situations. It's not only one situation. One situation is that, the patient who is actually, many of the patients are not having the advanced facility for the investigations. Even the genetic counseling, genetic examination, it is not available. More than 60% of the people who lives in the district hospital or so. So if we say that why it was detected, late, we can't say. But the problem is that they should permit, if it is a life-threatening or there is no probability of the baby being, surviving with the, full this thing, then there is a probability that we have to terminate. But here what I will like to bring it to everybody's notice, that it is the judiciary which is, indirectly responsible, because in one case they give the permission for the 34 weeks or 36 weeks for termination, and in other case they do not do. Similarly, if you can see, there was a rape case. We are on the JJ board, being in the Kama hospital. So some cases where the rape cases where it comes very late, say by 28 weeks or so, so it becomes so difficult, still they do not give the permission. And then that poor girl, 14-year girl or say 13-year girl has to carry that pregnancy, be teenage mother, face the life-threatening situation and take the baby with her is a very, very sad situation. So what we are actually trying to do here, I think in another question it will come that we have increased the limit of MTP to the 24 weeks. But here I like to say this is a case to case, as Firoza said correctly, and they have to take a little positive approach as far as the permission of the court is concerned. And now after this amendment, there is no need for the court to go. I think we are going to have that question later. So thank you very much. This is my opinion.
Thank you, ma'am. Ma'am, also, don't you feel that because in India, we still, even there are bodies like fetal Society for Fetal Medicine, we really don't have guidelines by the government of India where the actually in the government setup such screening is happening, or there is no, like, it's still a choice. It is not a mandatory test to go for any of these screenings. Don't you think that is also, all of the centers are not equally equipped to pick these up? So don't you think that is also one of the reasons that add to this? Even in urban setups, it is not.
Yeah. You are very correct that, it is the, government's duty when we are having so many regulations. I remember going to the Jaslok hospital and, I was in charge for the controlling the genetic clinic, So it is the responsibility for the government to give a correct guidelines that is there. But at the same time, I'm again and again telling that, hardly even in the big district hospital where I was in charge of the hospital, genetic services are not there. So it is the duty of the government also to provide those services also in those big hospitals and also give the guidelines. Of course, we are supposed to give. I agree with you, right?
Yes, ma'am. So my next question goes out to Dr. Jayashree. Is it the court decisions or is it a doctor's decisions? Whose decision is to make? Because actually the MTP law states that two people are responsible. If two doctors say that you can terminate, then you can actually go ahead and terminate.
As a doctor, I would facilitate the patient to take the decision. So we inform them the condition and the prognosis associated with the condition. So after the informed choice, the decision is to be made by the couple. But in this case, as you're saying, the period of gestation is 26 weeks. So fortunately, an amendment has been made wherein even beyond up to 24 weeks, as per MTP Act, we can terminate the pregnancy if the couple wishes to. And beyond 24 weeks, we have a board formed by gynecologist, pediatrician, radiologist, and a person appointed by the state. And that board can take a call regarding termination of pregnancy, provided the couple opts for termination of pregnancy. So now I don't think they have to go to the court. If the couple wishes to terminate the pregnancy, they can go ahead and do it with the board's approval.
Autonomy lies with the couple to decide what should be done.
Yes.
With this, I would actually ask.
One second, Dipan. Can I interrupt here? Ma'am, you are talking about a termination of pregnancy, Dr. Sujata, and you're talking about a couple, whereas she read out that it is a woman's right. But I have noticed that most OBGs, most people in India say that it has to be a couple or a consent of your partner. Why is that? Is that something cultural? Because I'm sure we can ask people from UK and all, it's not there. But here it happens. Why?
Can I say something?
Yes, ma'am. That's a very nice question raised by ma'am. Actually, I would like to change it after listening to ma'am. It's the women's consent. We can go ahead.
Yeah.
And why I use the term couple is most of the times they say that we will discuss with our partner and come. But yes, if she wishes to terminate the pregnancy, she has all the rights to do so.
And husband's signature or partner's signature is not required.
Not required.
If she is adult, she does not require anybody else's permission or the consent.
So I would request Advocate Rituparna to comment on this.
Yeah, thank you, Dipanjana. See, when we talk about this in light of Article 21 that we understand, which is something that all of us Indian citizens are governed with, it says that nobody will be deprived of personal liberty and deprived of life except procedure established by law. Now, law has made a procedure where this MTP Act has come in. What we need to understand today, and as we all know, all the panelists, all the doctors over here, that this MTP Act has undergone various changes, the latest amendment being in 2021, where this period of 20 weeks was extended to 24 weeks. And there's another important thing that came over here, was that this married women clause that was dropped from the 2021 amendment, that it's not only married women who can go in for medical termination of pregnancy, but even unmarried women who do not want to go ahead with the pregnancy and are victims of rape or any such other factors, even they can go ahead with this abortion. So we understand that the law is evolving. But what we need to really ask is it actually a decision of the court, or should this actually be governed by a law? My understanding, and this is really my personal opinion, if there is no law in India, I'm specifically talking about India, that says that, okay, at the age of 25 or 30, you have to get married. There's no law. There's no law that says that at the age of 32, you need to have a kid. If there are no laws which in the affirmative impose these obligations on citizens, then why should there be laws that will impose these restrictions? Like abortion, you can do an abortion at this time, you cannot do an abortion at this time on the citizens. So this should completely be left either to the woman, the mother, or as ma'am also
That is
pointed
exactly
out,
how it is in UK.
No, listen.
Right.
May I intervene here? The reason is also the safety of a woman, and termination of pregnancy after a particular time period is harmful for the mother. And the whole procedure becomes dangerous. Am I right? The obstetricians on the...
Absolutely, ma'am.
So that is why a law came into place. And for the counselors, all of you sitting here, we are not going into a debate with the policy. We have to talk. If we are counseling, the counseling has to be given with the legal article of the law. If you are in UK, it's different. If you are in US, it's different. From today in the US, you cannot terminate. So you will have to say, please don't go in for prenatal testing, but go in for pre-implantation genetic. But if you are in India, you have to follow. You have to say fetal sexing is not possible, which is possible in you. So our job as genetic counselors is to counsel and give the information relevant to the country and the law of the land.
That is true. So
correct.
I would next move to Dr. Wilson and ask her, like, so is the safety issues really not an issue in UK? Because as far as I know, there is no law for termination, right?
So I think it just must be said that there are screening practices in place so that we don't reach this point. Obviously, that's the basis. We don't want to get to this point and then discover that a patient is having a fetus with Down syndrome. That's why we screen so often. However, as you've mentioned, it's because her gestation is at 26 weeks. She's over the 24-week mark. The decision does not lie with us. We would have a panel of consultants who would assist and give the information. And I think as a genetic counselor, my job or our jobs would be to provide the information so that the patient has everything that they can expect from this prognosis with the Down syndrome fetus. In terms of making the decision, as far as I'm aware, it does come down to the woman or the couple. They have rights to make a decision, but because of the gestation, there needs to be discussion with consultants to protect the lives of the patient, so it can be done safely and securely. Because this has implications for the family going forward. So I think that would be our stand. But I must be honest, it's not a situation I come across very often. So I'd have to check.
I'd like to add something here, if I may.
Yes, ma'am.
Yeah. So today there is quite a bit of uproar in the IVF clinics themselves in USA, because once an embryo is transferred and if there are embryos that remain, which are accessory and which are frozen, the problem is many believe that life comes into the embryo at the time of creation. So it will also be very difficult now for couples to discard their embryos. They will have to continue paying a yearly fee to keep the embryos going, even if they don't want to use them. The other problem occurs is if you do PGT and you find out that this embryo is aneuploid, will you have the right to discard this embryo? Because many believe that life begins at the moment the embryo is created. So now overturning Roe versus Wade is going to bring unique problems even in the IVF field.
Yes, ma'am. We'll discuss that later, because in the Indian scenario, I guess we have the ART laws for that, and that's a bit different than what we have for the the US. But my immediate question now would be, now we have established that, Article 21 does respect the laws, but then after 24 weeks, for whatever reasons in India, it is a bit that there are different ways we can go for determination. So this is actually a very lab question, I would say, that we do screen for hemophilia and DMD. So in most of these cases, India does not have a guideline. Whatever guideline we follow are the ACMG guideline for reporting. Good labs which are NABL and CAP accredited, they follow ACMG guidelines. They don't give up carrier status. But if you look at many labs which are sprouting up, they do give carrier status, writing it as heterozygous, indicating it's a female fetus, and below they just give a disclaimer as likely unaffected. Now, how ethical is that in a country where PCPNDT Act exists? PCPNDT was brought in because we have a bias for female fetuses. So my first question would be to Dr. Meg, to please say that should genetic labs in India reveal carrier status, and should we come up with a guideline that, what should be done for the female fetuses with X-linked disorders?
Very good question, but I have my reservation, because in the PCPNDT law, it is written very, very clearly that we cannot disclose the sex of the fetus, whether it's ultrasound, whether it's your genetic, this carrier status or whatever. And we are prohibited from giving this diagnosis of female fetuses 100% sure. If you do that, then you are liable for the punishments. So what is my opinion is that in this condition, because now recently the ART law has come into force, surrogacy law has come into force, and also there are amendments that to be similarly PCPNDT requires an amendment, giving that those serious conditions like whatever hemophilia, other genetic counseling, they should be allowed with some reservation to declare the the sex of the fetus and their career status. Unless it is done, you cannot by law reveal the sex of the fetus and the conditions. That is as a
yes, Dr. Praveen, please.
Sorry, in PCP entity there is separate entity where here in this situation we can reveal the sex after consultation with the PCP entity authority. Of course, we need to have the proper genetic analysis report.
Okay, and my question will now go to Dr. Deepak Modi, asking, because he's a scientist, and my direct question is, are there no implications of misusing this?
Panchana, thank you for this wonderful question, and I think it will take a whole debate time if we go ahead. So you're talking of incidental findings now. I mean, in just a previous talk, most of us raised a hand for BRCA, that we were screening for something else, and now I got BRCA, should we report it or not? And half the population here said yes. But now it becomes an X-linked, and now suddenly we say no is also incorrect. And as Madam said at the same time, that suppose if it's a donor embryo, or if it's a donor cycle, which is again a debate in IVF, obviously as donors, they would not want any carriers to be brought into them. And at the IVF segment, we said that, okay, all the carrier screening has to be done. Now, when there is an embryo coming, which is abnormal, or we wouldn't call it as abnormal, potentially a carrier, should we not give it? So as a right of an individual, I would say, yes, I would want that information to be told to me. But at the same time, it's breaching the PCP and DT Act because it obviously reveals the sex of the fetus almost in a direct manner. So it's something which we need to deliberate upon in a more broader perspective that, okay, should we consider exceptions to it? Or we should say that, okay, we say that there is a potential carrier and not reveal the sex. And then eventually we can take a call. We'll have to evolve some guidelines.
I think it's a gray zone, and we really need to come up with better ideas because this shouldn't be misused. If it's misused, like the ultrasound, revealing the sex of the fetus can be misused. These reports can be misused to a greater extent, and we should be very careful. So, Dr. Anuradha.
So that's where actually counselors come into picture. That's where all of you will play a role. That's where you will have to talk to the family and explain to them that this is an X-linked disorder, and we will be giving you a report which says whether the fetus is affected or not affected. That's all we are going to give you. And the word carrier itself is also sometimes misleading. Sometimes when we say carrier, patient will feel that the baby is carrying the problem.
Correct,
So
correct.
you have to be very, very careful when you're talking to the patient and say that, see, if the baby is carrying one dose of the mutation, he or she will be exactly like you, as normal as you. And therefore, this counseling becomes extremely important in X-linked and and PNDT.
Deepanjana, hello.
Yeah,
I
Dr.
would like
Sani?
to add on with Duchenne, which we have been doing with more than 3,800 carriers we have screened. So the experience we have is, yes, the mother is a carrier. Okay, there is a family history. We understand. No, 1 minute, Annie. Yes, wait, let me go to the fetus. So now she conceives. No, she conceives. She has it. So no. 1 minute, Annie. Let me take it in the style I would want to. So she has conceived, and then we do the testing. Like prenatal testing is done. So we have already told them, yes, it's X-linked. The male is the one, the real affected.
Yes.
The other is carrier, so we don't see it. So it's fine. So as you rightly said, ma'am, we say the fetus is fine if we don't find the mutation.
Yes.
But on testing, if it's affected, then we say it is affected.
Yes.
And then it's the choice of the parent whether to abort or not.
Right.
So that is one scenario, which, yes, it gives we only say fetus. We don't say what it is. And that's how it should be done. The other thing I would really love Madam Feruza also to be there, because recently we had a IVF case with Duchenne. So, and they came in, the boy was 2.5 years old. And they said the mother and father were very clear because she had PCOD. The embryo was like frozen, and it was from a donor. And they said they don't know about the donor, and it was a Bangalore-based hospital which has done. And we found a point mutation, and the child is now in a gene therapy. They took the child all the way to the US and all. Unfortunately, the hospital had been calling them on and on saying, we still have the embryo, you want to keep, or you want, ma'am was saying, no, throw it off. So they were like, they didn't know, the symptoms were not seen till then. So they said, okay, let us go for one more kid. And she was in the 8th month or 9th month when they came to us with the symptoms for the first kid. See, there is no rules. See, we are trying to prevent going to the grassroots to say we shouldn't be having Duchenne kids. Let's do whatever is necessary. But here,
when they have gone for IVF, there is no protocol for testing any of these.
We will come to that, ma'am. We have a lot of questions, so we'll just
yes,
pace
so
up a
that
bit.
also needs to be addressed. But here we only say fetus as such, and we do lots of prenatals.
One request to everybody sitting over here. Many of us are associated with companies. Please ensure your company is not reporting a carrier, like not giving out the report. Just say as affected or unaffected. This is my request. We are working for varied companies. It is up to us to fight and bring this in. They are corporates. We are genetic counselors. This shouldn't be mixed. Exactly. So the next thing would be, actually, we have discussed this MTP Act, and we have discussed the 20 weeks laws, and we have discussed the extension and amendment to 24-week laws. But my question here would be to Dr. Jayashree, why was the landmark of 20 weeks chosen, and why was it extended till 24 weeks?
The landmark of 20 weeks was chosen in the earlier MTP Act because anomaly scan would be done between 18 and 20 weeks, and most of the anomalies would be picked up by then. And that is one thing. And to balance this rate of detection of anomalies with the risks involved with MTP at a later date, termination of pregnancy at 18 weeks, when we compare with termination of pregnancy at 22-24 weeks, as the period of gestation advances, the risk associated also will increase. So that's the reason why the 20 weeks cutoff was there initially, but now it has been extended to 24 weeks because most of the anomalies, some anomalies are detected better at 22 weeks, and sometimes they may take some time to take a
especially
decision.
the cardiac anomalies,
Yeah.
I guess. Yes.
And decision to terminate the pregnancy taken at 4-5 months cannot be taken in a day or two. So in order to provide the woman and the couple some time to ponder over it, probably the period of gestation was advanced to 24 weeks.
Correct. So another thing, what these acts, because these are bills and acts and whatever, they don't actually accommodate the empathetic part. You know, the couple can come from a different socioeconomic background, can come from a different religious background, and the personal considerations are invisible. The person might go through a separation, a divorce during the pregnancy, and where are we looking at that? The law is not looking at this. Sorry. So, so I'll come to this. So a twin pregnancy, say, was conceived through IVF. It's a case scenario. The fetus presented with club feet. The CMA came normal. There was no USG markers present. Even all prenatal scans, echo, etc., everything was done. But the child came back after 5 months saying that there is a heart issue, congenital heart problem, developmental delay, failure to thrive. Now, the couple is blaming the doctor that you did all the tests, then why is my baby affected? And it is negligence. So here there are 2-3, I would ask Dr. Praveen to take up the first question, is what is exactly, when we are counseling, when you are scanning or doing the invasive tests, what exactly should be the counseling points so that these also can be addressed?
Yeah, very nice question, because the moment they come to us and they think that once we have done that, it's normal scan, they think that baby is going to be 100% normal. That's very much wrong. Our counseling has to be proper in these situations. The ultrasound can detect structural abnormalities. Again, it is not 100%. Majority of the structural abnormality can be picked up. And some of the conditions, because of the maybe we have to see the condition of the mother with a high increased BMI and the position of the fetus, it can alter. Again, it can affect the diagnosis. And the person who is performing the scan also, what is his experience, whether he is following this proper protocol, that also matters. And also, some of the conditions can develop later on. For example, here, there is some cardiac condition has been missed. That's what claimed. So we need to know what was that condition. For example, the atrial septal defect, it can be functional during, and PDA, it can be functional during intrauterine life. We need to say this is normal defect during intrauterine life, and very rarely, say 1 or 2 out of 1,000, it may persist. So this is not in our hands. Same thing, some late evolving conditions like coarctation of aorta, pulmonary stenosis, these things can happen. So there are a lot of factors which involved, and also we have to counsel that we can identify structural abnormalities, not the functional abnormalities. That's the most important. We cannot say whether baby can have the hearing defect or vision, and developmental delays also.
So again, my point over here to all my colleagues is that when you get such cases and you are doing a post-test counseling, please reiterate very well. Not every condition can be screened. There are conditions which you are missing, and please highlight that in your recommendation notes that ultrasound does not pick up everything. CMA will not cover all the genetic testing, so that these patients or these couples does not come back to you saying that, there are issues. They should know that there are things that has not been screened. That is something very important. With that, ma'am, my next question to Dr. Meg would be, what consents should the primary physician take or the fetal medicine specialist take at this point?
All the fetal medicine specialists are supposed to be registered with under the PCPNDT Act. And as for the PCPNDT Act, for any genetic counseling center, genetic center, or genetic laboratory, Form G is given in the PCPNDT Act, in which the consent is supposed to be taken. Apart from that, it is very important if you are dealing with such complicated cases, there should be, as per my opinion, there should be informed consent also, because you are counseling, you are telling the patients risk and everything. So also you should take apart from your Form G, you can take this informed consent also. So that will cover everything as far as the safety is concerned.
Dr. Wilson, my question to you is here lies the importance of pre-test and post-test counseling. So for all my fellow GCs over here, what would you have written in your pre-test and post-test for these cases?
Thank you very much. It's quite difficult to comment because we don't often do genetic counseling for IVF. Because IVF, you've got patients going through it with fertility issues, so it's not something we talk about. But what I can relate it to is PGT, in that if a couple has an embryo planted that is only tested for one condition, we cannot say for certain that the baby's going to be absolutely healthy because we're not looking for everything. So I think it's a caveat that we talk about to say we're very happy to offer screening for this one condition, but please be aware that 2 to 3% of all pregnancies have congenital anomalies that happen by chance. That's not something that we can definitely rule out. I think from the sounds of the story above, that if based on the prenatal scans having club feet, it sounds like the medical professionals did everything possible in relation to that. So if they've done the fetal echo, they've checked everything, there's only so much we can do at that time. And so now it becomes about supporting the patients, about supporting that couple as they go through their decision-making process on what to do next.
Thank you so much. So I would go back to Advocate Rituparna on this. Just to highlight before even she comments, it was she who first told me that like doctors, genetic counselors, any allied medical professionals also has a medical legal insurance cover. Ensure your company has that cover for you, your hospital has that cover for you, or you can actually reach out like a Mediclaim and get that cover.
I have tried to reach out.
Ma'am, I have the cover.
Yeah, they have done it because we write a subjective thing. It is something like a pathology report, okay? And many counselors do not give a note. It is based on the note that you get into this and legal indemnity, okay? Legal indemnity for counselor, geneticists or lab professionals have it for the lab, and that is through NABL and all accreditation. So professional indemnity in hospital base for genetic counselors is not covered by the doctor's thing. There is a separate thing. Companies take it for the employees. It's not for genetic counselors as of now.
Not for genetic counselors, but individually you can ask. It
Yeah,
there
yeah.
is there. It
So
is there.
That's what I'm saying. So when we are talking of by and large genetic counselors and most of them working in companies, the companies take out a thing and they are responsible for the note followed by a signature. Okay.
Yes.
So maybe in the future, BGCI will take a stand and say that, okay, our certified counselors know the rules and they will, as that once they are certified, please give them and make them eligible for insurance.
The insurance cover which the allied like us people we get is not as much as the doctors, but it's a 5 lakh cover which we get. And I would request, not all medical legal companies are giving that out, but there are two which are, and you should reach out to them, the ones who are especially in the clinic scenario. So my question to Rituparna would be, like, how can we ensure, like, what should the lab or the center do to ensure this legal cover?
I think this has already been spoken about by Dr. Meg ma'am when she said about informed consent, because you will see that most of the patients your patients will understand only one particular part and not the entire scenario.
Right.
So informed consent should not only reach out to the parent, but parent of the woman. I think it should be also explained to the husband, the family members, because in our country, all these families and all, they do play an important factor in raising a child or in taking decisions of abortion, etc. So an informed consent which has to be written should definitely be taken. And secondly, just as ma'am was also pointing out right now, a certified panel of genetic counselors or doctors who are aware of all the nitty-gritties or the technicalities that you all are speaking about. I think even the courts should have the responsibility, because negligence cases will be there and we see them on a daily basis. So at least the courts and the bodies like BGCI, they should try and make a separate panel of these certified doctors who with their experience can give their individual and unbiased reports to courts, to judges, when these kind of cases come up. Because it's very easy to allege that there was some negligence, but there might not be cases of negligence despite written informed consent.
So again, another thing, informed consent, try to take it in the native language. Because it may so come up that you have taken it in English and people will come up and say that I didn't understand whatever was written there. I was asked to sign, so I have signed. So please, whenever you take a consent, ensure it's in the native language. It's in the language which your patient and the center and the family understands. So this brings to the next question, actually. So UK? Yes, ma'am.
So we take a recording.
Huh?
We record when we inform.
You have an informed recording. That's a very good way.
Informed recording, it's done. They say they have understood it. Then they sign it later. So that can be another thing that you all can think of in this age of, mobile
technology. Yes. So in this is the case in Calcutta High Court. There was a case of spinal bifida at
Now recording. You are attached to one company today. You move on to another company. Where are your records? Is the company responsible or the Let's not go into too much nitty-gritty as now Dipanjan. I'm telling you, you will get into more troubles and you're giving more confusion to the clinicians sitting here. And the few who are reaching out to genetic counselors will think 10 times.
Ma'am, normally this is for the centers which you are counseling. Like in the NICU setup, they do record, ma'am.
No, they don't. All NICU recordings are not done. Followed by a NICU consultation. When you have a parent consultation, that can be recorded.
Yes, ma'am. The parent consultations are recorded.
But my saying in the NICU, when I am looking at a case and recording in the case sheet, that is not recorded.
No. It's a patient consent we are talking about. When we go to an NICU and we are giving
in a NICU, if I am recommending an extended newborn screening, does it require consent?
No.
No. So that's what I'm saying. There are various things which require consent and which do not require consent. So it is not mandatory that anything any of us do, it should have a consent. That is not. Now, sometimes clinicians even say if you are putting out your hand, that is to give your sample, that is indirect consent that you're giving your blood, because you're doing so many tests without consent. In a hospital setting, once you are there, the consent is taken for invasive procedure.
Ma'am, consent
So
for
that is why
genetic
I'm saying
testing should
don't-
be taken, right, ma'am?
No. Consent for MTHFR C672 is not taken. It's not taken. For thalassemia screening, it's not taken. It is, no, in maternal screening, it comes in antenatal screening. So here you take consent because you are paying for it.
So there are different ways of the consent
That
form.
is what
For
I'm
example,
saying.
if you are doing MTHFR mutation or if you are doing some other thalassemia screening, the report itself is claims that these are the limitations of the test.
Correct.
These are the things that, so in those cases it's fine. But what I am saying is a recorded counseling session where you are actually taking the pedigree, talking to them, and then you're recommending something which they will take, and then they will take decisions based on your recommendations. If there is a possibility, like we have in our organization, a recording can be done. That always helps.
Fine.
That's
But it is not mandatory.
No, there's no rule that it is mandatory. Yeah.
It's not mandatory, but I would, it would be my personal opinion that it should be made mandatory, not just by these companies, but also by the government now. It's high time that we should do it.
Yes, and so now I just move on because we are running out of time. So the Calcutta High Court had chosen abortion at 34 weeks. This was a case of spinal bifida. Now, this actually raises more concern, like what is the maternal fetal conflict? Now, what exactly is maternal fetal conflict? That if Dr. Praveen can say that.
Yeah, the fetus has got rights. Basically, we have to see what type of fetal defect it is. If it is a major defect like anencephaly or a major like CNS abnormalities, or even for that matter, the spina bifida, open spina bifida. If you are detected early, of course, the path will be easy. If it is a minor defect like cleft lip or club foot, here comes the more confusion here. But as a fetal medicine specialist, what is our job is to say this fetus is like going to have a good prognosis, provided if we do these certain things, which we have to explain in detail. For example, we have to look for detailed other anomalies. It has to be done from a proper trained person. And we have to advise for invasive testing because there can be associated chromosomal problems. And after getting their like consent that they would like to continue, we would do these invasive procedures and rule out the chromosomal problems. Again, the counseling has to be proper, that we have not ruled out all the genetic abnormalities here. And there may be some associated abnormalities which we would not have picked up like 100%. And that they have to like understand that. And then intrauterine counseling with the team members also important. For example, if it is cleft lip, we can just like guide them to meet a plastic surgeon, and he can explain what are the outcome and what are the difficulties encountered and how the long-term outcome. He can give example. And pediatric team as well, what are the initial postnatal problems, feeding difficulties. And also, of course, obstetrician and the couple, the team has to work here. After understanding everything, if they decide to continue, and it's fine, but later on, if it turns out to be some genetic syndromes, it's again not in our hands. But when it is compatible with life and when it is salvageable, it is our duty to say that duty to support the fetus.
Right. With that, so if I explain maternal fetal conflict, it is that fetus is also a patient. So if the fetus is the patient, the mother is also a patient. But sometimes it may so happen that the mother might feel, because here we are talking about Article 21, the mother might feel, I don't want to carry this baby forward. Then what happens? But maybe the prognosis of the fetus is not bad. And here there is a conflict because probably the prognosis is good, but the mother does not want it. So here, how to counsel? So my question would be here to first Dr. Jayashree, that what is the right of the mother over here?
As I said, probably before the period of viability, the mother has the right. And beyond that, as I said, termination of pregnancy beyond 24 weeks, there is a board. And probably the formation of that board itself tells us that the fetus has a right of its own. The mother cannot decide that she wants termination of pregnancy for cleft lip or cleft palate. Even other individuals have to feel, the pediatrician, the radiologist, etc. I mean, the panel. If the panel feels that this pregnancy is to be terminated, only then legally she can, at least in India, she can go ahead and undergo a procedure.
Right.
I feel that the fetus has the right beyond
the maternal
24
right.
weeks. Yeah.
And what about Dr. Meg? What do you feel about the right of the fetus over here? It's an unborn child.
Yeah, I would like to again quote the MTP law, because as per the law, there are indications, and indications are one of the most important indication is a life-threatening situation for the fetus. So now we have to decide whether it is a very severe condition, or it is a a very it can be repaired or something like that. But there is this condition, on that basis actually legally it can be terminated, where there is no right of fetus, but it can be terminated. There is threatening this thing, grave injury to the mother and grave injury to the fetus. So I think I will consider the maternal fetal conflict. Mother is the main important component as far as
Mother is the driver of it. I will ask here Dr. Wilson again that like how is it difficult in UK? Like how do you counsel such cases?
I think it is really difficult, and I think it does come to understanding the prognosis of the condition, because we also need to take the mother's health into consideration by giving birth to that child. So again, it comes down to how long they are in the pregnancy, and as one of the doctors said, that there are people in place, there are consultants, there are ethical boards, there are ethical committees that we can discuss these cases with, so that we are providing the most accurate information to the patient and explaining what we can do in these situations. So I think it just comes down to absolutely supporting the patient, providing that information. Yeah, but at 36 or 37 weeks, that's a very difficult decision. And I think it is case by case basis. I don't think you can make a blanket ruling, and you can't say for any person in this situation it's the same. I think it has to be discussed individually.
Dr. Parekh?
Sorry, I was
in this scenario, because it's a very late gestation, in UK, I worked in UK, where they have option that feticide they do first and then they terminate. It is not routinely practiced in India, because here what's going to happen is 34 weeks, baby is going to be live. And what's the fate of the baby when we terminate it? Nobody is going to resuscitate 1 or 2 days. So this situation can be avoided by doing the feticide in these type of, when the court has given. So do the feticide. Not all the doctors, fetal medicine specialists will do because of the ethical issue, but there will be, I'm sure, some doctors can do this.
Yes, Dr.
In order to proceed with a feticide, though, it has to be agreed with many consultants. It can't just be a decision that's made by one person, because the mother has to be supported going through that, as well as the baby.
So I'm not going into details of the case, but there was a case where the couple have come to us, and the male partner has ectodermal dysplasia, not a single hair on his scalp, total lack of hair. And he said, I don't want to have a baby like this. It's an autosomal dominant with 50% risk. Now, when we tried to explain to him, I will not tell you what the decision he took, but I'm just telling this for the benefit of genetic counselors who can think about different ways of counseling. When I told him that there's no life-threatening issue, there is no problem with health, it's just lack of hair, he said, you wouldn't know what are all the problems I have undergone. You know, I couldn't get married. I had to go to some other state to get married. Nobody were giving me the girl. My sisters are not getting married. There is social stigma. I don't want my child to undergo something similar, although this is not a life-threatening situation. Now I'll leave it to you guys to think about these subtleties and sensitivities in your counseling sessions.
Again, non-directiveness. So here quickly, I'll take your opinion. Huh.
It's not just right of the mother, it's right of the father.
Yes.
We can't be so gentle.
Yes.
Exactly.
Okay, so Advocate Rituparna, please comment. Is it the judgment of the doctor counseling, or should the genetic counselors are taught to be non-directive, but patients come up and ask, what should I do? So
Yeah, that's because they know the best. The patient does not know. Like I'll tell you, I'm not a doctor. I don't know what goes on inside my body. So the moment I have fever, etc., I will reach out to a doctor, and whatever the doctor tells me, I'll do that. My decision whether I want to go my decision in directed by what the genetic counselor says. But that is actually how it should be, because they know the best. And just to add one thing, as we were discussing about rights of a fetus, in India, a fetus is a it's a legal person. There are laws in India that talk about the fetus being a legal person and having a legal identity, for everybody's clarification.
So my next question is, we do a lot of WES, and I'm sure all of you have seen a lot of TRF saying autism spectrum disorder, screening the index child for the next child. So let's say that we have such a situation and the parents come to you and say, we want a child who is 100% healthy. Dr. Anuradha, please take this up. And then in the report, you get a VOUS. That's complicated.
We want 100% designer baby. Yes, that's the desire of every parent. But then we also have to understand that usually all parents don't come to genetic counseling. When they come for genetic counseling, it's with some kind of indication. So again, we will have to counsel them that this is what you would get in getting your tests done. For example, carrier screening. We will be looking at only recessive mutations. And don't scare the patients. Don't give the list of the rest of the disorders that you cannot identify. That will really scare them. Be gentle in your approach. Use terms like optimistic approach, and let them take an optimistic approach. And then I think you can, as a geneticist, do your best. Here, I want to give a small example of carrier screening. Patients, this is a case that happened very recently. They have come to us, got carrier screening done, and we identified common mutation in a specific gene in both the partners. And we said, you have 25% risk for this. Immediately, they have gone to an IVF center and they have changed the donor. They've got the donor ova. And they did not test the donor ova. And they have had some other disease where the male partner and the donor were carriers of the same
we have questions
compound.
for that also later.
So when you're saying 100%, oh, I'm change kar deta hu, I'll do one donor ova, then I'll have a normal baby. Maybe not. You have to explain to them. And these are the things, and especially in carrier screening, especially in IVF setup, these questions, because they're already spending a lot of money, they want 100% normal baby, and therefore you'll have to counsel carefully. You have to understand where donor should be tested, etc., etc. I hope that answered a little bit of the question. It's a vast answer to give. So.
Yeah. So, Dr. Jayasree, can you, if a person comes to you for polygenic conditions, like sometimes they come for schizophrenia, sometimes they come for, cancer that, which is not hereditary. Like I have a lot of cancer incidents in my family and I don't want my baby to get it. But then again, autism. So what would your take be? Because you being the primary person where these patients would reach out to, what would be your counseling points?
If they would come to me for counseling, definitely I would refer them to the genetic counselor, because there are so many aspects to be explained, and I'm pretty sure I wouldn't be the right person. So I would really refer them, and I would seriously advise them to take the counseling. But then at times we have situations wherein one baby, as you have put it up over here, one baby is suffering from autism, and if they come to me and ask, if can you give me 100% chance that after meeting the counselor, after taking their advice and after doing everything which you advise us, am I going to have a normal baby 100%? Then definitely my answer would be no. But for explanation, definitely I would refer them to a counselor.
Next question would be, should a prenatal, we'll just answer a bit quickly because we are running out of time. And I'll just target this to Dr. Modi, saying that if we did not find anything, is there a prenatal or a preconception test done? Because I have seen certain IVF centers push that if you have autism baby, as ma'am was saying, let's go for an egg donation and nothing will happen. Or let's just do a prenatal and a whole exome sequencing and we know it's a good baby. Are these the right practices?
So this practice has three aspects to it, and I'll answer all the three of them one by one. So as a patient, as an index case, I would really want this answer that yes, can I have a disease-free baby? Because that's what I'm going to the doctor for. I'm not going to the doctor just for fun. I'm not going to the genetics lab just for fun. So I need that answer because I already have somebody in my family suffering. So that's as my right as a patient. Now, my right as a doctor or as a geneticist, I would say that especially in India, we have to be very careful while offering genetic counseling and genetic diagnosis for polygenic disease. The problem being that these are not monogenic inherited conditions where, it's exactly 1 in 25, as madam says, that we cannot give a number to it. And when we cannot give a number to it, subjectivity comes in. And the problem in India is that when we use these panels, the background data, that the frequency that yes, you are at high risk or low risk comes from the European or the Caucasian data, which does not apply to us correctly. Now, most of the genetic labs which I know, we do not know what kind of background data they're using to give us the polygenic risk score, whether that is relevant to our population. Classic example is a BRCA mutation. The BRCA mutation, the 4 pathogenic variants which are reported in the Caucasian population are non-pathogenic in our condition. But then we are taking a lot of clinical decisions. And that's largely being that we do not have this background data in this country. So as a laboratory person, I would say that we should not offer these tests till the background data is available, whether it is prenatal, pre-implantation, or even to the generic population, because you're going to base a lot of your clinical decision based on something which you're not even sure is right for this country. And therefore, societies like this need to have laws, I wouldn't say laws, but rather guidelines. That, okay, what should be offered? The problem being that we rely too much on the government. All the talks since yesterday to today that I've been hearing, we say, oh, we refer ACOG guidelines, we refer the American guidelines, and we want to just blindly adopt to this country. Why? I do not see a reason why there are no ISHG guidelines or BGCI guidelines. There have to be guidelines evolving out of societies, because even in the West, the guidelines are driven by societies, not by the government. And I'm sure Rituparna also mentioned in her statement that, it is this learned bodies which is going to drive how the legal system is going to take the call. So as individuals, as geneticists, as genetic counselors, as laboratory people, as doctors, we have to collectively take a decision what's going to work for us and what's not going to work for us. And I see both the presidents here, and I would urge that at least we should start developing guidelines, because these are the things which will continue discussing conference after conference and not have an answer, because we are not evolving our own practice. There are a lot of learned people here. So I think that there's no straight answer to any of these questions till we evolve our own guidelines, and we should identify burning issues. So that's just my humble submission to the entire spectrum here, that please let us seriously start thinking, and we should have the I guidelines, not the A guidelines applied on us.
Correct. And now I'll continue with Deepak, because this is a very sensitive topic for him, and is the ART bill that has come up. So, so this ART bill, I don't know how many of you are aware, but very quickly, Deepak, because I'm extending a bit 10 minutes from the tea break. Please, what is the controversy and why exactly is it important for us?
So the ART bill has multiple components there, and this is again largely being driven by the legal system, which is very unlike the Europe, where ESHRE drives a lot of guidelines which are being put for the IVF fraternity. But in India, because no guidelines evolved, and we want the legal system to do everything, so we evolved these legal guidelines, and that came with the problem. Number of problems, like for example, gamete donation, as Madam said, that okay, we take gamete from the third person. It's perfectly right. As a couple, I have the right to take the decision, but then the ART bill bans it. Should every donor be screened for a genetic disorders? I would say as a geneticist, yes, definitely yes, that they should be screened because we do not want problems like this. But then how many genetic disorders? Who will tell? The legal system has put that yes, screen for genetic disorders, but what sort of genetic disorders should be screened? Who will tell the legal system?
What if we get a VOUS? What will
if we get a VOUS? What will happen? Because we again don't have the background data.
We don't have the background.
We don't have the background data. So there are a lot of issues with the ART bill, and as a legal system, how to interpret the legal system lies on learned bodies like ours. So I think again, I reiterate the same point that these are again the very reasons why to solve these medical legal issues, like Rituparna will come to us for advice, and because we don't have advice, she will have to catch 5 people, ask the question, and then get the answer. But as learned bodies, we should start. So I think there are a lot of issues in this ART bill where the use of donor is concerned, because should we have the donor? Should we have a sperm donor? Should we have the egg donor? Because there are a lot of practices which have been done, which may systematically be right or not right. Some of them may have evolved out of our own requirements, and we have not taken care of our requirements, our patient requirement in this country. For example, when Madam was saying that 20 weeks may move to 24 weeks, most of our patients come to the clinic at 20 weeks. They don't even declare their pregnancies way before. I mean, we talk about doing all the screening in first trimester, but how many of us obstetricians do your patient come at first trimester? They don't. Now we have adopted the American guidelines, and tomorrow we will say, okay, let's do first trimester screening. It doesn't apply to us. So I think the same issues have happened with the ART bill, that we have put it on a system which doesn't have the right kind of, I wouldn't say the right kind of, but the right infrastructure to address it.
I will, because Madam has joined, like Madam's has been dropping. Madam Firoza Parekh, Madam Doctor, please tell me, in an IVF setup, when you're using donor gametes with the current ART bill, will you actually screen the gametes?
Very important question, and my apologies, for some reason my internet is not working too well and I was getting dropped, but it's an important question. In India, we are finding that young women, even in their mid-30s, are facing premature ovarian failure, and they are having diminished ovarian reserve. We have done a study where we have shown that the AMH in young women coming for infertility treatment is diminishing very rapidly. So yes, we definitely need donor gametes. And what we do in our program is we do the clinical exome for the donors and also for the biological parent, that is the father. So this is mandatory for us, because we face situations where in another clinic, as was said earlier, they had used donor gametes and the child had a mitochondrial disorder and passed away at the age of 1.5. So in our clinic, it is mandatory when we are using donor eggs to do the clinical exome.
Ma'am, what about VOUSs, ma'am? When you get VOUS, how do you counsel these patients?
So today's VOUS will become a definite, it will be not a VOUS anymore after a year or two. So the science is evolving, the technology is evolving. So one needs to say that this is a VOS. Today it is not significant. Maybe after a year it may be significant. So this is technology which is evolving. You have to take the patient into confidence and give them this information.
Quick question to Advocate Rituparna. So if a patient declines, says that, it's too much for me, I don't want to, do the test, do we need a written disclaimer from them?
Yes, of course, because without any disrespect to anybody, I'd tell you that these are exactly the same patients who would come around, turn around, and then leave no stone unturned to sue the hospital and the doctors. And I am saying this as a lawyer because we have clients coming to us who talk about negligence and other cases, diagnostic failures from diagnostic labs and all, and this is what they want to do. Informed consent, as we've already discussed, written informed consent is really mandatory from all of them.
So again, this is something which we practice in my hospital and my wherever I am attached. We do take a consent from them saying that they have declined the test. The test was offered and it was declined. So this is again a surrogacy.
Deepanjana, excuse me, I would like to ask the legal person about the the donor thing, which has already happened. Is there a law today to take upon that particular, because the parents have been asking us, and Dr. Parekh clearly said they have a system to screen.
Ma'am, even we have a system. We do the same thing.
But if we know the hospital, are the parents to ask the legal person? So no, they haven't done anything this particular. No, here it is a point mutation.
That is the reason why we need a carrier. What is the carrier status? What are the carrier frequencies in India?
No, that's fine, Deepanjana. Dr. Parekh was very clear. They do a complete clinical exome. Here, it's a very straight thing. The parents have taken a donor egg, and the first kid, it has, after 2.5 years, they observed symptoms. By then, the hospital was pushing them, saying, we have your, it is frozen and kept, you want it, how you're going to. So they said, okay, let's have one more kid, and they took it. And they said it's from the same donor. And by then, she delivered, the first kid had Duchenne. And it was a nonsense mutation.
Ma'am, there is no guideline to screen because we don't have a guideline. But as far as the ACMG guidelines or the ACOG guidelines stands, for IVF pregnancy, you are supposed to offer a carrier screening. The problem with India is, as ma'am correctly pointed out, we don't know what to screen.
If it is a donor egg, Dr. Firuz and others also screen for X-linked disorders such as DMD and Fragile X. And
So right
in
now
male, they ensure that CFTR is covered fully.
And it is actually given as tier 1, tier 2, tier 3, tier 4. So if we are doing a donor, we do tier 4 where DMD, MLPA, SMA, MLPA and exome all are covered.
No, if it's not done, then what do the parents do to the particular hospital?
Then we just have to explain the limitations
But there is
of
no
not doing it.
guidelines, ma'am. Parents can't do anything. It's a ACMG
Yeah,
guideline. It's not an Indian
I believe
guideline.
there is no law or any guideline regulating this, as you correctly said.
There is no Indian guideline. There's nothing to do.
So there's nothing. That's the answer.
So this that is the
I'll just add here 1 second, Deepanjana. Although there is no specific guideline or there is no law that really deals with this, under the gamut of negligence, that parent can still sue the doctor and the hospital, because this negligence before the consumer forum or in tort law does covers any such eventualities also. How far it will be tenable, that is a different thing. That is for the courts to see and for both sides to see.
Ritupana, since you're so much with this, can I ask the parents to get in touch with you?
Sorry?
Can I ask the parents to get in touch with you?
Yes, ma'am, you can.
I would not like to
can veto for her.
Okay,
Yes.
thank you.
Deepanjana, can I add something here, please?
Yes.
So when incidents like this happens, we as genetic counselors should raise awareness about these type of issues. Through BGCI, we should publish, we should write about these type of things in newspapers, magazines, and try our best to publish these type of issues and bring awareness among the common people who have no idea what they should do. And no one knows what SMA is. No, even the government people, they don't know what SMA is and what type of disorder it is. So we should try to promote our tribe.
We should have a guideline. So that is probably the underlying statement. And I just want to finish this. So please excuse me if I'm taking a bit of more time and rushing also. So there's an assisted reproductive technology ka bill hai, which also says that surrogacy was, commercial surrogacy was there very much. But recently we have a bill which says that surrogacy is banned. But we know Priyanka Chopra, she got a baby out of a surrogacy and there's nothing. Article 21 stands over there because she did it, again, not from India, from outside. But as geneticists, we do have certain conditions like the MRK syndrome, where a person might not be able to carry a baby to term. And here commercial surrogacy is probably the only way. I myself have 2 patients with this, and they have opted for surrogacy. So the question is that shouldn't we as genetic counselors, actually, because the government is thinking in terms of maluse of surrogacy, which is correct. I stand by that. But then shouldn't there be a board which actually reviews patients who have a genetic condition and where commercial surrogacy should be allowed? So my question here would be to Dr. Anuradha and then to Dr. Modi.
Yes, I think not just the physical uterine defects, implantation failures, but even things like, the physical
mental
phenotype,
retardations and mental
and
issues.
also the certain mutations like TUBB8. TUBB8 is responsible for spindle fiber work. And if that is disrupted, then there will be an embryonic development issue in the early embryo. And in such conditions, the patient will not be able to carry it. So surrogacy will be required, and we just need guidelines so that we can approve surrogacy and not do it
Please,
left and right.
Anuradha, listen. This is a bill against commercial surrogacy.
Yes.
It is exactly the same which was there about blood donation. Earlier, blood was donated with money. 300 rupees, 200 rupees per unit. Then a law came that there will not be any commercial blood donation. Similarly, here also they have not banned surrogacy.
Yes.
They have banned commercial surrogacy, that you don't hire your womb like you hire a house. But in the thing, there is a provision of surrogacy, where there is voluntary surrogacy, where
Altruistic
there is
surrogacy.
familial
Yeah.
surrogacy, where there is, all kinds of. So here they have just removed the commercial aspect of it because young women were being used, and it's the same for commercial renal kidney donation. So don't say that the law is to be criticized. The law was brought into
the
place
misuse
because
of the
they were-
surrogacy should be
because it was being
criticized.
No, the misuse of the law was there, but the problem is
So they have made it still voluntary. You can still do voluntary surrogacy.
Yes, ma'am, but how many family members will volunteer for a womb?
That all we don't know. We are doing it for renal. You are seeing it now for renal. Then do you think it's more than that? No. We are talking about voluntary and commercial. So we can go into the law and look at it.
No, we cannot equate these two. No, fertility issues are a larger context because every couple wants to have a baby, and getting a commercial uterus is far more a difficult condition. Number one. Number two, no woman is going to just give her uterus philanthropical. In women are not philanthropic bodies. कि, okay, चलो मैं अपना uterus दे देती हूँ. Let's not make women as commodities. So absolutely, immediate family members, and especially in ART infertility, often it runs in sisters, and usually infertility we also see in issues where the absolute sisters and the immediate cousins have an issue. How can that be just said that no, we cannot have commercial? It will be, and it's a woman's right as well that she's spending her 9 months of time. She's giving out a uterus, she's putting in a lot of energy, and as a woman, she needs that money. Why not? It should not be for a commercial reason, and there should be a board which can assess that. How much money to give can be assessed, but we cannot just blindly say that no commercial surrogacy. I think there's a problem.
Again, gray areas, guidelines needed. So PGT as a tool. So we all know we have been using PGT, but again, the ART laws actually have said that PGT cannot be used unless there is a genetic condition. So very quickly, like extremely quickly. So PGT as a tool for healthy baby. Dr. Meg.
I will recommend it. On the contrary, 1 minute. There are newer guidelines from the government that now they are promoting the pre-counseling, clinics, prenatal clinic, pre-counseling clinics, and UNICEF along with government of Maharashtra, we are having. So I will recommend it as a tool for the healthy babies. This is my recommendation.
I would also ask over here, so is then PGT-A or PGT-SR banned?
No,
Because then there's no pre-existing genetic condition.
No. See, when we are talking about rights of people, PGTA right also should be discussed in the sense. But if a patient or a couple had multiple recurrent pregnancy losses, and the way of reducing the recurrence pregnancy losses is by doing a PGTA and transferring a euploid embryo, why remove that right from a couple? Then they have all right to go in for PGTA at that time. I mean, this is just my personal opinion, but so I don't think there has to be a ban. What is important is proper counseling should be available so that the couple can take a decision. Anyway, it is
Agreed, ma'am.
expensive.
Totally. I
no-
think ultimately it comes back to counseling.
Yeah,
So I think I'm so sorry to cut you short, but I think we've established very clearly that counseling, especially in these cases, has to be done pre and post test.
Yeah.
And we need to actually have qualified genetic counselors for the same. So we are running extremely short of time, but I'm just going to quickly ask you to wrap up. Thank you.
I will cut off. Thank you so much, the panelists, for being here. Also, the offline, the online and the offline panelists. Thank you, everybody, for bearing with us for the extra time. And I thank JSS Hospital, Dr. Deepa Bhatt, Dr. Pooja, and Prochi Madam, and Annie Madam, and BGCI for giving us a platform. Thank you so much.
Thank you.
Here, I would like to say one thing.
I request all of you to please be on stage. Yes. Sure, ma'am. Ma'am.
I'm an academician. So what I heard, I just wanted to see what is the root cause, because when we are talking about going for screening, so we don't have any database of our population. So the first step is we have to create our database so that we know what is our population, what are our problems, so that accordingly we can go for screening or whatever suggestion. So I feel, genetic counselor and genetic data is the first thing which we need to establish. Successful manner, the other things.
Agreed, ma'am. I think
just
on day one, we all agreed that all genetic counselors are going to be working together collaboratively. I think that's the first thing we're going to do, publish Indian data. And soon to be followed will be the guidelines and everything else accordingly. So very valid, ma'am. Thank you. I would now request, Dr. Banwar to please come on stage to hand over the mementos to our faculty this session.
Can I just say thank you very much from myself and my colleague who spoke to you yesterday from the UK. Thank you for having us here and thank you for allowing us some time to speak to you. It's been lovely to listen.
Tin, please stay online. We would like to take a photo of all the panelists.
Okay.
You can just hold on for another 2 minutes. Dr. Mandakini Meg, Dr. Firza Parikh, please stay online.
Yes.
For just 2 more minutes. Thank you. I request Dr. Banwar to please hand over the memento to our speaker, Dr. Anuradha Odumudi. I request Dr. Banwar to please felicitate Professor Parveen. Dr. Jayashree. Dr. Praveen NS. Dr. Deepak Modi. I request Dr. Banwar to also felicitate our brilliant moderators, Dr. Prochi and Dipanjana, Dr. Dipanjana. And Dr. Dipanjana Datta. Okay, one final group photograph. And session wise, session wise. Thank you so much. Thank you, Dr. Mandakini Meg. It was really great having you here. Dr. Firuza, Tim, thank you so much. I know we've had a lot of issues, especially technically to reach to you. But in spite of that, Tim, we are very glad that, we could make this happen. And I think it was a brilliant discussion. I think going forward, there are going to be more such discussions. Rituparna, we missed you. Did you just come in?
I did.
Oh my God, we dropped off.
Okay.
Okay, I'm so sorry, but we're going to finish
Absolutely
up
all
you.
right.
We're going to
Sure. Thank you so much.
Okay, thank you so much for your valuable suggestions and discussion. Thank you so much. Have a great day.
Hi, Firoza.
Hi, Manda.
Thank you.
So we'll catch up later.
Yes.
Thank you very much.
Bye-bye.
I'm so sorry, Firoza ma'am. We had more questions for you, but we couldn't get you. I'm so sorry.
Not at all. My pleasure.
Okay,
We will
bye-bye.
have a separate discussion on this later.
Certainly.
Thank you, Ritu. Thank you, Dr. Wilson.
Thank you very much for having
Thanks,
us.
everyone. Bye. Have a nice time.
Bye-bye.
Thank you. Madam, game one for emojis for meeting us. Yeah. I'm talking to
everyone, I want to hear a big hi. Not loud enough. Sorry. Not at all loud enough. What is this, young genetic counselors? I can hear loudly from Annie, ma'am. Okay. So we've quickly come to the end of 3 days. Can you all believe it? I can't. Anyway, so we want to begin this valedictory by an invocation song. I request Madhavilata to please come on stage. Before that, I would like to also invite Dr. Annie Hassan, President of BGCI, to come on stage. And please take your seat. Dr. Lakshmi, Vice President of BGCI. Dr. Jaya Vyas, ma'am, please come on stage. Dr. Prachi Madan. Most importantly, our home for the last 3 days, thanks to JSS. And on behalf of the entire JSS, I would like to welcome Dr. Pushpalata. Please come on stage, ma'am. Percy, sir, you are wanted on stage. It will not go ahead without you. Dr. Akila Prashant, please come on stage. Dr. Deepa Bhatt. I now hand it over to Madhvi.
या कुन्देन्दुतुषारहारधवला या शुभ्रवस्त्रावृता या कुन्देन्दुतुषारहारधवला या शुभ्रवस्त्रावृता या वीणा वरदण्डमण्डितकरा या श्वेत पद्मासना या ब्रह्माच्युत शङ्कर प्रभृतिभिः देवैः सदा वन्दिता सा सरस्वती भगवती जाड्या जाड्या
Thank you so much, Madhvi. So, I want to hear from the crowd. How was JSS? What? I want to hear 3 cheers for it. I want it as loud as possible. Hip hip. Not loud enough. Hip hip. Once more. Hip hip. Still not enough, but still, I'm going to assume that you had the best time here. Have you gone around the entire campus? Hello. if you had participated in all the fun activities, you would have got an opportunity. Okay, we are talking in front of the president and the vice president. So we're going to cut down on this. So I'm sure you all enjoyed the stay in the last 3 days. And we are really thankful to JSS for giving us this opportunity. It was a big pleasure. After living in metro cities, Mysore was a real breath of fresh air. So in the last 3 days, we've covered what? We are short of one session, right? We've covered 2 pre-conference workshops, 5 sessions in independent specialities of medicine. So as I call out every workshop, I want to hear a yes. Did you learn something from pre-conference workshop 1, a patient interactive session? Couldn't hear. Thank you. Please know that unless you give me the same yes, I'm not going to move ahead. Pre-conference workshop on genetic counseling and genomic education. You learned something? Really? Okay, we'll see that in the next BGCI exam. Okay, let's see how many of you actually come. Then genetic counseling in first skeletal and musculoskeletal disorders. Wasn't that the best session? Every session was awesome. Okay, the next one, genetic counseling in. What was the second one? What is the second session? At least the moderator should know. Oncology, cardiology. We had Professor Davinder Kumar speak all the way from UK. We're going to, next time he's going to come here in person, FYI. Ma'am, we have to invite him in person next time. So last session, oncology. Super. Super. Okay. Genetic counseling in ophthalmology. I want it louder, guys. Thank you. And genetic counseling in reproductive medicine. Okay, it died. You got tired. Okay. And we have neurology coming up, but I want to hear a yes for that already. Okay. We'll go ahead later at the end of it. So we have covered quite a bit. So this whole conference was to ensure that you have understanding of all the different, types of disorders in each segment, all the different technologies that is currently available, and how do you actually use genetic counseling to actually impart that information to your patients. And I hope in the last 3 days, you've actually got to know your peers, right? Exchange numbers, shared your goals, because we want all of us to work together. And this is not going to end here. So we are going to connect very soon. So at this point, I just want to mention that we had 2,300 participants. About 400, about 350 in person and about 2,000 virtually. So imagine even if all these 2,000 of us, right, have 10 students or train 10 counselors, we have our golden number. I will not stop stressing on that enough. Please remember that it is important for you to grow so that you help others grow. So at this point, I would also like to invite Dr. Jaya Vyas to introduce our judges for the abstract and posters. Do you know how many abstracts we got? Take a guess. Yeah? Who said 100? I think you already saw it somewhere. Yeah, but can you believe we had 100 abstracts and posters? That's a great number. How come? I'm sorry. I correct myself. It was 112. Those 12 people, I think, sent it on the last day. That's why I don't have the count. But we had amazing participation. And next year, all of us should have actual publications too. not just abstracts and posters. I now request Dr. Jaya Vyas to introduce the judges and announce the winners of the abstracts and posters. I got it.
Hello. Yeah, so this is a very happy moment for BGCI because we are going to announce the poster awards for this year. And I'm very happy to say we received 112 posters which were to be evaluated. Each poster was evaluated by 2 judges independently. And we had a panel of 10 judges, esteemed honorable judges. And I can just list out the names which you will be seeing on the screen as well. Dr. Smita Rao, yeah. Miss Deepika Nathan, okay, from USA. She's from University of California. Her CV is being projected. Miss Vishalakshi Kamath, Dr. Sirisha Mova, she's from Newburgh Diagnostics. Dr. Tina Koshe, she's from Sri Ramchandra Institute from Chennai. Dr. Hema Prasad, she's from Osmania University, Hyderabad. Dr. Amy Shah, she's from Wadia Children's Hospital, Mumbai. Miss Ariba Khan, she's a cancer genetic counselor at Guy's and St. Thomas NHS Foundation, UK. Dr. Dhanalakshmi Shetty, she's from Tata Memorial Center, Mumbai. Dr. Noor Sheikh, he's from King Abdulaziz University in Saudi Arabia. So all these judges actually have been requested to be online. I don't know how many are there. You can check that.
Ma'am, all of us are watching virtually. Guys, one more big round of applause. They're all virtually watching us.
Yeah.
Thank you, all the judges.
Yeah, I'm so happy. A big thank you to all the judges who have joined. So I'll quickly read out the judging criteria and then I'll request the judges to give in their comments and share some encouraging points to the students who have applied. So the abstracts, for total 4 marks were there for abstracts. For data, 2 marks, 1 for presentation, 1 for quality. E-posters, total 7 marks, content 1, novelty 1, clear presentation 1, visual look 1. For video, 7 marks, presentation style and clarity 2, content 3 marks for keeping requirement timing up to 3 minutes or 2 marks for exceeding the time for 4 minutes and 1 mark for videos over for 4 minutes, for videos which were more than 4 minutes. And for abstracts which were submitted after the deadline, 2 marks were cut. And we will add from the backend in the portal. Means this was actually added by the MICE people because they were actually knowing that when these posters and abstracts were received before or after the deadline. So the total marks for judging the posters, videos, and abstracts were out of 20. So I'm very, very happy to say that there has been a very close competition and we've got actually a number of people who have been getting the same marks. So for the third prize, we have actually 4 candidates. I will read out the name and one of them is here. So I'll request her to be here on stage. So third prize goes to Nupur Thakur. I think she's online. Acha, है ना? Okay. Acha. Okay. Prachi will collect her for her. Dr. Amy, I'll request you to give the Prachi. Sorry. I request Dr. Amy to present. Okay. I know. I said Dr. Amy only. I'm so glad she's here actually. Can you read the title? Yes. Her title was on Importance of Post-Test Genetic Counseling in Establishing Genotype-Phenotype Correlation, a case-based study on rare findings in ZNF699 gene. The second candidate who got the third prize and who is here in person, I would request her to come, Miss Tejas Bhende. Her abstract title was Assessment of Cancer Patients Using Distress Thermometer to Evaluate Perceived and Calculated Stress in order to identify individuals requiring additional psychological support.
Tejas did this work with us at Kamini, and I somehow felt it was good enough.
Yeah.
It was anonymized. So I was not involved. Just clarify.
Okay. And the third person who got the third prize is Madhavi Panpalia from Jaslok, SURF1 related Leigh syndrome, a nuclear mitochondrial disorder with autosomal recessive inheritance. Her prize and award will be sent later on. Yeah, the fourth prize also goes to Arundhati Athale from Jaslok. The title is Pre-Implantation Genetic Testing and Genetic Counseling in a Couple with Identical 7 Variants of Uncertain Significance in HYDIN gene. So coming to the second prize, which goes to 2 people, and the name, the second prize goes to Ria Fernandez. She's from Newburgh Center for Genomic Medicine. Her title is Importance of Paternal Family History in Ascertain Risk Assessment in Cancer Cases.
Anybody from Newburgh? Vishaka can come. Yeah, just give the certificate. Yeah, he has this.
Name is. The actual certificate will send later. Okay. We the second prize goes to Inder Mohan Singh Sandhu. Yeah. So Mr. Inder Mohan Singh Sandhu is in person here.
Yes.
He's from Sri Guru Ramdas Institute of Medical Research and Science. Congratulations. He presented a work on importance of prenatal genetic counseling in rare genetic disorder and experience with hereditary thrombotic thrombocytopenic purpura, a case report. Okay. Now comes the first prize. This is also for 2 people. And yeah, so the first prize goes to Anusri Singapore. She's from Newburgh Center for Genomic Medicine. I think Newburgh should be really proud today. Abstract title was Post-Test Genetic Counseling for NIPT, High Risk for Trisomy 13.
Vishaka, the only one here from Newburgh?
I think you can stay here, Prachya, because the next one is also going to Newburgh, apparently. So the first prize also goes to Newburgh Center for Genomic Medicine, Akashi Vyas. And the abstract title is PCDH19 gene-related epilepsy following X-linked inheritance in mosaic male, case study and genetic counseling. Sorry. I'll request if Dr. Amy Shah is there online, I'll request her to say a few words of encouragement to the students and how was her experience in judging the abstract and posters.
Good evening, everyone. I hope I'm audible. Please excuse me for my voice. I'm just under the weather a little bit.
Yes, Dr. Amy, please continue. We can hear you very well.
Yes, I'm so thankful. This is my first experience to be on the other side and to be actually judging the poster instead of presenting one. And I see that the other side is as difficult as the first side. So kudos to all the participants who were there. It was a very, very difficult job. It wasn't a 5-minute job at all. And what I'm happy to see is what sort of young talent is actually going to come across post the exams and what we have to look forward to. And I have already had the fortune to interact with some of the genetic counselors, or in the past few years that I've been practicing. And I hope that many more come into practice, and that we can expand our genetic family, as I call, so that we can provide the best possible genetic care in India, just like all the other foreign countries are already providing, so that we can catch up to them very, very soon. So all the best to all the participants. I think other than the ones who actually won, even the ones who didn't, don't need to lose heart at all. I think it's just good enough. In fact, it's the best that you've actually given a try and come up with a poster. So just keep at it and do your best. Thank you so much for having me.
Yeah. Thank you, Dr. Amy. I really agree with you. There was a very tough competition, and the list will be just scrolled down, and people can see that they've just missed by a half a mark or like 1 mark or something. So it's been a real close competition. A big congratulations to all and everybody. And with this, I hand over to Pooja again.
Thank you so much, Dr. Jaya. So before we move further, as genetic counselors, another thing we should remember is that as much as we are, into helping our patients, it's also important to help ourselves. So there is a possibility that in our profession, as we are practicing, we may face challenges or we may need support. It is totally okay to take help. We as counselors can reach out to other counselors, other therapists, other professionals, clinical geneticists, anybody to take help. It's most important to also remember that we are not alone. So that is why a fun aspect was introduced into the conference. I hope you had fun in the last 2-3 days. So we also had a few games, and I'm just going to quickly announce the winners, and I would request the winners to come up and Lakshmi ma'am to hand over the prizes for the same. So the first major event we had was the musical chairs. So how many of you remember that? I request Sachin Chaurasia, who won the game, to please come on stage. Run as fast as you ran for the musical chair. We don't have time. Go ahead. And today we had a couple of more games. We had a team event as well as an individual event. We had a game called Red Light, Green Light. And we have the winner, Neha Ranjit. Please come. I request Dr. Prochi to hand over the gift. And we had a team event as well. It was a rapid 30-second game where you had to act out the chits quickly. So we have a team of 5 who won this. So I quickly request all of you to come on stage. Riya Ratna, Prachi Namdar, Vishaka Mali, Devi Surya Narayana, Nandini. Please come on stage. And I request Percy sir and Dr. Pushpalata and Dr. Akila Prashant. We have enough people. And Dr. Akila also. No, it's one each. They're all in different companies. How will you share? Your companies will get into fights with us. And at this point, I would definitely have to mention that the gifts were sponsored by Unipath Labs and Lilac Insights. So that also means that join these companies, you will get to have fun as well. Thank you. I quickly request Dr. Annie Hassan to share 2 lines, just 2 lines, ma'am. Then that.
2 minutes to talk or 2 lines? I think we really enjoyed this. I would like to thank JSS, everybody who participated as chairpersons, speakers, faculty, moderators, and participants. One thing I'd like to tell you, next time I expect all of you to come early enough for all the sessions. Okay, thank you.
We should learn to stick to time like Annie ma'am. She's leading us by example. Then I request Dr. Pushpalata, please share a few thoughts.
Pranams to His Holiness. I think it was a great opportunity for JSS to host this BGCI conference, the 7th international conference. I think we thank BGCI from JSS Academy and from JSS Medical College and from Department of Anatomy. And I think I thank Annie Madam for trusting Dr. Deepa Bhatt and giving the opportunity for her to host this. And a big round of applause for Dr. Deepa, Dr. Akila and Dr. Pooja. Though it was very difficult to coordinate because from the department and Deepa with she was in between the department from the JSS and to the BGCI. And it is, thank you, Madam, for trusting us and giving us this opportunity. Thank you, one and all.
Thank you so much, Dr. Pushpalata. I now request one person from the audience, only one, to come on stage and share your experience as a participant. Somebody who is non-BGCI. Yes. Thank you, ma'am. Claps for her, guys. We have Dr. Prasanna Kumari.
Hello, everybody. Hello. I am Dr. Prasanna Kumari from Bangalore. Really, it is a wonderful session. I never attended of this kind. That especially the last session was very informative and message carrying session. Sorry, I'm breathless because of 4 steps. I am all that. And I'm interested to join this. I'm behind Madam since yesterday. I'm pursuing her because I'm carried away. I have served as a cytogenetist nearly 40 years. By accumulation of knowledge is not enough. Discharging as a diagnostic person or reporting to the clinician or the patient. And a bridge required between a clinician, genetist, and the patient is required. It is a 3-way bridge. It's a triangle. I realized that now I realized the lacuna in my work style, and I would like to fill that gap. So I would like to pursue this. I would like to use this platform for my future service to the field of medicine. Really, this session, all the sessions which I have attended are carried me little forward, and it has given me more confidence and courage to continue in this field. Really, I was little disturbed My friend was discouraged. It is not an easy job, but I have taken it as a challenge. I will look forward. I will take forward with the cooperation of everybody. And thank you. I'm thanking the organization as well as the people really involved directly or indirectly for the success of this event. Thank you, one and all.
Thank you so much, Dr. Prasanna Kumari. So we've learned two things from what she said. First, we have to work together as a triangle. Please remember, it's not the Bermuda Triangle. We have to ensure that it's a triangle where whatever efforts we put in will show. We just need to have patience. And second thing is, I'm sure a position of a genetic counselor is going to open in her center. Please reach out to ma'am. Thank you so much once again, ma'am. So I now request Dr. Deepa Bhatt to please share the vote of thanks.
Yes, I can't believe that we have come to an end. Maybe it's a beginning of next 2023 conference, seeking the blessings of His Holiness. I have a long list to thank. Please bear with me for this. So at the outset, I am extremely thankful to my JSS Academy of Higher Education and Research and all the administrative authorities for believing in me that I will be able to, through my institution, handle this conference, especially Pro-Chancellor, Vice-Chancellor, Registrar, and everyone. And from my institution, I would like to thank my principal, Dr. H. Basavanagodappa, and our administrative officer. And especially my department, I'm extremely thankful for readjusting I'm basically an anatomist. So all the responsibilities with 20 courses plus courses with the clinical as well as this responsibilities, they without anything they have adjusted with me. And from past 8 months, they have borne with me. I'm extremely thankful to my department. And also my fellow department who has been at Department of Biochemistry with Dr. Suma as Vice Principal and HOD, and also Akila ma'am, with whom we have really been from past 5 years are able to establish this Department of Medical Genetics and Counseling here. Thank you. I will fail in thanking if I do not mention my all non-teaching and supporting staff, starting from electrician to internet, everybody who have been behind the scene, but definitely if today this conference is very smooth, it's all because of them. Thank you one and all. Coming to BGCI, yes, ma'am. I'm extremely sorry if I have been at times, it was the stress. So thank you, BGCI, and each one of you who have been really, it was a learning lesson for me to connecting with people, expanding the horizons. So it was really wonderful experience. So everyone in the BGCI, I wholeheartedly thanks for considering us for this conference. I would like to thank all the speakers across the world who have been very wonderful, who have shared their experiences and expertise so that it's just exchange of knowledge so that we will take it home and apply it. Thank you. And all the renowned in your own respective fields who are sitting in the audience, thank you all for physically coming all the way and being with us and making, so the audience was full even on Sunday. That made me feel elated. And I would like to thank the chairpersons, moderators, online, offline delegates without whom this wouldn't have been possible. And also all the organizing committee members who were behind me and helping me in planning, executing this conference. Then I would like to thank our academic partners who were generous enough to give their sponsorship and help us to conduct this program. And I would like to also thank the MICE who have helped us in coordinating this event. Thank you, MICE, and all who are representing here. And maybe a final word, there are 3 people with me who have been really wonderful, and a big cheers to Pooja, because we really coordinated well. In my absentia, she made it and we both coordinated, and she was a wonderful partner to work with. And there is one person who has been in JSS it would be really, really, I have to acknowledge her because I was sick and I was not in Mysore. All my responsibilities were delegated by her. And I would like to thank Mrs. Savita from my department. And big round of applause because more than me, she has worked for me on behalf of my institution. And like yesterday, we had ordered 325 food and 500 people have eaten, and it's all adjusted. It was because of her. So many things. And the last person, and I must really thank, is Percy sir. You have always been our stress buster every time. And the common word he used to tell is, don't worry, the Pan Puja will handle ladies. So this was and really thankful, sir. You were really our boost, and really you gave us that every time we were feeling low, and you elated us and made us feel that, yes, we can do it. Thank you so much. Backbone, really. And I apologize if I have missed out someone. And I thank each one of you for making this a success. Thank you.
Thank you so much, everyone. We're going to quickly start the session because we have our speakers who are already online. For those who missed, these were the number of people who attended in person. I hope you can all find yourself in the photo, maybe. And those who missed, learn to be on time. Learn from Annie ma'am. Sorry. Okay, so we'll quickly move on to the next session. Of course, we're going to see you again next year. But now I request our genetic counseling in neurology session moderators to take over. I request Dr. G. Madhavilata, Senior Genetic Counselor, who's moderating this session in genetic counseling in neurology, to please come on stage and introduce the chairpersons.
we have come to the last session of the conference, but it's the most important because we are talking about brain. Now we know brain controls thoughts, memory, emotions, touch, vision, breathing, motor skills, and every process that is regulated in the body. So the last 3 days, all that we discussed about, even now I'm talking, we have certain skills, and all this comes from here. And there are disorders that affect this. Okay, it's the head. And together with the brain stem, the nervous system, it's called the central nervous system or the CNS. So we know now neurogenetics is the field of study that attempts, I would say that attempts to better understand the genetic causes of the brain disorders. So we do not understand brain as much we know, and disorders of the brain is a huge challenge. And yes, there are disorders that do not affect the intellect, that do not affect cognition, but they only affect movement. So there are conditions which are again childhood onset, adult onset, which do not affect the intellect, and there are disorders which affect the intellect. So we did learn some of them under neuromuscular, along with muscular disorders, where in yesterday's first session. Today, most of them, what we will be seeing is about movement disorders. And we'll have a nice panel discussion about certain tests and what is the precision genomics approach. So we have 4 good talks lined up. So let me not take much time. And Dr. Prashant, he's my co-moderator. He will be introducing the chairpersons. We have good speakers and very awesome chairpersons lined up. Dr. Prashant, please introduce the chairpersons. Thank you.
Hi, good evening, everyone. Happy to see all GCs sitting here, and it's very important session. Now I'm speaking around 2.5 to 5 lakhs neuron firing at a time in 1 minute. So it is very important for GCs, and already I'm working since last 4 years, I believe, madam. 2016 with Dr. Annie ma'am, and then that's how I developed my interest. And very happy to moderate this session. I'll introduce our first chairperson, Dr. Harsha Sundarmurthy. He is a MD Medicine and DM Neurology. He is a head of department and professor of neurology in JSS Medical College. He is MBBS, MD Medicine and DM Neurology. Additionally, he is a Professor M. Vishwanathan Diabetic Research Center and MV Hospital for Diabetes. He has done the degree in that. And career highlights are the Movement Disorder Society is a member of that. Indian Academy of Neurology, IAN, he is a life member. And American Academy of Neurology is a member for IAN. Welcome, Harsha sir. Now I'll introduce Professor Prakash Babu sir, who is a PhD. He is a chairman for Institutional Committee for the Stem Cell Research. Asian Institute of Gastroenterology is a member. LV Prasad Eye Hospital, Jipmar Pondicherry is a member research advisory committee, Nizam Institute of Medical Sciences. Academician, he has done his graduation from Acharya Nagarjuna University, Guntur, and masters from Andhra University, Vishakhapatnam, PhD from Hyderabad, and postdoctoral training from the Research Institute for Brain and Blood Vessels in Japan and King College, London, UK. His area of interest are cerebral ischemia, glioma, meningioma, and cerebral malaria. Please welcome, sir. So shall we start with first session? Harsha sir, you can start with introduction of our first speaker.
Good evening, everybody. At the outset, both of us thank on behalf of ourselves, the organizers, for giving us the opportunity to chair this session. Like in the introductory part of this session, it was told that brain is an important organ, and all of us have finally realized that brain is important, but neurological disorders and genetics go a long way back. You know, when we started out long back, I have belonged to an era when neurology was practiced with very what looks like very crude technique, pneumoencephalogram, EEG, angiograms. Can you believe that we had no CT scans when I started my career as a junior resident in neurology? It was that stage. So you can as well imagine what exactly was happening in the field of genetics. Absolutely, we were zero. In fact, the only diagnostic tool finally, which we used to have in many of these developmental disorders or neurodegenerative disorders, as we call them, was a direct tissue biopsy. It would be a brain biopsy or it would be a muscle biopsy, and many different stains and pattern of illness would help us make a diagnosis. But as technology has evolved and by leaps and bounds, today we are into the field of genetics. And because of genetics, gene sequencing, and many other things, we are avoiding many of these traumatic procedures. And today, just by taking out a few ml of blood and analyzing them, we are able to find out the genetic abnormality. So it's more like a syndromic approach. So if a patient fits into a particular syndrome, we do the genetic sequencing and find out if the genetic abnormality is there in the particular chromosome or the sequence, and then make a diagnosis. And more importantly, it helps us in doing genetic counseling. I'm really proud to see so many of you around here. Maybe many of you will not know that even our national conference will have as many people as this. So I'm really happy that genetics is really taken off. Now I have the proud privilege of welcoming our first speaker. She is speaking on a very important topic. It's not common in our part of the country, that's or even anywhere in country, that's X-linked. It's an X-linked disease. Starts off with a dystonia, then evolves into a Parkinson's disease. And she is Nisi Grace from Philippines. In fact, this particular disorder is endemic to Philippines. She has finished her Bachelor of Science in Nursing from Philippines and then done a Master of Science in Genetic Counseling from the University of Philippines, Manila. She has got interest in neurological care and research, and she is particularly interested in the natural history of X-linked dystonia and Parkinsonism. She is a part of the collaborative center of X-linked dystonia Parkinsonism in Department of Neurology at Massachusetts General Hospital. Over to Lizzie.
So hello, everyone. I'm really honored to be joining you today on your 7th Annual International Conference this year. And I thank the officers, faculties, and organizers for putting up this wonderful venue to learn and be inspired by the speakers we heard so far. So I am Nancy Grace Ganza, and tonight I will be sharing to you genetic counseling of X-linked dystonia Parkinsonism, a neurologic disorder of Filipino origin. So before I proceed, I would like to disclose the following. I am a genetic counselor and a clinical researcher at the Sunshine Care Foundation for Neurological Care and Research based here in the Philippines. It is a non-government organization which caters to the needs of patients and families with XDP. I and my co-genetic counselor and co-clinical researcher, John Benedict Lagarde, practice specifically in this field, and we are also members of the Collaborative Center for X-linked Dystonia Parkinsonism at Massachusetts General Hospital based in Boston, Massachusetts, USA. So I declare no conflict of interest in providing this talk. So to give you an overview of X-linked dystonia Parkinsonism, or XDP, it is an adult onset genetic neurodegenerative movement disorder characterized by dystonic movements which coexist or replaced by Parkinsonism. Other names for XDP are lubag, which is a local term for twisting, dystonia of Panay, where the first and most cases are seen, or DYP3 dystonia because of its genetic basis. And the first cases are documented by Dr. George Viterbo, a neurologist in Panay Islands in the early 1970s. And in this picture, we can see his first sketches from his first patient here in Panay Island. And XDP are mostly seen in males. And we can see a maternal ancestry in this island in the Philippines. So to give you a perspective, here is your country, India. And we are all over here in the Panay Islands of the Philippines, where we know that the founder mutation is believed to originate. Similar to other movement disorders such as Huntington's disease and Parkinson's disease, the brains of XDP patients show signs of neuronal atrophy and lesioning of the basal ganglia. This is a part of our brain that modulates our movement. With the limited XDP post-mortem brain samples and neuropathological studies of these tissues, it has been reported that there is a selective disappearance of medium spiny neurons as the disease progresses, as seen in these pictures. Neuroimaging has demonstrated volume loss of the caudate, putamen, and pallidum, as well as broad neuroanatomical change across multiple brain regions. So here are then the clinical phenotype of XDP. So the average age of onset among XDP patients is at approximately 39 years old in male and 52 in females, although we have a broad range of age when the symptoms have started. It is known to have three phases. First, the dystonic phase, which starts focally like big toe extension, blepharospasm, or neck dystonia, to segmental dystonia, to generalized dystonia. And in the course of the disease, it combines with or replaced by Parkinsonism features that predominates 10 to 15 years after the onset of the disease. The presentation of XDP is highly variable in each patient despite of one common genetic mutation. Thus, for the prognosis, patients become more disabled and they become dependent on others for care. They have reduced life expectancy due to the complication of the disease, such as, to name a few, malnutrition, aspiration pneumonia, and tuberculosis. Clinical researchers are currently conducting natural history studies in the Philippines and Filipino cohort in North America to define the full spectrum of the disease to understand this variation, which are actually crucial for eventual clinical trials. So after years of studying its genetics, it was concluded that XDP is a Mendelian disorder associated with an insertion of an SBA retrotransposon in TAF1 DYP3 locus, and the pattern of inheritance is X-linked recessive. Let me quickly share to you how this XDP founder haplotype was discovered. So it was believed that the founder mutation originated again in the Panay Islands of the Philippines, where male cases dominated the clinic. And through a series of linkage studies, they mapped the disease locus on the long arm of X chromosome at the critical region 13.1. And later, 7 variation, which includes 5 different disease-specific single nucleotide changes, DSC1, 2, 3, 10, and 12, 48 base pair deletions, and an SBA retrotransposon insertion in TOF1 gene were found on all XDP cases by targeted sequencing. It was concluded that the mutation in TOF1 gene appears to be the genetic basis for XDP, and the confirmatory PCR-based genetic testing for XDP is available in the Philippines, looking into specifically the insertion of SBA retrotransposon, which is a piece of junk DNA that somehow disrupt the gene's functioning that leads to the death of neurons in XDP brains. There are discoveries now show that the SBA insertion, that junk DNA, contains a hexameric repeat, CCCT-CT, which has a strong inverse correlation between repeats and age of symptom onset. The higher the repeats, the earlier the onset of XDP symptoms. Also, that hexamer length exhibits intergenerational instability. So as observed in this pedigree, repeats varied even within the families. So when inherited from the mother, the SB8 repeat primarily increased in length or remained stable, whereas inheritance from fathers to daughters may have a more frequent tendency to decrease the repeats. So currently, further studies are done in this phenomenon, and the team is looking into the possibility of anticipation as seen in other neurogenetic disorders like Fragile X and Huntington's disease. Of all these discoveries, I'm happy to be part of CCXDP, which again is an international consortium of scientists, physicians, and advocates working to advance research and clinical care for people with XDP. And among the many researches and projects we are looking at now, let me share these two studies with you on the therapeutic. So one therapeutic approach that the consortium is looking currently is the gene editing technique called CRISPR or Cas9. Using this technique, the team was able to cut out the junk DNA or SBA retrotransposon from XDP cell cultures, transforming the abnormal XDP cells back to their normal state and corrects the expression of the TAP1 gene. Today, they are looking at this gene editing technique and might be used inside the brain as an in vivo therapeutic mechanism to address neurological diseases such as XDP. In addition to gene therapy, the consortium is exploring drugs that may either fix the genetic defect or address its downstream effects. This drug includes antisense oligonucleotides, which are short stretches of DNA that can block or change gene expression as they successfully done in Duchenne muscular dystrophy. Efforts are being done to really work on the betterment of the care and the search for cures. So as of this talk, there's a big event titled Hack for XDP, which is our call for new solutions that ultimately improve the lives of individuals with XDP. These solutions could be strategies to increase public awareness of the disease, engage with communities at risk, or better connect patient families to their care teams and or each other. Other solutions could be a research idea that tests a new technology, may it be a digital app, develops a potential therapy, proposes a new drug target, or identifies an opportunity to repurpose an existing drug. So you might want to use these clues if you've seen similar case from your country. So XDP should be an adult onset. That's one. There's a clinical pattern of dystonia or Parkinsonism, and there's an ancestral connection to the Philippines, particularly in the island of Panay. So currently, there is no cure for XDP, and management is symptomatic approach. So we give oral medications for dystonia and Parkinsonism, botulinum toxin injections for focal dystonia, swallow evaluation and nutritional support to modify diet and reduce the risk of aspiration, and the deep brain stimulation or DBS, which implants electrodes in the basal ganglia to repattern its output in a way that somehow normalize patients' movement. Though this DBS is on effective management for XDP symptoms, the experts are still not sure exactly why it works and why the procedure does not appear to stop brain cell loss. So at this point forward, let me share to you two cases of XDP. One from a male XDP case, which is a common case in the clinic, and one from a female XDP case that we see rarely. First case, let me share to you the case of patient M, who is a 39-year-old male of Filipino descent who was referred for genetic counseling after being examined to have intermittent twisting of neck and difficulty swallowing, which in only a span of 1 year progressed to more severe manifestations such as sustained twisting of trunk, sustained twisting of neck, jaw opening, difficulty swallowing, and shuffling of gait. So his dystonia is temporarily abated by certain sensory tricks, such as touching the back part of the neck, which corrects the twisting of neck, and biting a towel to correct the jaw opening. The proband, if you can see here in the pedigree, is the fourth among the 8 siblings born to a non-consanguineous couple of Filipino descent. Both paternal and maternal ancestries are from Panay Island, Philippines. Similar symptoms seen in his deceased identical twin. It was inferred also that the mother is an obligate carrier since the maternal grandfather and the brother had comparable clinical presentation of lubag or twisting. Also, 2 sons of his eldest sister was reported to have starting symptoms similar to his. So to maximize pedigree taking, as a side note, when we take family history, we try to ask questions of activities of daily living that may suggest early signs of dystonia and Parkinsonism. For example, has any of the family member experienced difficulty buttoning or zipping up pants? Is any other family members easily falls down or chokes frequently? So this information will help us establish a pattern, especially if the patient cannot afford to be tested. So this is the flow of which we, genetic counselors involved in the healthcare, have been coming and following up patients. So of course, we have this initial approach where we establish rapport and we take all the necessary information from the patient, especially the patient's pedigree, which is, we can to check if there are any X-linked pattern of inheritance in the family. Then we endorse patient to a neurologist or a movement disorder specialist so that we can establish working diagnosis based on the symptoms. They are actually referred back to us for counseling and for genetic testing. And here we come in to provide information about XDP that we learned earlier in this talk, and along with its genetics. We provide pre-genetic testing counseling to assess and prepare the patient with the possible results, whether the patient will have positive results, which means there's a presence of SVA retrotransposon insertion in the TAF1 gene, or a negative results, which we cannot see any insertion on the TAF1 gene. So all of this along with the familial implication of the results. And later on, we see them back again for post-genetic testing counseling. Concurrently, medical management is provided to treat and alleviate their symptoms. They are navigated to different services in the clinic, schedule them for follow-up checkups because, again, this is a progressive movement disorder, so we have to see them regularly. We see them also for genetic counseling if other family members are asking for the risk. Refer them also to support group and community where they can be really involved, such as awareness programs and research activities. So here's just a snapshot of the tools we use in the clinic to provide genetic education. We share the concept of the human body down to its genes and DNA. We share the inheritance of the chromosomes from each parent, focusing on the sex chromosome. That's also the focus of this disease. Specifically looking at that X chromosome with the information about the junk DNA that inserted, which is the SVA retrotransposon, along, of course, with the implication of the disease and the recurrence risk to other members of the family. So going back to patient M and closing this case, he actually underwent a confirmatory genetic testing for XDP, and we have seen that here he has a positive for the SVA retrotransposon insertion in TOF1 or DYP3 locus, which actually confirms the diagnosis of X-linked dystonia Parkinsonism. So currently, patient M is being managed by taking oral medication, receiving botulinum toxin injection, and he continually receives care and seen in support groups dealing and coping with XDP. Albeit rare, like 1:99 ratio from old literatures, we also have encountered females manifesting signs and symptoms of XDP. And various researches suggest that their manifestations are not that severe, and their manifestations of or the age of onset of their symptoms is not that early as to their male counterparts. So in the second case of XDP in female, I will focus on the psychosocial issues that usually arise upon giving genetic counseling. So briefly, let me share to you the case of patient F and the family pedigree. She is a 50-year-old female born to a non-consanguineous couple of Filipino descent. Maternal and paternal ancestries are from Panay Islands, Philippines. She started curling her right toes at the age of 45 and progressed to bradykinesia, left big toe extension, and bilateral hand tremor. So we can see dystonia and Parkinsonism to this patient. So also, if you can see in her pedigree, her father is affected with XDP and her mother is an obligate carrier. And so applying the principles of X-linked recessive pattern of inheritance, it makes her a homozygous carrier of SBA retrotransposon insertion. So this is also confirmed by the PCR-based genetic testing done to her. And currently, she is being seen in the clinic taking or managing her symptoms by taking anticholinergics. And she consistently joined the XTP community activities, both in clinic and in research. But what makes female cases in general, so currently I've seen 6 in our clinic, and what makes them really challenging is the psychosocial aspect of genetic counseling. So usually in our female patients, they have adverse emotional reactions like anger, blaming, fear, grief, and guilt towards that 100% chance of passing a highly penetrant disease to male offspring. Homozygous females will pass this mutation to offsprings, making male offspring affected and making female offspring an obligate carriers of XDP. So in the case of patient F, her only male offspring is currently showing symptoms of XDP and tested positive for it as well. Another psychosocial issues we're dealing is their question of why me. So this is usually experienced in families with a number of affected male members in the family, or she joined the clinic where majority of the patients she sees are males. And also another issue is their concerns about care coordination and that they would often ask what to do when they will observe symptoms on their sons. So as a reflection, when dealing with those issues, we realize the importance of providing genetic education that is appropriate to patients' background and emotional well-being. Always, we put it in the context of personalized genetic counseling. Patient may feel actually guilty and manifest self-blaming. So we should try to explain non-genetic versus genetic causation. Emphasize that the patient did not do anything bad during their pregnancy that led to that 100% chance of passing the defective genes to her male offspring. If she could have been aware of her genetic status, she could have informed reproductive decision making in the past. So this may help in avoiding self-blame. Another is surveillance of symptoms among male offspring due to the high penetrance of this condition. And of course, the provision of the information that will address the holistic needs of patient, like referring them to appropriate services. So in conclusion, and in spite of the commonality in the genotype, the phenotype of XDP is highly variable, and so are the patient's responses to the medical, psychosocial, and familial implications of the condition. This is the reason why personalized genetic counseling is deemed important here in XDP community. However, genetic counseling can also be daunting to our patients too, especially when they hear that bad news, not only for themselves, but for the entire family. So as genetic counselors, let us be that someone who will guide them over the course of their new journey. In our practice today here as community genetic counselors for XDP, there are different roles emerging and evolving, which prompts us to be flexible to meet the demands of XDP community, and of course, the demands of the research discoveries and everything, and all of this to help our patients with XDP. So with that, also, we are gearing towards creating an evidence-based practice guidelines to assist Filipino and even international genetic counselors provide genetic counseling services to this Filipino neurogenetic disease. And with that, and this then ends my talk, and I thank you very much for your kind attention.
Good day,
Thank you
everyone.
very much, Nisi. That was a very good overview of XDP in your country. We'll have discussion on counseling and the condition later. Please stay on for the panel discussion. May I please ask Professor Prakash to please introduce the next speaker, Ms. Jennifer.
Yeah, so I thank the organizers for giving me opportunity to chair this session, and especially Dr. Annie Hassan, who always keeps me on the dais whenever there is an opportunity comes. So thanks a lot. And it's an important area of the genetic counseling. So without wasting the time, let me invite the next speaker, so Dr. Jennifer. Her affiliation is with the Chief Executive Officer of the Frederick Ataxia Research Alliance, University of Pennsylvania and Children's Hospital of Philadelphia. She did MSc in Genetic Counseling, Master of Science in Genetic Counseling with the distinction from Arcadia University, Glenside, Pennsylvania, Certified Genetic Counselor from the American Board of Genetic Counseling, Bethesda, Maryland. Her interests are special interests in the neurodegenerative conditions, and then went on to establish and coordinate clinical and research program for individuals and families diagnosed with the Friedreich ataxia and other neurodegenerative diseases. So her career highlights are increase the research grant program from funding more than 1 million annually to up to 6 million annually for FARA, a reviewer in Journal of Genetic Counseling, held several key positions in ALD Connect, NSGC, and ACMG. She edited 2 books and has publications of international repute and also 5 book chapters. With these few introductory remarks, may I invite Dr. Jennifer to start your lecture.
Thank you so much for that kind introduction. And it's really a privilege to be a part of this amazing genetic counseling conference. I just need to, now I can share my slides. Thank you. I really appreciate the opportunity to participate in your conference this year. It's just a real privilege. And would like to, in the time that I have with you today, take you through a little bit about the inherited ataxias. And I am going to focus on Friedreich ataxia more so than the others because that's really my area of expertise. But hopefully I can give you a good understanding for the whole field of inherited ataxias because it's an exciting time. The diagnosis has come a long way thanks to genetic testing. And we're now in a place of, developing therapies for what have been untreatable disorders for a very long time. So I'll give you an overview of kind of the approach to primary hereditary ataxias and some of the genetic counseling challenges that come along with that. And then focus a little bit more specifically on Friedreich ataxia as an example, especially where there's a lot of development in bringing new therapies forward and how genetic counselors can play a key role in also helping patients and families find these therapies. So Friedreich's ataxia is a symptom, and it is primarily a problem of balance, gait, coordination, or speech. It can present differently. The first manifestation that people will notice often is trouble with walking, a wide base gait, unsteadiness, maybe increasing falls. Some individuals will also describe their first symptom as dizziness, which can lead them to a bunch of appointments for inner ear problems or vestibular problems, and can really delay a diagnosis of primary ataxia. Also, individuals can present with difficulty coordinating their upper limbs as well. Frequently we'll hear from parents or kids that, everybody thought they were clumsy because they were the one always spilling the milk at the dinner table when they'd go to reach for their cup. And again, in some people, ataxia has its first symptom as slurred speech. There's an excellent review on hereditary ataxias that Dr. Susan Perlman just updated on Gene Reviews. And I would encourage anybody who's having to work up a family with a hereditary ataxia to go to that review article. Really does a phenomenal job of helping us understand the complexity of inherited ataxias. Just in terms of the underlying biology, what's happening, hereditary ataxias are caused primarily in one of two ways. It can be from the peripheral nervous system, so sensory ataxia, where there's sensory loss in the peripheral nervous system, and so information is not getting fed back into the central nervous system appropriately. So in Friedreich's ataxia, this is the case where individuals don't know where their hands and feet are in space. So the inputs from the periphery back to the brain are not functioning properly. And then in a lot of the spinocerebellar ataxias, it is the cerebellum itself that is undergoing atrophy and degeneration over time, causing the symptoms. So really, there are multiple sort of anatomic contributions to these inherited ataxias, and that can be helpful also in trying to figure out which hereditary ataxia a patient might be presenting with. There are currently over 40 different hereditary ataxias. They have different ages of onset. They cover all modes of inheritance, and there are still new genes being identified all the time. And when when an adult presents with what we call late onset cerebellar ataxia, so, anytime in their 30s to 60s, and they don't have a family history of ataxia, we can only identify a genetic cause in about 50% of those cases. So ataxia can also occur for non-genetic reasons. But because at least or more than half of these individuals will have a genetic cause, it is important to give them a full and comprehensive workup. So age of onset, like I said, can contribute to helping you sort out, which of the hereditary ataxias you might want to look at. There are very few ataxias that are present at birth. Only SCA2 and SCA7 have an infantile presentation. Ataxia telangiectasia presents between the ages, early childhood ages, between the ages of 1 and 5 typically. Friedreich's ataxia typically occurs between the ages of 5 and 15, along with ataxia with ocular motor apraxia. And these are usually autosomal recessive. These are both autosomal recessive conditions, so oftentimes there is no family history. For individuals with adult onset ataxia, typically between the ages of 20 and 50, you should be thinking about spinocerebellar ataxias. All of those have a dominant pattern of inheritance. DRPLA also is autosomal dominant. And 25% of Friedreich's ataxia has late onset after the age of 25 years. So you can't completely rule out Friedreich's ataxia just based on an early presentation. There can be cases of FA that present much later. And after the age of 50, it's uncommon for the hereditary ataxias to present. Only SCA6 is really well described after the age of 50 years. I'm not going to go through all of these, but just to say that there are non-clinical signs, the non-ataxia clinical features that can help direct you to a specific type of ataxia. So for example, retinopathy is common with SCA7. There are some forms of cognitive decline that are associated with some of the SCAs. Friedreich's ataxia, for example, presents with scoliosis and cardiomyopathy. There are also specific neurologic signs that the neurologist will pick up on exam that can also help direct your search for what type of ataxia an individual might be having. And then geography can also be really helpful in trying to figure out what, or ethnic background might be very helpful in trying to figure out what type of ataxia your patient may have. This is a summary looking at just the spinocerebellar ataxias and sort of how there's specific geographic prevalence of certain types. So for example, SCA3 is very common in the Portuguese population, both in Portugal and Brazil. So when you're trying to work up somebody who's presented with ataxia symptoms, family history is very important. If you see a dominant pattern of family history, that can quickly direct you to most of those spinocerebellar ataxias, age of onset, those additional clinical signs, and sometimes where somebody comes from is also a helpful hint. This is important because genetic testing for the ataxias is complicated. Many of the inherited ataxias are caused by trinucleotide or repeat nucleotides, and these are not easily diagnosed by doing whole exome sequencing or whole genome sequencing. And so there are specific ataxia panels that have been created by a lot of the genetic testing companies. Some of them are autosomal dominant panels, some of them are autosomal recessive panels, some of them include both dominant and recessive based on age of onset. So it's really helpful if you can use some of the family history and clinical signs to help figure out which of the ataxia panels is going to be most beneficial to get to a diagnosis for your patient as quickly and efficiently as possible. I will say there have been some papers that have come out recently about some of the advances in the genomic sequencing that are now allowing for better detection of repeats in through these sequencing panels. So I do suspect that in the upcoming years, a lot of these conditions that were previously very difficult to detect by whole genome sequencing will get better and better as the technology to read through those long repeats improves. And I think with that, there will be new challenges for us as genetic counselors as well. But just to kind of think about some of these hereditary ataxias, in the dominant conditions, again, many of them are repeat expansion disorders. And with those repeat expansion disorders, you often see anticipation. So the phenotype presents earlier and earlier with each generation. And so the risk for more severe disease increases as the condition gets passed on from generation to generation. There can be genotype-phenotype correlations that are also important, not only with the repeat expansions, but also with the non-repeat expansion mutations. Many of these families seek pre-symptomatic diagnosis and counseling because of the significant disability that these inherited ataxias cause. Many of these conditions leave individuals non-ambulatory 5 to 10 years after diagnosis. And most of them, nearly all of them, I believe, don't have any approved therapies that can really slow or stop the progression of these diseases. So, a diagnosis of any of these hereditary ataxias is going to mean loss of ambulation, significant loss of independence, significant disability. And that's, a lot of the reason why individuals who are in families often seek pre-symptomatic testing and counseling. For the autosomal recessive ataxias, especially Friedreich's ataxia, there can be some important counseling issues based on genotype, phenotype. Again, longer repeats are associated with earlier age of onset and also additional symptoms like cardiomyopathy. In ataxia telangiectasia, there are a lot of individual sort of private mutations that are identified. And so it's important for counselors to be able to talk to families who are encountering new mutations about their risk for certain types of cancer, as well as immunodeficiency that occurs with ataxia telangiectasia. Many families need reproductive counseling because they are, having a child newly diagnosed with one of these recessive conditions and will need counseling to understand the risk for their other children or future children. And then, like I said, many of these conditions now have emerging treatments. And I think there's an important role for genetic counselors in helping patients connect to clinical trials, natural history studies. There's a lot of research that families can get connected to that might help improve their long-term prognosis. So I'm going to kind of take a deep dive now as a case example into Friedreich's ataxia. FA is a rare recessive disease, as I've mentioned. It affects about 1 in 50,000 individuals, and that is, a general prevalence number. The prevalence in India is not well characterized yet, but we do know that there have been at least several hundred individuals diagnosed at one of our clinics in New Delhi at AIMS, and we have many individuals in our patient registry and participating in our online forums. And this is an area of interest for our organization, is to really partner with you and with your community to get a better understanding of the true prevalence of FA throughout India, so that we can begin doing natural history studies and bringing some of these new clinical trials to the FA community in India. Most individuals with FA present with neurologic features, so that classic gait disturbance or ataxia is the primary presenting symptom in about 90 to 95% of people with FA, despite the fact that it is a multi-system disease. It affects additional organ systems beyond the brain and spinal cord. The most common age of onset is between 5 and 50 years, although individuals can present after the age of 25. Individuals with late onset have a more mild phenotype with a slower progression. And at this time, like I said, there are no approved therapies for Friedreich's ataxia. This is just an example of a typical patient profile. So the middle boy up in the top left-hand corner, Keith, was diagnosed with FA at the age of 11. And you can see him here at a much earlier age, at about age 4, with his younger brother and his older brother. And you can see even before he's diagnosed, he already has a much wider base of standing than his 2 brothers. His family started noticing symptoms when he was in elementary school. His writing was deteriorating. He was kind of having extra movements, and he appeared to be stumbling and kind of bumping into walls a lot. And that's what got his parents to take him to a neurologist to see what was going on. At the time when he was diagnosed at age 11, he was found to also have scoliosis and hypertrophic cardiomyopathy. He had to have spinal fusion surgery at the age of 15. By the age of 18, he was also diagnosed with diabetes and was using a wheelchair full time. So he had a very rapid progression of his disease. His cardiomyopathy was also progressive, and Keith passed away at the age of 25 due to heart failure.
Jen, you have 2 minutes to conclude, please.
Oh, okay, thank you.
Thank you.
Kyle is a very different scenario. Kyle has onset of FA at the age of 17, and his progression has been much slower. He did not require use of a wheelchair until the age of 25, 27, and he's still able to live independently at the age of 40 and drive with hand controls. And so the age of onset is very much a predictor of the severity and the progression of the disease. Given the time, I'm just going to speed ahead and just talk briefly about the genetics. So FA is a single gene disorder, and as I mentioned, it is caused by these repeat expansions. Individuals with FA will have repeat expansions on both alleles, or they'll be compound heterozygous for a repeat expansion on one allele and a loss of function mutation on the other. Importantly, this repeat expansion leads to epigenetic silencing of the gene and thus deficiency of the frataxin protein. This epigenetic silencing is quite complex, and it occurs based on sort of the formation of heterochromatin, methylation, RNA and DNA hybrids, and understanding this over the last 10 to 15 years has led to our ability to develop new therapies for FA. And I'll, in the interest of time, kind of skip through a little bit of this, but as the other speaker had mentioned, there is an inverse correlation with the length of the repeat expansion and the age of onset and the severity of the progression of FA. But when we think about therapies for these diseases, we start at the root cause, the gene. And so there are now both gene editing and gene replacement approaches that are entering the clinic for Friedreich's ataxia. There are also therapies that are downstream of the gene, focused on the frataxin protein and the deficiency of the protein and sort of how that causes cellular dysfunction within the mitochondria. And so there's small molecule approaches to therapies. This is what we call the treatment pipeline and kind of shows you the range of both traditional drugs here at the top that are in the clinic right now being tested for Friedreich's ataxia, as well as the gene replacement and gene editing approaches. They are in earlier stages of development, but the first gene therapy will go into the clinic this year. Likely having the first patient dosed next month, which is incredibly exciting. And we also have one drug called omaveloxolone, which is a small molecule that improves mitochondrial function in FA that is currently being reviewed by the FDA for consideration of approval. Maybe on that positive note, I will just get to a summary, which is, hereditary ataxias include over 40 different diseases. As I mentioned, they can be quite phenotypically distinct, and, an individualized or personalized genetic counseling and genetic testing approach will need to be incorporated. Accessibility to whole genome sequencing is going to lead to pre-symptomatic diagnosis. We had the first case of this in Friedreich's ataxia brought to my attention about 2 months ago. A young child who was 2 years of age and having some speech delay and receiving early intervention services, had whole genome sequencing done, and was found to have 2 repeat expansions in the frataxin gene. And his presentation of speech delay is really not linked to a typical sign or symptom of FA even early. And so we think that it's very likely that we'll see more of this in terms of children receiving early intervention services, being diagnosed with hereditary ataxias before they normally would present to the clinic. And finally, many of these emerging treatments are genetic and complicated genetic treatments, gene editing, gene replacement approaches. And I see a real need for genetic counselors in helping patients understand what these therapies have to offer and being connected to them and being educated on the risks and benefits involved with gene replacement therapies. And so I see this as a very exciting time for your profession and new and exciting roles for you to play in helping patients connect to these therapies. So with that, I'll say thank you for inviting me, and I look forward to the panel discussion.
Thank you very much, Jennifer. That was a very beautiful overview on ataxias. Thank you very much. Dr. Harsha, can you please introduce the next speaker, Dr.
Yeah.
Suma?
Good evening. It gives me great pleasure to introduce Dr. Suma Shankar. She is unique in that she has got an eye for detail and eye for precision. Having finished a MBBS and MD from this country, she has completed her FRCS in ophthalmology from the United Kingdom, following which she has done her boards. She has been in the University of Iowa, where she has done her PhD and postdoctoral fellowship in molecular genetics and is a board certified in medical genetics. As it is, ophthalmologists are finicky about precision and amount of incision which they make and things like that. Now she is into precision medicine, precision genomics, clinical translation research, and is the chief of genomic medicine, Department of Pediatrics, University of California, Davis Health. She is also the director of genomic program in Mind Institute and editor of genetics in medicine for Journal of American College of Genetics and Genomics. She has, to her credit, starting of the genetic clinic and in the Department of Ophthalmology at Emory University School of Medicine, and also has established a precision genomics clinical program in the University of California, Davis. She has held several positions and has multiple papers and 7 books to her credit. Now I call upon Dr. Suma Shankar.
Hi, everyone. Are you able to hear me okay?
Yes, Dr. Suma, we can hear you.
Yeah, thank you so much for that very kind introduction. I would like to thank the BGCI and the organizers, Dr. Deepa Bhatt, Dr. Akila Prashant, and Dr. Pooja Raisam for inviting me to present at this very incredible and exciting conference. Thank you for the opportunity. And we have had some very interesting and invigorating presentations. And I would like to now share my experience in genomics. Okay. Just again want to confirm that you're all seeing my slide okay now? Okay, thanks very much. So we heard a lot about different genetic disorders and management of genetic conditions as well. I have no disclosures. What I would like you all to take a different approach and now kind of think about, you've heard the term precision medicine a lot, probably in the past few years, and what's the role of genomics in precision medicine? So overall, precision medicine is something where one would like to tailor treatment based on the variability in genes, environment, and lifestyle, and be able to provide individualized or personalized treatment to our patients and families. So we heard a lot about genetic disorders. In this very last session, I invite you all to change gears and put on your diagnostic hats. And while we cannot be very interactive, I encourage each one of you to be thinking in your own minds, what's the most appropriate genetic testing one would like to do given a particular clinical scenario. So we all gather detailed clinical history, and genetic counselors are really excellent at gathering history from individuals and also gathering the family history, then performing deep phenotyping. And based on this information that is gathered, one would choose the most appropriate genetic testing. As we all heard, exome sequencing and now clinical genome sequencing is widely available. And is genome sequencing the most advanced and the most expensive test, the best test to go to? I invite you all to think for yourselves with the examples that I'm going to be sharing. So again, a brief overview, all of our genetic information is stored in our chromosomes. And then the approach that we have taken historically is to do karyotype analysis for identifying chromosomal aneuploidies, to chromosomal microarray analysis for identifying deletions and duplications. And then we did single gene testing to determine genetic etiology for individual disorders with Sanger sequencing. And then we moved on to next generation sequencing with exome analysis and genome analysis. And of course, not to forget the mitochondrial DNA with the mitochondrial DNA analysis, which also can be covered with genome sequencing that we heard earlier in the session. So now inviting you on to go to a patient who may present to the neurology clinic with history of hypotonia and developmental delays. So this patient presents with history of hypotonia and developmental delays. You take a look at him. And then you start thinking, because of the facial features, you're trained to be dysmorphologists as well. So, and then you want to know a little bit more about the history. And parents give, there was history of congenital heart defect. And then you notice the distinct facial features of the depressed nasal bridge, the hypotonia of the face, protuberant tongue, enlarged, and then you can also see the overfolded earlobes, and then you see the single palmar crease, and then clinobrachydactyly. Now I would invite you to ask, what do you think is the clinical diagnosis in this individual, and what would be the best clinical test for this particular patient? So I'll just pause there for a moment. I know it's hard to be interactive, but of course, if you're all thinking trisomy 21 and Down syndrome, you're absolutely right in the diagnosis of that. And so the test that one would typically order is not a genome sequencing, but a high resolution chromosome analysis, which is a karyotype, and you may see an extra chromosome 21, or you may see the Robertsonian translocation with the 14 to 21 translocation. And as genetic counselors, this is extremely important when you're counseling, because you all know that there is a highly increased risk of having another child with Down syndrome if the mother is a silent carrier of 1421 balanced translocation. So again, moving on to another individual who may present to the neurological clinic with stereotypic behaviors. The parents may say, oh, there is like, she exhibits a feature of upper body or a self-hug. And they may also have some idiosyncratic behaviors like putting things in their nostrils or the ears. And you take a look and you notice that the child has broad forehead, deep set eyes, and then there could be mid-face retrusion. And then thinking about diagnosis, one may start to think that, okay, maybe chromosome microarray analysis is the best next test for this individual. And nearly 4 to 7% of children with either autism spectrum disorder or developmental delays may have chromosomal abnormalities. So you do a chromosome microarray analysis and it identifies a 17p11.2 deletion, including the RAI1 gene, diagnostic for Smith-Magenis syndrome, confirming your clinical diagnosis. So, okay, you may then, moving on again rapidly, to a patient who may present with history of seizures. And often we have a number of seizure panels now available to determine what's the underlying genetic etiology in an individual with seizures. So when you see a child with seizures and then take a detailed history, they may give history of developmental delays, speech impairment, minimal to no use of words, and then they may also share that the child has frequent laughter, smiling, and is a happy child with excitability and has hand movements. They may also have movement or balance disorders with ataxic gait and some tremulous movements. Now, in this particular individual, again, if you do a seizure panel or a exome sequencing or genome sequencing, you may not identify a underlying genetic etiology because this, as again, many of you in the audience who may have correctly diagnosed as Angelman syndrome, is an imprinting disorder, and the first test of choice would be methylation testing for Prader-Willi syndrome and Angelman syndrome. So this again is very important, and it's a genetic counseling need. So I have to show some pedigrees, and in this instance, you would be able to counsel your family appropriately about decreased risk for additional children. Moving on to another disorder where there could be speech delays and autism spectrum disorder. Males with are more commonly present with this particular condition and may present with relative macrocephaly, long facies, prominent forehead, and protuberant ears. Again, it's a triplet nuclear disorder, the Fragile X syndrome. And for this as well, the most appropriate test would be PCR or Southern blot. And if you do a genome, although some labs are beginning to look for triplet nucleotide disorders and are reporting them at this time, the more valuable test may be PCR or Southern blot. So showing the importance of clinical correlation in deciding the test that one would be considering. Another child presents to, let's say, ophthalmology, and the parents notice the eye turning in or standing close to the TV. And when the ophthalmologist or pediatric ophthalmologist look into their eye, they notice that the optic nerve is swollen, and a scan shows optic nerve glioma. And as an astute physician, you notice that there are also a number of Café-au-lait macules on the child. And when you look at the mom or the father, you notice that there are some cutaneous neurofibromas. So in this instance, one may not need to go to an exome or a genome sequencing, as you would already have rightly diagnosed clinically the neurofibromatosis type 1, and you would order just a single gene testing of neurofibromatosis type 1, the NF1 gene. So when this is an autosomal dominant condition, and again, to emphasize, there is so much of clinical variability. And so the first person who may come to attention may be the child with the vision loss, as other individuals in the family may just have Café-au-lait macules or cutaneous neurofibromas that may not have required medical attention. So with autosomal dominant condition, consider both the variable expressivity as well as reduced penetrance, and also remember spontaneous mutations if there is no family history. So if you look at OMIM, we know that there are, although we have about 20,000 genes, we know the underlying genetic etiology or what genes cause genetic disorders in only about a third of them, or about 1/4 of them. And so we still have a lot to discover. So when do we do an exome analysis or a genome analysis? Typically, this is undertaken when individuals present with non-specific presentations, and that could be global developmental delay or autism spectrum disorder, or when they come with diagnostic odysseys, which typically is, in many instances, are neurological presentations. And again, this audience doesn't need introduction about the differences between exome and genome analysis. So we will move on, and with a couple more case presentations, I would like to share the complexity of neurological disorders and how neurological disorders are not only like neurodevelopmental and neurodegenerative, and this can span one's entire lifetime. And depending on what age a person or a child presents with, the same clinical disorder can present with various manifestations. And with this, I would like to present an individual who came to the genetics clinic in his 30s, but his odyssey had begun long before then. At his first birthday, he had mild delays, but he really kind of came to attention because at 2 years of age, he had a speech delay and was diagnosed to have autism spectrum disorder between 2 and 6 years of age. And around that time, he also received a diagnosis of oral motor dyspraxia. At the time, the go-to genetic testing for any individual with delays or autism spectrum disorder was Fragile X testing, and that was performed and was negative. He went on to have developmental delays and was given clinical diagnosis of severe global apraxia. He also was diagnosed with moderate sensory neural hearing loss, and then was kind of like lost to follow-up for genetics because by then the one available genetic testing was done and was negative, and he was followed by developmental physicians and his primary care doctor. He later presented to neurology again because in his early 30s, he presented with difficulties in his gait, had shuffling gait, started developing balance problems and weakness of the lower limbs. He had Parkinson's-like movements, and he was noted to have changes in the globi pallidi and substantia nigra. And when he presented to us, we looked at his complex clinical picture, and at the time we had a research study going on, and we still do, for individuals who present with nonverbal autism spectrum disorder or who are minimally verbal. And since he qualified, we went for clinical whole genome sequencing in him. And quickly to move on to the diagnosis, we identified our whole genome sequencing identified a splice site variant in a gene, WDR45, which is an X-linked gene. And this was reported as being mosaic. And this is important because if it is not, this is a condition where this is lethal in males. And if it wasn't mosaic, then we wouldn't have expected to find this in our proband who's a male. So we found this in him, and this explained his presentation because he has the neurodegeneration with brain iron accumulation 5, also called as BPAN. And this gave a diagnosis in him for his presentation of Parkinson's-like movement, shuffling gait, and dyspraxia. But because we had done whole genome sequencing, we also identified a number of other findings that I'm going to share. So another finding that was found in him was a missense variant in the gene GNAL, which can cause dystonia. And then we heard about incidental findings and actionable genes for 73 genes that cause either cancers, breast cancer, or heart disease, where one can provide treatment or screen individuals to monitor for development of tumors or arrhythmias. And in this particular individual, he also had a variant in pathogenic variant in the gene PALB2, which causes breast cancer. The genome sequencing also gives pharmacogenetic variants. So we identified a number of changes in him where we could give guidance as to his treatment management. And then in addition, he was noted to be a carrier for a number of disorders listed here, including oculocutaneous albinism, hemochromatosis, Usher's syndrome, and spastic paraplegia with hemoglobinemia, and so on. So we already discussed about how important it is to inform families about what they are going to receive if they go for a whole genome sequencing. And this is an example of how complex one's results can be, even though you are looking just for one change that explains the clinical presentation. So did it make a difference to his management? Well, for his Parkinson's-like movements, he was started on dopamine, which helped him with his movement. But given the identification of the WDR45 variant, which causes brain iron accumulation, he was started off-label on deferriprone, which is an iron chelator that crosses the blood-brain barrier and this was off-label use. And this particular family, the parents were very interested in trying anything that may be available as a treatment. And so we started him on it. And while it seemed like there was some initial perceived, I would say, improvement, we don't think that there was any change because we put him on deferriprone at this time. However, there are clinical trials for other neuronal brain iron accumulation disorders. I'm not going to get into that. And then I just want to, at this time, say that if he was identified early on in life, would it have made a difference? We don't know that. Many of these are very still in clinical trial stage or not even at clinical trial stage. And we need to know a lot more before we can start providing or advocating precision treatments. And that's where there is this cautious optimism and hope, but not give them unrealistic hopes that a genetic testing would provide a treatment. So finally, to move on to another family where the probands also presented both from neurological and ophthalmological symptoms. These are probands 38 and 35 years of age who were doing extremely well until 14 years of age. They were athletes, did well in school per mother, and were stars of the school, but then in early childhood, they presented with bilateral sensorineural hearing loss and then progressively went on to develop tremors, dystonic movements, and tremulousness and ataxia. So these individuals also were noted to have absent dental enamel, and they presented to ophthalmology and had adult onset retinal dystrophy. So just with this particular information clinically, one can come to a clinical possible differential diagnosis. On exam, one noticed that they had dysarthria. The extraocular movements were limited. There was some facial weakness. They also had amyotrophy. The sensory was retained, but they had severe ataxia, both for the gait and also for finger nose presentation. And the diagnosis was Parkinsonism, dystonia, and ataxia. So this kind of like has a broad differential diagnosis. And here are the retinal images showing slightly pale optic nerves, narrowed arterioles, and changes in the retinal pigment epithelium, macular changes, more evident in this red infrared photographs, where you can see these changes in the macular region as well. So they were losing their vision, they were having problems with their hearing. And if you think about differential diagnosis with just retinitis pigmentosa and hearing loss, one would be thinking about Usher syndrome. But remember that these two individuals are presenting with additional features. The brain MRI showed slightly depressed signal intensity in the red nucleus and substantia nigra, which was consistent with decreased iron stores, and there was some pontocerebellar atrophy. But when you put all of the clinical features together, and again, theirs was a diagnostic journey, so they were investigated for autoimmune disorders, had a number of clinical genetic testing done, Fragile X spinocerebellar atrophies, for trinucleotide repeats, Friedreich's ataxia, also mitochondrial genes, and had muscle biopsy as well that was not conclusive. They also had very long chain fatty acids for paroxysomal disorder, but this was thought to be non-diagnostic. An exome was recommended but was denied by insurance. So at this point, given that they were presenting with diagnostic odyssey, we went for genome sequencing. However, our top differential diagnosis, just by doing a good OMIM search, you can come up with the paroxysomal disorders caused by either PEX1 or PEX6 genes, and genome sequencing revealed a missense variant Win cis with a 3' UTR change, which was in both siblings, and both of these were inherited from fathers. Now, you all will recall that paroxysomal disorders are autosomal recessive conditions. And when there are two males presenting, often, and rightly so, people would be thinking about X-linked disorders. However, this kind of like came as a surprise in that this is an allelic expression imbalance that kind of presents like an autosomal dominant disorder, because it's an unusual presentation where when there is a missense variant along with a change in the 3' UTR region, this acts like a dominant negative mutation and causes a disease. And this was really serendipitous in that we identified this because there was a beautiful manuscript presenting this phenomenon in 2017 where there was allelic expression imbalance that promoted a mutant PEX6 allele, and there were functional results that substantiated this. And because our probants had genome sequencing following this publication, we were able to diagnose them accurately. Now, while there is no treatment, I think, like moms feel a lot of guilt about X-linked disorders, and mother kind of like expressed her relief that she was not responsible for it. However, now it seemed to have shifted to the dad, and so there is a lot of genetic counseling involved in how we often, we don't have a choice, not often, we don't really have a choice in what we pass on to our offsprings. And unless one chooses to do pre-implantation genetic diagnosis, then it really is a 1 in 2 chance of what we pass to our offsprings. So with this, I would like to say that we are in the era of precision medicine, where genomics, a lot of big data and artificial intelligence using our electronic health records, maybe using all of the information from our iPhones as to how much we walk or what we eat and drink, to how much exercise we do, to influence how we can individualize treatments, but genomics plays part of the role in it. And with that, I would like to thank my colleagues and my funding, and then thank you again for providing the opportunity to present here.
Thank you very much, Dr. Suma. You started from Down syndrome and went on to that complex presentation. Very, very beautifully done. Dr. Prakash, can you please introduce the next speaker? Yeah, yes, Dr. Prashant.
Dr. Anup Raul. He is the Associate Director of Medical Genomics and Genetics, SRL Diagnostic. He is a consultant clinical and cancer geneticist, Fortis Hospital, Mumbai. He is a MBBS, MD in internal medicine. Then medical genetic and geriatric hospital and health management from Maharashtra Mahatma Gandhi Institute of Medical Sciences. He is a DM medical geneticist from Gandhi Postgraduate Institute of Medical Sciences. His interests are in almost all areas, starting from reproductive genetics, congenital anomalies, infertility, cardiomyopathy, seizures, skeletal dysplasia, and inborn error of metabolism. It's advocate premarital and preconceptional genetic consultation for all couples. So welcome you.
Yeah, thank you, sir, for the kind introduction. First of all, let me thank the team BGCI for hosting such a wonderful conference for entire group of genetic counselors across specialties. And it's been wonderful. I've been following it online. I've got feedback from my colleagues who have been attending this conference. And it's been a wonderful experience getting to meet old colleagues, getting acquainted to new ones. So unlike the Indian cricket team, which always collapses, my previous speakers have set a very nice tempo. And let me see if I can just take a whirlwind like Bumrah did yesterday. So I'm attached to Fortis Hospital, Mulund, and I'm working in the capacity of Associate Director, Medical Genomics Division at SRL Mumbai. So just in next few minutes, as the tempo is set, let me take through to the topic of neurodevelopmental disorders, the genetic counseling perspective. We'll see about what are the tests that we do, what are the points that need to be taken care of when we are doing counseling, right? So neurodevelopmental disorders, particularly delays in the skill domains of the infants. So these domains are various: intellectual disability, global, it could be, or communicative aspects, or autism related learning aspect, communication and learning, and or it could be purely motor. So there is a classification that has been given in DSM-5 that we follow for neurodevelopmental delay. And of course, in India, the scenario is nothing different from the global scenario, lot many patients, but yes, timely diagnosis management that still remains because most of them are undiagnosed or underdiagnosed. And the irony is most of them are a component or chunk of them are having rare disorders which rarely get diagnosed. Just to point out, for patients with rare diseases, they spend somewhere on an average between 4 to 7 years before they get a final diagnosis that sets in the way for management ahead. So when we are talking of neurodevelopmental disorders, these are the domains that we look at: the motor, language, and cognitive problems, and the learning aspects, so behavioral and emotional. So anywhere this genetic aspect is one thing, there also could be non-genetic things that contribute that need to be identified when you're dealing with the patient while you're working them up, because this will govern or help you take particular statistics when you're talking to the patient as to tell them about the risk of recurrence or certain clinical trials that may be there or certain new things that are coming up that can be applied to the management in terms of, say, surveillance planning for that patient for monitoring certain specific morbidities in those patients. So when we talk of neurodevelopmental disorders, we all have seen, like this has been previously covered by the speakers. So when we're talking, it could be either structural part that is involved, where there is underlying genetic abnormality at various levels, where the structure of the central nervous system or peripheral nervous system get affected, or it could be the functional at the level of channels or synapses, channelopathies and so on. And when we are talking about neurodevelopmental disorders, genetics is one aspect, but which all other factors could again influence the outcome in terms of phenotype, like maternal conditions, if she's hypothyroid, if she has hypertension, preeclampsia, if she is diabetic, if her maternal immune activation, certain phenomena which lead to complications in pregnancy, which impact the pregnancy per se and the outcome of the pregnancy, socioeconomic factors, so on. Again, postnatal environment, perinatal infections, socioeconomic factors, family functions, so on. And again, at the background of it, there could be epigenetic factors which are important. A lot of studies, research is going on. This could again have a bearing on the outcome of the overall neurological status of the child. So when we are assessing a child with neurodevelopmental delay, as a clinician, history is very focused around the disease. But when as a medical geneticist, we see the patient, we have to go through all these steps. Maternal history, if there is history of some intellectual disability in the mother, menstrual history may be relevant, or there has been primary infertility after which she has conceived. On the maternal side, her brothers, if there is a history of mental retardation. So such clues could point to some say X-linked disorders like Fragile X that we need to look at. Paternal history, paternal age, then history on the father's side, consanguinity if is there, then history during the pregnancy, infections, complications, which could have, or multiple gestations, perinatal developmental history, and family history that we cover in detail. So one has to distinguish whether it is indeed a developmental delay involving one or more domains, or indeed it is a global developmental delay, or something which we commonly see ASD where more of functional communication is involved. Because this will help us in identifying as a clinician what test we want to go after. So throughout this process, we are looking at certain clues where we are trying to focus in or zero in on certain condition, and based on that we pinpoint what test we want to do, because our counseling is going to be around that test, the pre-test, post-test, and what could be the outcomes and how it could impact the management. And why this testing or this understanding this etiopathogenesis is important, because of course, like if the cases that we have seen from previous speakers, say something like Fragile X is very evident. So I know what test I'm going to go for. I'll definitely go for a triplet prime PCR, TP-PCR, that is done nowadays. But one thing I should remember, that it will pick up the positive diagnosis in 99% of the cases. In those remaining 1%, it is a sequence or DNA sequence related abnormality where I might need to do a Sanger or a NGS to cover the differentials as well. So this knowledge is very important when we are dealing with the patients, and this is very important to complete the aspect of counseling when we are dealing such patients. And again, to come up, like what is going on in the field of research, like functional studies, and nowadays a lot of repurposing of drugs is also going on. So RAS-MAPK pathway related conditions, Noonan's, cardiofasciocutaneous. So mTOR inhibitors are being targeted there, and those studies are actually going on. Clinical trials are going on, and the results are very promising. And maybe in next few years, we have something substantial that comes out. So when we're looking at causes across all spectrum, genetics causes on one side and other causes which influence the outcome at the same time. So clues in history, dysmorphism, consanguinity, any particular syndromic association like anomalies of the heart, of the lungs, of the GIT, of the genitourinary tract, dysmorphism along with developmental delay. These could point to certain genetic conditions which upfront based on gestalt at times can give you a clue what test you want to go for. So this is one very interesting article that I found, where for each pathway, this few mutated genes have been indicated, like in neurodevelopmental disorders. When we are looking at the structural aspect of the brain, how it grows. So what are certain genes which at background, if there is a pathogenic variant in those, can affect the various aspects of development and result in a neurodevelopmental disorder. So this is a very common diagnostic protocol that pediatricians follow. But why I want to highlight this slide is, though a pediatrician or pediatric neurologist might be formulating the clinical diagnosis, differentials, and working it up, at the same time, there is important role of a psychologist, maybe a genetic counselor, or a pediatric psychiatrist, and also a role of clinical geneticist, where it comes handy, because diagnosis by gestalt, using these clinical details for counseling, what is the family history, what is the empirical risk, and when we have worked up what is the final risk. So what happens in the pre-test and post-test, and most important is time factor, where the clinicians are lacking, which can be covered and efficiently addressed by the genetic counselors. Yeah, a spectrum of tests, lot many were discussed in by previous speakers. So a particular test, like suppose I am thinking of a phenotype, say with Rett syndrome. I know that, okay, in 10 to 12% cases, it's going to be a copy number variations, and rest of it is a sequence related issue. So I'll go for a Sanger sequencing first maybe, or a NGS to cover the differentials. If that comes negative, I look at the copy number variations. So I have my approach clear cut based on the clinical picture. So on, and most important, so genetic test is one thing. One very important aspects even before going for genetic testing is based on the clinical diagnosis that we have, or at the differentials that we have. Other tests also come in very handy. Most importantly, if you're thinking of inborn error of metabolisms, GCMS, TMS, and imaging studies to zero in on the clinical diagnosis, the differentials, and based on that, then we look at what underlying genetic abnormality could be a possibility and pick up appropriate test. So when we come to NGS, it's a multidisciplinary approach. It's not just a clinician ordering a test. Most of the time, what happens on seeing, okay, there was a baby with a neurodevelopmental delay, whole exome sequencing was ordered, the test came out to be negative, and the clinician is like, he is having issues, clinical picture is there, but your test is negative. So what may happen? So these are the things that need to be addressed. Like if dysmorphism is there, neurodevelopmental delay is there, consanguinity is there, history of infertility is there, history of miscarriage is there. Is there a balanced chromosomal rearrangement somewhere? Or based on clues, you get something like X-linked fragile X picture and you're ordering a sequencing based test, which is never going to pick up what you're looking for. So these mismatches usually happen in the clinic, which can be avoided if there is a fine tuning between the counselors, the geneticist, and the clinicians. And then there are a lot many algorithms like the one which I've shown here. And lot many guidelines have also come up. So child with neurodevelopmental delay, the first test of choice is chromosomal microarray. And what we should remember is to do a high resolution microarray. So that usually happens like microarray test is ordered, but it is low resolution. So such things can impact the results and expectations of the clinicians as well. And again, the diagnosis gets delayed, and at times unnecessary investigations do happen. So just to sum up, when the clinical picture is pointing towards any particular disorder, we know what test to do. We focus on those tests first. If the test is negative, we look at, okay, well, suppose Fragile X, I've given a TP-PCR test requisition. Clinically, I'm sure X-linked history on pedigree, clinical picture is of Fragile X. There is a history of, say, premature ovarian arrest in the females, but the test comes negative. So I know I should do a sequencing here along with the differentials. So this is how we go. If those single gene tests are negative, then go for a panel. And if panel turns out negative for the differentials, maybe a whole exome sequencing, or on research basis, we can do a whole genome sequencing. There are quite a few labs which are doing that. So now coming to the genetic counseling aspects of neurodevelopmental disorders. So these points have been covered time and again for various conditions, maybe apart from neurological conditions as well. So first is, it is non-directive, as we know. We have to understand the parents' perspective, get them on board. We have to facilitate the decision making. Counseling about risk of recurrence, this is very important. And usually what happens in pre-test counseling, lot of anxiety is there. So this needs to be addressed, because we are talking about diagnosis of a baby, and somewhere we bring up the topic of risk of recurrence. So how we facilitate or converse and put across this message is very important. Then managing uncertainty, increasing parental sense of control. So very rightly said, like non-directive, we give all the information, we help them take a decision, we don't take a decision for them. So same thing, I interact with the clinicians. This is the message I always put across. And most importantly is getting these parents in touch with similar groups or social support groups for those particular disorders if they are there. So for example, the Downs group in India is very active. They keep on doing lots of activities. And this is how, like, if a family is there, they have a child with Downs, what is the future like? What are the morbidities they might face? What are the difficulties they might face? So this is a very good platform where they get to interact with similar parents, with similar background, and there is a lot of exchange of thoughts, and it is very comforting for them, because at times they might not discuss issues with a counselor or a doctor for that matter, as they might be more comfortable and seek information there. And what are the benefits? So first of all, end of the diagnostic odyssey. So we know what it is. Once we know what it is, we know how it is going to go ahead. What are going to be the morbidities, complications, how we are going to manage. Those things get addressed easily. Enabling provision for prognostic information, tailoring medical management, targeted therapies as and when. So most important aspect is inborn error of metabolism. For more than 80 IEMs, we have definite management in terms of, say, enzyme therapy, substrate replacement, or dietary modifications, where we can definitely not 100%, but make a lot of difference in the clinical condition of the child. Again, increasing access to services and condition-specific support groups, and enabling counseling for specific risk of recurrence and reproductive options, because this is something what the couple is looking at. If they have a first child who has some issues, so addressing that issue is one thing that they're looking at. But more importantly, what if they're planning for a next issue? So that also needs to be addressed. Then again, in such cases, collaterally, there are issues of limitations which need to be discussed. So just to point out, we don't have any single genetic test as of now which will pick up all the abnormalities. It's mix and match based on what information we have at hand, what it is pointing at, what we are suspecting, and what tests we pick up. So the best case scenario where we try to solve this jigsaw puzzle is using minimum of test with maximum, which can target maximum differentials for that particular case which is at hand. Yeah, failure to identify definitive diagnosis. This happens at times. So clinical picture may be very clear, but the test turns negative. And that is a sad aspect, happens in almost, I'll say 25 to 30% of the cases, what we see in the clinics. But that is not the end of it. We need to counsel, we need to understand what are the parameters or other confounding factors actually which are causing this result. That needs to be investigated, and same needs to be conveyed to the parents. Then genetic diagnosis associated with limited or no prognostic information. So this is like when we say that we have done a test, but information on this in front is not available, because parents in the end, they want to understand whatever the neurodevelopmental disorder is, to what level it is going to impact my child, what his future is going to be. And if we don't get any information on that particular front, so this is very devastating for the parents. So such scenarios should, like a possibility like this may exist, needs to be put across to the parents in pre-test counseling itself. So there is a remote possibility like this might happen. We have to be prepared. So if this information is given beforehand and later on such an issue arises, they know that this was conveyed and why it has happened. Now the thought procedure goes to the next level.
Dr. Anup,
Yes.
2 minutes to conclude.
Yeah, just 2 slides, I think. So possibility of VOUS needs to be discussed in detail. Negative emotional responses, unexpected diagnosis. Again, this is very important. If some diagnosis is picked up, then cascade screening of the relatives at risk. And again, concerns about just genetic discrimination and privacy of the data. Though awareness has started to increase, this need to be addressed and documented for all medical legal purposes. Then delivering genetic diagnosis in neurodevelopmental disorders. So I think most of us are already well versed with this. Most important thing which I would like to highlight is a proper documentation in maybe a soft version or a hard version. That is very important for all medical legal purposes. And also, most of the time it happens that a couple comes, the child had some issue, you did counseling, documentation was done, and they go on and they couple may not, they might misplace it, or they might lose it, or because of whatever has happened, they want to get over it and they just destroy it. And they come later, and at that time we don't know what was it. And for those particular cases, if documentation is done and it is preserved, it can be a boon in such scenarios. So just about the recent advances, as I mentioned, more than 80 neurodevelopmental delays associated with IEMs. So this is one area where from perspective of management, you can make a lot of difference. If you get the genetic diagnosis, risk of recurrence exactly can be put across, and you can help the couple with prenatal diagnosis in the next pregnancy. Then RAS-MAPK pathway inhibitors, mTOR inhibitors. So this group of drugs, there has been a repurposing in tuberous sclerosis, and results are really promising. So this is something that is coming up, and we should update ourselves in particular focus areas which we want to practice in. Then also this mTOR inhibitors have been shown beneficial in controlling seizures and improving neuropsychiatric symptoms. So benefit in terms of management. Again, functional studies, mouse model for Kabuki syndrome in postnatal treatment with histone deacetylase inhibitor. Now that's an imprinting disorder. This improved the neurogenesis and ameliorated functional deficits throughout the developmental stages of the mice. So something very promising. So in the end, as a genetic counselor, when we are faced with a child with neurodevelopmental delay, the focus of the parents is only on two things. What it is, we want to find out how the child is going to behave, how his future is going to be. And the third important aspect is, will it affect my other child as well if we plan for next pregnancy? So these issues need to be addressed with due care, proper awareness of the condition that is at hand. And of course, it's a teamwork. A medical geneticist or for a clinician or for a genetic counselor. Individually, it is very difficult to cover all the domains. And it's a fine tuning in all the specialties where we can put across a proper prompt and proper management protocol for such patients individually. I think, so these are the references that I've put across. I think I'll end my
Thank you,
speech.
Dr. Anup.
Yeah, thank you.
So you have very happy that you have added one more angle, and being a clinician working in a pediatric neurology, I could say one of the dimension already added to us, that is along with neurologists, physiotherapists, occupational speech, dietitian. Now one more angle of geneticist is coming. Thank you. Dr. Madhuri will now start with the panel discussion. So I'll request Dr. Arsha to start with adult neurology cases. I'll conclude with pediatric neurology cases.
Good evening, everybody. At the outset, I think I'll kick off this discussion with a question to Nisi. Nisi, are you online? Are you able to hear me?
Yeah, I can hear you.
Yeah.
Thank you.
Nisi, this is regarding your X-linked dystonia, which is confined to one part of Philippines. What is fascinating about this is there any history of consanguinity in these families? Or how is that this disease is almost region specific? Any theories which have come about?
Apologies, but I cannot understand clearly. Did you say, is there any signs of Alzheimer's in the family?
No.
Sorry.
No,
Pardon.
I was asking, is there history of consanguinity? See, here in India, we have the system of marriages within blood relations.
Consanguineous couples.
Yeah.
Based on my experience, yes, we've seen consanguineous couples in our clinic, and one family I catered is that they have females in the family. The reason for that is both sides of the families had histories of X-linked dystonia, Parkinsonism that reach out to both males and females on the next generation line. So definitely we in the Filipino community, consanguineous couples are also present, but not of a big ratio.
One question, Missy. this is a late adult onset. You can take it, right? Because most of the presentation is after 35, right? So
yes, it's an adult.
that means if there are number of brothers, so the eldest brother would present first. And the moment you diagnose or there are symptoms that are seen, the other brothers would, there is some kind of anticipation here that what if I also have got this? So how you actually deal with counseling the asymptomatic siblings of these affected individuals?
Thank you so much for that question. But yes, we've seen in a previous conference, I presented a lot of brothers in one family because Filipino community has a tendency to have multiple siblings here. So they sometimes reach 10 to 12, and most of them are males. But based on my experience, it's not always the eldest to have the symptoms first. Sometimes it's the middle male sibling or the youngest one who had it first. But definitely when one sibling is diagnosed with XDP and the other siblings comes into clinic and asks for their risk, of course you're giving them a 50% risk. When dealing with them, we give them a balanced perspective. When we give them, there's a 50% chance of having this condition, but there's also 50% chance not to have this decision. And it's really personal and dealing with the asymptomatic sibling. One challenge we have here is that we don't have pre-symptomatic testing, and it's not acceptable in the Philippines yet because we cannot do anything if the symptoms like at an early age, if the symptoms not yet if the patient is not still manifesting it. So we don't have pre-symptomatic testing available in the Philippines. So that's even more challenging, but we keep on attacking it on a personal level and how to prepare them just in case this happens to them as well.
Okay, so there is no pre-symptomatic testing. It's
yeah, unfortunately, but I believe there are other countries who is offering that, but they need to have a series of genetic counseling, and that's what we're working on also here in the Philippines. We're gearing towards researchers, the genetic counselors specifically working on how to deal with pre-symptomatic genetic testing for males and also for carrier testing for females, because we know reproductive decision is very important.
What about prenatal testing?
Prenatal testing is not also available. It's not included in the newborn testing, but still, we are still in the 4 years of an active research and clinic cases here in the Philippines, and we're really working on a lot of institutions and stakeholders to work on with that as well.
Okay, doctor, I asked about the prenatal. Okay. So you cannot prevent it. Yes, sir. Yes, yes.
Before going for that, we'll introduce Yo-Yo had just joined us.
I think she joined from Hong Kong.
Yes.
Yo-Yo Chu. I think she will also be one of the panelists, and she will also participate in this.
Miss Yo-Yo is joining us from Hong Kong. Yes, Dr. Prakash. So she's a genetic counselor. She's from Lee Ka-shing Faculty of Medicine, University of Hong Kong, and previously associated with Prenetics and Compass Genetics and Department of Pediatric and Adolescent Medicine from Hong Kong. And she was also with the Royal Children's Hospital at Melbourne. She's done her Bachelor of Arts and Science with the University of Melbourne and Master of Genetic Counseling at the University of Melbourne. Her interests are in clinical genetics in a public health area and genetic counseling education in the health profession. Ms. Yo-Yo, you're welcome to the panel discussion. Very happy to have you here.
Thank you for having me. Thanks.
Thank you. Yeah.
Right. So, Jennifer, you are there, right? Yeah, I think you have unmute. Yeah. So, in your one of the slides, you have indicated in the Frederick ataxia, genetic basis is less or below 40%. Can you throw more light on that?
Yeah, so there is evidence through haplotype analysis of a founder effect for the triplet repeat expansion. And, the the carrier frequency of Friedreich's ataxia is about 1 in 100 in most Caucasian individuals and throughout Southern Europe, but we actually see a much lower prevalence, for example, in Northern Europe, like in Scandinavian countries. In the US, the carrier frequency is about 1 in 100 in Caucasian individuals, but it's not been really well studied, the prevalence outside of Europe and the US. And so there's, I think, a lot more work we need to do to understand the true prevalence of the disease and the carrier frequency in other populations. For example, several years ago, we were able to work with an advocacy group in Brazil, and they've been able to identify more than 700 individuals with genetically confirmed FA in Brazil, and it was really previously unrecognized, what the actual prevalence was in the country, and it's still an evolving story. So I think there's a lot of work that we need to continue to do to really understand the true prevalence globally of the disease. But the founder mutation does go back to sort of an area of southeastern Europe. And so pretty much, everywhere the Roman Empire spread is where we see higher frequencies of Friedreich ataxia. There are very few cases that have been reported throughout parts of Asia like China and Japan. And it's very low frequency as well throughout sub-Saharan African countries.
Any statistics about the Indian subcontinent?
We don't have any good statistics. I know through work that I've been doing recently with AIMS in New Delhi that they've got about 250 individuals that they've been able to confirm genetic diagnosis in. And I know there's another clinic in the south of India, in Bangalore, where there's also been an effort to, diagnose, screen and diagnose more individuals with FA, but we don't have a good understanding of the true prevalence.
I'm just continuing the conversation. You put up a slide regarding the incidence of various modality, various types of ataxia in different parts of the globe. Whatever basic things we have. In resource poor countries, would you just say that you would just do a targeted testing or screening for these diseases or for these abnormalities?
So the slide that I showed with the sort of the geographic different types of, those were all spinocerebellar ataxias that did not include Friedreich's ataxia or some of the other recessive ataxias like AOA2 and 1 or ataxia telangiectasia. So, in some cases, yes, I think you can be more selective in targeting for single genes. But, I think it's challenging. It depends on the clinical presentation really of the patient, in addition to what their geography or ethnic background might be.
I'd like to add something to this. We have worked a lot on the neurodegenerative spinocerebellar ataxias. And because there's no registry, most of the work has come out in publications. And Friedreich's ataxia is more in South because of the consanguinity, being an autosomal recessive one. The other parts have, then the next common is SCA3 and 1 in India. 6 and 12 are mostly in the east of India, that is Calcutta and all. But for them, we do not recommend any NGS-based testing. We recommend panels. Panels, if in the pedigree there is a consanguinity, FA is the first line of testing, followed by SCA1, 1, 2, and 3. Then we go to the next 6, 7, and 12. So that's how we do the diagnostic.
this question to Dr. Sumashan and Dr. Anup. Being a pediatric neurologist, we come across the scenario where you have the insurance covers this test. But in India, it's very difficult. When you come across a child with either autism or single test, like a child is having ataxia, we don't know whether we to go for which type of test we should go for. We got clear-cut understanding, but for Indian scenario, what do you suggest?
So to start with, like once we have the patient, it all starts with the clinical history, family history. And throughout the journey, we look at certain clues if it is going towards any particular syndrome. So the rule of thumb is if there is dysmorphism, gestalt that we look at, if it is pointing towards certain microdeletion syndrome. So then in those cases, we look for targeted testing like say Williams, velocardiofacial, if other congenital anomalies are falling in place and it is pointing towards a genetic syndrome, we go after that targeted testing. That is the approach. Otherwise, the guidelines say neurodevelopmental disorders, cytogenetic microarray is the first line of test. And I think in Indian scenario, the costs have come down significantly over the years. So that is one test, first line test that we look at. And if that doesn't give the answer, then definitely then next generation based sequencing test, maybe a whole exome that usually we do for the patients.
In clinician, but
Yes.
difficulty is that
So
we don't know which microarray we need to do.
MSPCR typically comes in if you have a clinical phenotype which is pointing towards say Prader-Willi or Angelman's. So then we will do it. Yes. So if we have a happy gestalt female who is affected, only those, or for that matter, there is a neuroregression after a certain point of development, and then there is a microcephaly, we look for Rett. So all the neurologists, clinically, we look at what clinical diagnosis it is, and based on that, we'll go for individual testing. So whether it is Fragile X, where based on family history, clinical picture in the relatives, male relatives, female relatives, history of premature ovarian failure, infertilities per se. So we'll go for Fragile X testing first. So based on what is the clinical picture, we'll try to identify the disorder, because each disorder has a unique underlying genetic abnormality and techniques may be different because these abnormalities may be different. So accordingly, we do the test.
What's your comment, Dr. Sumashankar?
Yeah.
I agree with what has been said completely. The American College of Medical Genetics had guidelines published that initially recommended chromosomal microarray analysis and Fragile X testing for any child who presents with neurodevelopmental delays. So that chromosome microarray as a first step maybe, is a good first approach unless you find evidence to do other testing. I agree.
Just to add on one more aspect to this, Dr. Suma, what she rightly said, the yield wise, there's a lot of difference, like cohort of neurodevelopmental delay, you do karyotype, the yield is roughly 5 to 8%. You do a microarray, the yield is 25 to 28, 30%. And you do a whole exome, the yield may be somewhere between 40 to 50%. So it varies. And again, the newer bioinformatics analysis pipeline that are coming up with next generation sequencing, they are also able to pick up these CNVs with better confidence than before. So, but again, NGS is not the gold standard to look at copy number variations. I just want to point out, if any such is suspected on bioinformatics analysis, needs to be confirmed by alternative techniques. Yeah, thank you.
True. So finally, what's your recommendation? Is it a microarray?
So the recommendations is for chromosomal microarray.
So
that will be the
first year test. Yeah, first year test. Yes.
So clinician and geneticists should work together on the. So bullet point is that.
Yeah. Ms. Yo-Yo, so how is it that you follow the guidelines similarly, like when there is a intellectual delay, you go ahead with microarray first and then for sequencing?
Yes, that's correct. In the pediatric practice, we also follow the American College of the Medical Genetics and Genomics guideline. Yeah, so If they cannot identify the syndromic features, then first line of testing would be the chromosomal microarray. And sometimes I see the pediatricians or the clinical geneticists will add on the Fragile X testing. Yeah.
So at this point, I want to ask all of, because we have 2 counselors and then doctors. So in cases where we are not able to, or the clinician is not able to give a counselor a proper diagnosis, you're just giving us the symptoms that are being presented. So we have done a microarray, it's a normal result. Should we go for a panel testing, and or should we directly go for a whole exome rather than go for a clinical focused? Because we are all from different countries. At least in my country, we do not have the patient pays from his or her own pocket. So there's no insurance. And I saw one example where Dr. Suma also said that they were denied insurance, maybe because they've been doing lots of, I don't know what was the reason. But then when there is no proper diagnosis, when we are not able to say, maybe because of many reasons, it could be an evolving phenotype, just like again what Dr. Suma showed us. Maybe at the time when the patient came to the clinician, there are few symptoms shown. So what is your take on this? Should we go for smaller panels, keep on doing the tests, or look for major of these 2 major variations, chromosomal and single nucleotide variations? Dr. Suma, yeah, we can start with you.
Yeah, no, thank you. Thank you for that very interesting question. Something that we struggle with every day as we see our patients. It really depends on, again, part of it is driven by insurance. So if they do, I think more and more we are doing exome analysis rather than going for next generation sequencing panels. Part of the reason is if the coverage for the genes on the exome is getting better, then our reasoning is if we do not identify a definitive cause, then we have already done an exome and they're in this pool of data where if there are new gene identifications, then that data is there where we may receive updates as to, okay, we found something new. Would you be interested? Because there are programs like Gene Matcher where if they do identify a variant of uncertain significance in a gene of unknown significance, then there are certain labs that will give those test results as possible causes, and then we have the opportunity to go further. So we do, I think we are more inclined to do exome analysis. Now, depending on the cost of the genome, and if it is going to come down rapidly, yes, we may be approaching the era of, okay, genome them all or genome everybody, because then you'll be getting both your chromosomal microarray analysis as well as the exome together. And that would depend on the cost, absolutely. And then it also requires a lot of counseling. And it is also opening a can of worms, because like you are looking into things that the family is not coming for. So it's that adage of be careful what you ask for. But again, these are things that we discuss individually with each family and then often take into consideration in a what we hope to be a non-directive manner as to what the family's preferences are. And I would say that for the vast majority of the families that we see, in instances where there is profound neurodevelopmental delays or profound neurological implications, I think at that point the families are like, oh yeah, we just want to know what it is, and they would like to know what it is. So when I had the option of doing whole genome sequencing, I didn't choose ophthalmological conditions, but chose neurodevelopmental delays, though that wasn't my original expertise. Because for an individual with an eye disorder, maybe they didn't care to know what their other genetic abnormalities are. So I would say it depends on each individual family, and discuss with your families as to what their preferences are too.
Dr. Prashant,
Yes.
I would like to ask you, because you're a pediatric neurologist, and then you would also be coming across, because they're young and the parents are like, maybe they're still in their reproductive age and they want to ask you. So, and in our scenario, like just like what Dr. Suma said, our companies here do not give so many of these incidental findings. Right now, not all of them, even if you go for a genome sequencing, there are few, but not many. So in that cases, do you prefer again going for do you offer the test as whole
See,
exome
what
or?
we do, because I'm working with GC, our Nadiraman, our GC is with us. Purely, I'm sharing the view of rural India where I go to the district of Latur. There we filter. If it clear-cut indication according to the thumb rule, it is divided.
Okay.
But when it is bias, mild dysmorphism or confused, it is autism, and what to send. We try to counsel the parents for whole exome sequencing along with chromosomal micro, because in India, they comes to doctor once, they spend significant amount of money on tests, they don't want to do it. So we prefer sending both in a tact way that, okay, this is the last test, what we are offering.
At this point, I would like to say to all the genetic counselors that whenever you are sent for counseling from a referring clinician, I would also, after counseling, I would refer them back to the primary clinician because he would have done an extensive evaluation and a workup. So if something comes, you've got more details, call the doctor, get the details, tell him or her that I have found these additional ones. Maybe as you're counseling, you would have get more details. So ask them to go back to the referring clinician because they would know that why this was done and what is the next step and how it should be done. So
one request to BGCI committee, when they pass the see counselor, they should interact with the clinician. It's little bit lacking because I have come across, it is not criticism, but Down syndrome clear-cut baby has been advised whole exome sequencing and chromosomal microarray. It's not their fault. They have passed it. Theoretically, they know it, but they have to go to a compulsory to the clinician to see the cases.
There is one question to Jennifer. So in one of your slides, you have written that 40, there are around 40 disorders, but only with a few which are phenotypically distinct. So that means in this particular set of disorders, there is, or in most of them, I don't know, there is a chance of misdiagnosis, right? So
Yes.
So how would you, as counselors, how we can approach this?
Yeah, many of the patients, by the time they get a diagnosis that I've met, have been on a diagnostic journey. The average is, 4+ years, especially for adult onset hereditary ataxias. And, I think that for many of these individuals, the testing is not always conclusive because many of these diseases have the trinucleotide repeats. And so many individuals get sent for whole exome sequencing. They don't come back with a disease causing mutation, and that it was a matter of the incorrect test was ordered. That they what they really needed was a hereditary ataxia panel. So it is still challenging, I think, for families to get diagnosis. And I think that's why it's important that they hopefully get referred to neurologists who can do a really careful exam and help us to, guide us towards the right testing, whether that's an individual gene or a panel. But that's, the clinician and the counselor really need to work closely together to prioritize the testing and to try and reduce that diagnostic odyssey for patients. And as you were mentioning, the out-of-pocket expenses, that people incur are quite significant. Just even, the travel back and forth to the center, how many times they have to go. Many individuals will see anywhere from 4 to 6 specialists before they get a diagnosis. So it can be quite challenging and quite frustrating for many of the families that I've met and I've counseled with these inherited ataxia disorders.
Just to add, like I had a similar experience since this point came up. A father and son both clinically hereditary ataxia. Father around 40-45 years and child was around Son was around 18, 20 years, and son had just started to manifest since 2, 3 years. Spinocerebellar ataxia panel done from 2 different labs for father and son, negative. Then with the consultation with neurologist, we went ahead with whole exome sequencing for the son. It came out to be negative. Then we again got the data, tried to look into, is there anything that we are missing? Is it Fragile X? Is it some monogenic condition which is there? And typically there was history of consanguinity that was there. So we are more focused on autosomal recessive conditions. Surprisingly, now there is one ataxia disorder, DRPLA, which manifests similar like spinocerebellar ataxias. Once that, and again, that is also repeat disorder. Once that test was done, that came positive for both. So here we have done entire panel for SCA, which was negative. We did whole exome for the son, which was negative, and it was indeed one disorder which was not picked up, particularly because SCA panel doesn't cover it up, and NGS platform is not the test to look for that. So until and unless the clinical suspicion is strong, you will not, like, it's definitely mix and match or a trial and error that we go about it. Yeah.
Thank you, Dr. Anu. There is one question to Dr. Suma. Gene therapy for LX2006 for FRDA will be used for only exonic specific variations, and which exons will be considered initially?
I think the Friedreich's ataxia. Did you say for Friedreich's ataxia? Yeah. Janu, do you want to take that?
Yeah, so the question was about gene therapy or gene editing? I'm sorry.
Gene therapy for of LX2006.
The Lexi. Yeah, so that is so that therapy is an IV administered gene replacement approach to treat the cardiomyopathy associated with FA. It is an AAV RH10 viral capsid that is, delivering the frataxin gene. And so it should deliver the gene to the heart, to skeletal muscle, and to the dorsal root ganglia, which are also part of the one of the target tissues in Friedreich's ataxia. The first study is planned to begin later this year. In the next month or two, they'll enroll individuals who have evidence of hypertrophic cardiomyopathy with some progression of the cardiomyopathy, but not individuals who are kind of too late in their disease where they've already have significant symptoms of heart failure. So what the goal would be to show that the gene therapy, once delivered to the heart, improves the hypertrophy and reduces the risk for development of heart failure in FA. And we'll look to see if they're also looking to see if there's any evidence of, neurologic improvement or other systemic type improvements in terms of glucose metabolism, because the gene, will travel to other tissues beyond just the heart.
Okay. Thank you. This is a question for genetic counselor. I think I'll ask Yo-Yo for this. We know for neurofibromatosis and ataxia-telangiectasia, there is a chance for the heterozygotes to have or a risk for malignancies. So the parents have actually come for the child. You're doing a pediatric counseling there. But then the moment, when the doctor actually tells us that, yes, counselor, I'm suspecting AT here, or this is NF, and you know that if the results come positive, you also have to approach the parents for ataxia, that there is a risk for malignancies also. So how do you actually, include from the pediatrics go to the adult? It goes to a completely cancer genetic counseling.
Yeah, that is often a very challenging part for genetic counseling, especially if something associated with the potential of the malignancy. So when I break down the news about the positive genetic results, for example, NF1, we say that what are the features that we have already observed in your child which match with the the clinical presentation. And then slowly, I would just say there's a chance of malignancy. However, this is why it is very important to work with like pediatricians to have like the regular medical follow-ups as well as a screening. And of course, we have to, have like a very close working relationship between parents and pediatricians to ensure that we are monitoring your child's health beings for a regular period of time. So make sure that he or she wouldn't miss the medical appointment. And if something that they have observed is like, for example, some symptoms that is unusual for for example, NF1, then they should seek them immediately.